Caribbean Gynecologic Cancer Society meeting in lovely Barbados. I know it required a lot of arm twisting to get you guys to come to this lovely paradise. And I hope apart from enjoying these academic presentations, we have a lot more time too for camaraderie and seeing some of Barbados while you are here. To be formal, distinguished guests, colleagues, esteemed speakers, honored guests, sponsors, and friends, good morning. It is with great pride and heartfelt enthusiasm that I welcome you all to the Caribbean Gynecologic Cancer Society Annual Scientific Meeting 2026, here in the beautiful island of Barbados. On behalf of the CGCS, I extend our deepest gratitude to each of you for joining us. Your presence reflects a shared commitment to advancing gynecological oncology across the Caribbean and beyond. This gathering represents not only a conference, but a collective movement, one rooted in collaboration, innovation, and the pursuit of excellence in patient care. Over the course of the next 2 days, we are privileged to engage with a distinguished faculty of regional and international experts who will share cutting-edge research, clinical advancements, and practical insight. Together, we will explore evolving approaches to prevention, early detection, treatment, and ensuring that our patients benefit from the highest standard of care. As we exchange knowledge and experiences, let us also strengthen the professional bonds that unite us as a medical community. It is through these connections we have persons here from Great Britain, Ireland, North America, as close as Miami, Chicago. We have from the region, Bahamas, Trinidad, Jamaica, Barbados, St. Vincent and the Grenadines. The society started in 2019, and in that 7 years, we've made leaps and bounds where we have now started training fellows in gynae oncology at the University of the West Indies under the auspices of the International Gynecological Cancer Society. So not only is it a society for us to meet, but we're deeply involved in training. We have set guidelines for the region through the World Health Organization regional body, PAHO, and we're trying to make a difference when it comes to the care for women with cancers. We're exceptionally grateful also to our sponsors and partners whose generous support has made this conference possible. The commitment to healthcare advancement is both valued and impactful. So while we are here to learn and collaborate, I encourage you to also embrace the warmth and culture of Barbados, which may include a little bit of rum, may include a little bit of sunshine, a little bit of sea, but the hospitality here is rich. It has good heritage. Country has a vibrant spirit, and I'm sure you all who are visiting will enjoy. May this experience be both professionally enriching and personally memorable. In closing, I thank you once again for your participation and dedication. I wish you a productive, insightful, and enjoyable conference, and I guarantee we're on time. So welcome. Thank you. So now it gives me great pleasure introducing our president of the Caribbean Gynecological Cancer Society. He earned his MBBS his MBBS degree from the University of the West Indies in Mona. He's Bahamian in origin, and he received the Bahamas Supermarket Scholarship and became a fellow of the Royal College of Obstetricians and Gynecologists in the UK in 1990, 36 years ago. He previously served as head of department at the Rand Memorial Hospital in Freeport, Bahamas, where he developed a strong interest in addressing the limited oncology services in Bahamas. He was awarded a Commonwealth Scholarship. He pursued research at the University of Southampton, focusing on molecular genetics and gynecological cancers. He co-authored several publications, including work on loss of heterozygosity in cervical cancer, and earned his MD for this research. He has continued in research locally, including studies on HPV serotypes in HIV patients in the Bahamas. He completed a fellowship in gynae-oncology at the University of Toronto in 1999, and then since returning home, he has served as chairman of the obstetrics and gynecology and has been a consultant gynecological oncologist at Princess Margaret Hospital. He's actively involved in regional and international cancer initiatives, including cervical cancer prevention efforts, PAHO working groups, and leadership roles within the Caribbean and global gynecological oncology organizations. He has extensive research. Not only is our president of the society, he's a lecturer at the University of the West Indies. I see him twice a year at university exams. He has been a mentor to all of us in the society. He is our regional godfather for gynae-oncology. It gives me great warmth in welcoming Dr. Raleigh Butler to the podium to give the welcome remarks.
Thank you for those kind words, Vikesh. Distinguished colleagues, honored guests, invited speakers, sponsors, trainees, and friends, ladies and gentlemen, I too would like to welcome you to the 2026 CME Scientific Conference of the Caribbean Gynecologic Cancer Society, and again, welcome to Barbados. It is my privilege, and I use the word deliberately, to stand before you and your outgoing president and reflect with gratitude and honesty where we have been and where we must go. Throughout my tenure as your president, my mantra has been one of Sir Isaac Newton's statements made in 1675. If I had seen further, it is by standing on the shoulders of giants. Newton wrote those words in triumph, but not in humility. He knew that even the most brilliant breakthroughs depend on patience, discipline, foundational work, and those who came before. Modern breakthroughs are possible because of our predecessors. Newton's insight of humility, gratitude, acceptance of a collective nature of progress is the lens through which I will reflect the journey of this society, and the lens through which you must imagine its future. I begin by naming giants through which the Gynecologic Cancer Society has accomplished much, and on whose shoulders I stand. By celebrating what we have built together and laying our scoreboard on the table to advance this society with confidence and urgency. Let me take you back to 2014, when a group of senior gynecologic surgeons and oncologists from the UWI campus in Jamaica, Trinidad, Barbados, and Bahamas sat together with a shared and burning conviction that women in our region with gynecologic cancers deserve better access, better standards, better coordinated care. That conviction led to a formal position paper written by Professor Denny DiPetrillo of Toronto Professor Michael Funky Fung of Ottawa. It was presented to our 4 UWI deans, who led by our distinguished Professor Horace Fletcher from Mona. That document and that convictions of the people behind it gave birth to this society. Professor DiPetrillo, I must begin with my mentor, our architect. Professor DiPetrillo, you trained me. I focus not on his titles or his institutions, but with the personal and direct fact that your outgoing president was shaped, guided, and challenged by this man. He also trained Dr. Tim Goopersing from Trinidad, and beyond the two of us, he opened the doors of Toronto, Ottawa, Calgary to successive Caribbean physicians who needed a path into formal gynecologic oncology training and had nowhere else to turn. These opportunities did not exist in our islands, and DiPetrillo made them exist. He telephoned, he wrote letters, he vouched for us, he arranged placements, and built the bridges that we have since learned to walk across ourselves. He didn't stop there. When a Caribbean island was without a gynecologic oncologist, was temporarily uncovered, and his women left without specialist care, Professor DiPetrillo arranged coverage. He understood that the gap between a fellowship graduating and a service being established could cost lives, and he acted accordingly. This is not the work of a distant mentor. This is the work of a physician who cared personally for the health of our Caribbean women. Professor DiPetrillo has served in many academic and clinical leadership roles. McMaster, Toronto, Princess Margaret in Toronto, and Cancer Care Ontario, as well as many national surgical and gynecologic oncology organizations across Canada. He is a figure of genuine international stature. And yet, all of that, he kept the faith with this region, with these islands, and with the vision that Caribbean women deserve subspecialty care delivered by trained Caribbean physicians. With profound pride and deep personal gratitude, we will announce a presentation at the end of this discussion. Next came Professor Fletcher of UWI Mona. He was our first honorary president, and he gave the society in its early credibility and directions. Guess where that occurred? Right here in Barbados. Next came Dr. Carol Rattray of UWI Mona. A fellow pioneer, she assumed the presidency of the society in its earliest years and built it during a formative and critical chapter. Her leadership of the professional fellowship training program, weaving through fellowship programs in UWI, in Belfast, and in Dublin, and other international gynecologic cancer societies. She was nothing short of a visionary. She planted the seed that has now grown into a functional regional training pipeline for our fellows. What can I say about our conference chairman, Vikash. Dr. Vikash hosted the first meeting here in Barbados. He has been the heartbeat of the organization in Barbados, and he is the architect of this beautiful meeting and gathering here today. I thank you without reservations, my brother. His mentor and friend, Dr. Carlos Chase, who is the director of the medical services of Queen Elizabeth Hospital in Barbados, also joins us today. I was proud when I met Carlos as I traveled many times here for exams to see how he mentored and, of course, developed the specialist care that Dr. Vikesh was able to develop at the Queen Elizabeth Hospital in Barbados. I am a clinician. I believe in evidence. So let us examine what your society has achieved. I am putting the scoreboard on the table, not boasting, but as an honest account of what has been built since its founding, the milestones by milestones, and I invite you to examine it with me. Since the establishment of the Society in 2014, we have held annual conferences across the region, from South Florida in the north to Trinidad in the south, with stops in the Bahamas, Jamaica, and Barbados. We have established fellowship programs in gynecologic oncology, with our fellows matriculating in global centers of excellence from Ireland in the east, Canada in the west, Florida, and the Caribbean islands in the south. We have conducted workshops advancing screening protocols with PAHO right here in Barbados and introduced HPV vaccine programs underscored with universal access throughout the Caribbean healthcare systems. Over the next 10 years, we have set the compass to eliminate cervical cancer in the Caribbean to meet the human resource needs of the region and to make regional research and data coordination the foundation of our gynecologic oncology agenda. We as a society kept all of these promises from a position paper 12 years ago in Kingston to today with a 2-day international CME conference at the beautiful Hilton in Barbados. We have speakers today, Fairfield of Chicago, Princess Margaret Hospital in Toronto, University of Miami, Queen Elizabeth Hospital locally, our Royal College of O&G in London, and across the Caribbean. This is not a small thing. Our society is not a stagnant being. It is a movement. How did we build this pipeline? Of everything we have done, I am most proud of the fellowship training pipeline. Let me trace it for you because it tells the story of a society that refused to accept the status quo. It began in Jamaica in 2017. My good colleague and friend, Dr. Demers Batiste is here, and Medley Singh became our first Caribbean fellows in gynecologic oncology, trained at UWI in Mona in collaboration with fellowships programs in Belfast and Dublin, Ireland. That partnership, Caribbean institutions working across the Atlantic with Ireland, proved something very important. Our region could build internationally validated training programs without simply exporting our physicians and hoping they will return. In March 2019, we brought the society home to the Bahamas. We were stronger together in that meeting and simultaneously extended the fellowship program to Bahamas, with Dr. Rangel from Guyana joining the training network. That same year, Dr. Batis rotated to Nassau with us for 3 months. Think about what that represented. It was a Caribbean physician trained in Jamaica, rotating within the Caribbean to Nassau. The network was functioning. This pipeline was real. And then in summer 2019 came the agreement that I regard as the society's most consequential achievement, the formal tripartite agreement between UWI School of Clinical Medicine and Research in our campus, the University of Miami, and the International Gynecologic Cancer Society. Under that framework, my colleague Dr. Bo was enrolled and has finished and is now a budding, growing consultant gynecologic oncologist in our region. The Caribbean faces Caribbean training slots. This is how a sustainable specialty has to be built. The incoming leadership cannot wonder whether the pipeline exists. The question is, how will it expand with more sites, more fellows? This will result in shorter waiting times in the Caribbean for our women who need gynecologic oncologists, and hopefully stand the time of our people going to Miami and to London. Cervical cancer elimination. This is unfinished business. The Caribbean, including the West Indies, ranks globally seventh. This should make every person in the room very uncomfortable. We are one of the world's most beautiful conference venues in one of our region's most prosperous countries, discussing cancer. This is almost entirely preventable, and we are ranked 7 in the world. This is a contradiction. We live it, and this is unacceptable. During my tenure, we advocated actively for strengthening HPV availability across the Caribbean states. We sat at PAHO tables arguing for access to HPV vaccines and immunotherapies in various Caribbean settings. We held colposcopy skills workshop with our colleagues at our Miami conference because cervical cancer requires trained hands, not just policies. And on day 2, I am proud to announce that Dr. Anna K. Taylor Christmas will address us on the turning epidemiological insight into a concrete cervical cancer eliminating strategy. That session matters, and I ask everyone in the room, please attend. Now let me speak to the 2 days ahead of us. On day 1, we will focus on fertility issues in gynecologic oncology, advancing surgical techniques in endometrial and ovarian cancers, and a multidisciplinary issues that arise in our subject. Day 2, we will highlight issues directly related to those of our countries with limited resources and the scourge of non-communicable diseases. This is not a provincial program. There are world-class topics addressed by regional and international experts delivered in our wonderful Caribbean setting. This is precisely what the founders envisioned in 2014. I want everyone in this room to know that your presence here is an investment in the women of the Caribbean, for which we are grateful. I am also deeply satisfied that CME credits will be awarded. The future directions you must think about. Newton's full insight was not just about the past, it was about what becomes possible when we build correctly. When we are willing to stand on the work of others and reach further, the compass has been set to expand the fellowship. More Caribbean oncologists for our Caribbean women. Build a regional research agenda. Sustain advocacy at every table. Ensure equity in access from our capitals to community. We have invested in the next generation deliberately. To every member of the Caribbean Gynae Cancer Society across the Bahamas, Jamaica, Trinidad, Barbados, and our diaspora, for your encouragement, your fellowship, and your sustained commitment to the society mission across difficult years and celebratory ones unnoticed. To our sponsors, speakers, partners, organizing team, you made this conference meaningful. And to the women of the Caribbean who face gynecologic cancers that we see every day, you are the reason for all of this. The society exists because of you and for you, and it will not stop until every woman in our region has access to a timely diagnosis, expert treatment, and compassionate care. As I close, I was entrusted with it by the giants who came before me. I want everyone in the room to appreciate that this was not possible if it was not for the time my dear wife, who sits in the room, entrusted me to travel, miss many nights, to be up and down the Caribbean, carrying your torch for your society to make it a better place. I would like to invite Dr. Vikesh and Dr. Chase, because I think it is an honor for me, before I leave as your president, to donate and give on behalf of our society our medal and a small token to you, Professor Dupatrillo, for believing in us, believing in me, and making this all come to fruition. And you deserve every credit and everything that we have achieved in this society. Would you two men join us? Huh? Okay. You want us over here? Oh, you want it? Darren? Yeah, you put it. Oh, silent stallion. We wanted to get 10 Cooper things to enter.
He can hear us, Darren. He can unmute. Can you unmute, Tim? You're on mute. We can't hear you, Tim. So just unmute the mic there.
If you can't hear Tim, Tim Cooper Singh is a very interesting character. He was a senior gynecologist, did gynae-oncology, and worked at Mount Hope in Trinidad for many, many years. He has since left our ranks and has moved sideways into politics. He is an astute politician, well respected in Trinidad, and the society has been blessed to have an individual with his credentials. Hopefully he can move the society upward into political sphere, especially CARICOM, where we will have a seat at that table where we can batter for the care of women with gynecologic cancers in the Caribbean. And we hope to make him an honorary vice president, one who will not have a portfolio, but one who has served the society well. And he has always been my big brother in the back room. Thank you, Tim.
Yes, thank you. I'll see the video. Good morning, the distinguished participants, and of course to the chairman and the secretary of this morning's conference. My humblest apologies for being unable to be with you this morning. The political life has become part of me. Well, thank you very much, Raleigh, for giving me the opportunity to say special words of congratulations to my distinguished mentor, friend, colleague, and confidant on many occasions, on the award by the Gynecologic Society of the Caribbean for his tremendous work and contribution towards women's health care in the Caribbean. Colleagues, I joined Dr. Pitolo in 1988, being his first trainee from the Caribbean. I spent about 9 months with it in Canada, around the 5 hospitals. And from since then, when I came back to that, then he has been an integral part of trying to show that gynecologic oncology became a part of the training and the teaching and caring for patients with gynecologic oncology. Raleigh, our president, and my distinguished colleagues from the Caribbean and internationally, from Belfast, from Canada, United States, and the Royal College of OLP. I feel very privileged and honored to express my sincere congratulations to Professor Di Petrillo on the award by the Caribbean Gynecologic Cancer Society on a very well-deserved honor. Sincere congratulations, Denny, and thank you for all that you do for our Caribbean people. And thank you to our Gynecologic Cancer Society for all the tremendous work you continue to do. You have success in their deliberation for the next 2 days. Thank you for the honor.
Thank you, Tim. Great pleasure to have you here virtually. Thank you. All right, take care. So Tim Gopi Singh, apart from being an obstetrician gynecologist, is also a former Minister of Health in Trinidad. And obviously, hands are very busy. His government's in power. So he has a lot of things on his plate. So we thank him for making the effort today. Thank you, Prof. Di Petrillo, for accepting that presidential award from Raleigh. And thank you, Raleigh, for such a great tribute to the society as well as to Prof. He is really and truly the godfather of gynae oncology. The next person to welcome you is Dr. Carlos Chase, a highly experienced and respected consultant obstetrician and gynecologist. He's been doing this for over 30 years, 3 decades. He actually examined me as a medical student back in 2002. Not meant to reveal his age, but really his wisdom in the field of practice of obstetrics and gynecology. He's a fully registered practitioner. He's qualified. He took up a new hat recently as the Director of Medical Services at the Queen Elizabeth Hospital. Knowing him for all my professional career, it gives me great honor in welcoming Dr. Carlos Chase to the podium to give his remarks on behalf of us at QEH and at the Ministry of Health until the Minister can make it later and give her own remarks. Thank you, Dr. Chase.
Dr. Vikash Chatrani, Chairman of the Caribbean Gynecological Cancer Society, Dr. Raleigh Butler, President of the CGCS, Professor Danny Di Petrillo, the grandfather of gynecology, members of the Gynecology Club of Great Britain and Ireland, distinguished colleagues locally, regionally, internationally, specially invited guests, members of the media, ladies and gentlemen, good morning. First, I cannot speak on behalf of the Ministry of Health. So I will speak on behalf of the Queen Elizabeth Hospital in certain regards. So thank you, Dr. Chatrani, for this invitation. I'm very honored to be invited here. Gynecological cancer at the hospital has taken a new turn with the implementation of our linear accelerator recently commissioned. And with that, we've seen an increase in the numbers of patients being referred to the hospital, both from within the island and outside the island. And there's plans to have actually a big cancer institute built on the old MR site across the road, a multi-level facility, a new cancer diagnostic and therapeutic suite with a connecting bridge across the road, which will house the latest in technology as far as MRI, PET scan, and laboratory services. So there'll be a big expansion of cancer services at the hospital, and we will need partnerships with societies such as the Gynecological Cancer Society, regional, international, help to expand our facilities, expand our services, expand our staffing, and to train up the next generation of gynecological oncologists, especially as well as other specialists as well. Going forward, I look forward to the continued collaboration between the Community Hospital and the Gynecologic Cancer Society to improve our care of our women and to improve the health of our people around the world. I hope that with our joint venture, we make Community Hospital a beacon of excellence for regional and international cancer, and we can put the hospital back on the map as far as excellence. Thank you.
Thank you, Dr. Chase. Big things for QEH in Barbados, and thank you for that warm welcome. Now, before I get to the next speaker, a little housekeeping. We often leave out things that are small, but does not mean that they're not important. Dr. Sherry Tulloch, I forgot to mention your presence here from Antigua. I mentioned all the other Caribbean islands, and I think it's very important to mention her because she's one of the upcoming gynecologists in the region and has done great work in preventative medicine in terms of introducing HPV screening and AI in colposcopy in Antigua. We had the fortune of going to a workshop in March 2025 under the patronage of the Governor General. Her great work, she's a scholar. Dr. Jagray can see her interests. I'm going to invite you to meet her and speak to her, especially from the Barbados Cancer Society perspective, what we can do to incorporate new technologies that is out there to us in terms of artificial intelligence and how that can help with screening for cervical cancer. So I didn't leave out Antigua. It may have slipped my tongue, but I acknowledge and recognize your presence here, and we're grateful that you are here. Our next speaker, Dr. Juliet Skinner, was born in Barbados. So don't let the accent fool you, depending. Since she has a lot of her colleagues here from Ireland, you might hear that come out. But she has completed her undergraduate medical training at the Trinity College in Dublin, Ireland, following which she completed specialty training in obstetrics and gynecology, and then went on and did her membership with the Royal College of Obstetricians and Gynecologists. She's a member of the Royal College of Physicians in Ireland. She returned to Barbados in 1999 and dedicated her time to expanding the medical care options for women on the island and within the Caribbean, and I'm going to add internationally with regards to fertility care and IVF. This became her main focus of interest, and she was instrumental in opening one of the island's first and only in vitro fertilization unit in 2002. The center was established to treat local, regional, and international patients, with almost 90% of patients being non-resident. The Barbados Fertility Center is the region's only JCI-accredited IVF unit and joins a handful of medical facilities with JCI accreditation in the CARICOM region. The Fertility Center in Barbados opened a satellite unit in Trinidad in 2009 and opened a second IVF facility in Cayman in 2019. Dr. Skinner remains the medical director of the Barbados Fertility Center and will continue on the board of management and advisor to the Cayman Fertility Center. In 2021, Dr. Skinner received national recognition and was awarded the Order of the Republic as part of the Independence Honors of Barbados, all in recognition of her contribution in the medical field in Barbados and globally. She has made Barbados a destination for medical tourism when it comes to fertility care. She has been instrumental in my first sister's firstborn, my firstborn. It gives me great pleasure to welcome Dr. Juliet Skinner to the podium. Thank you, Juliet. Okay, wait.
Good morning. Yeah, thanks. So, thank you, Vikash. And I was asked to speak this morning on fertility cryopreservation options for female patients diagnosed with cancer. just hit next slide. Will that go? Yep. I think it's fair to say that when a patient receives a diagnosis of cancer, the priority of care has got to be the treatment of her cancer. But with improved successful treatment options in the oncology field, planning for life after cancer must also be taken into account in her treatment choices. And for some women, the desire of having children is huge. The impact on their future fertility potential is going to be potentially directly because of the cancer type. It's also going to have an impact from the potential surgery that will be performed and adjuvant therapy. Even excluding that, we have to remember that the impact of deferred ability to be pregnant will come with cancer, because let's face it, there's usually going to be a minimum of a couple of years where the patient's advised not to get pregnant. To bring us back to a little bit of basic biology, women are born with all of their oocytes. Over time, the number and quality are going to decline, reducing the odds of conception naturally and increasing the need for likely IVF. As age increases, miscarriage rates increase, as does genetic abnormality. And if we even turn to IVF, the number of eggs it will retrieve at egg collection is going to go down as age increases. So even if there is no direct impact of the cancer surgery or need for adjuvant treatment, deferred clearance for pregnancy has an impact. So how do we protect for that fertility after cancer survival? Ultimately, there are three fairly well-established ways that we might consider: mature oocyte cryopreservation, embryo cryopreservation, or ovarian tissue cryopreservation. The first two of those ultimately are what we do every day, which is IVF, where you use gonadotrophins generally to stimulate ovaries over the course of 10 to 12 days typically, and we monitor with ultrasound. At the point we have those follicles larger with the right output of hormones, we're going to trigger, and 36 hours later, we're going to retrieve eggs. The step to retrieve eggs is a very simple step. It's transvaginal guided aspiration of follicles. It's done with conscious sedation. And typically, we expect to get somewhere between 8 and 18 eggs at an egg retrieval. If we think about it in the context of cancer, well, it goes without saying that, of course, we're going to use ovarian stimulation and controlled ovarian stimulation so that we get a number of eggs. Because in many cases, we might have one bite at that, where we're going to do one retrieval and that's it, because she's going to go on with her cancer care. Historically, we would have often waited to the natural period to start, or in many units use pill starts, where they go on the pill for 10 to 14 days, and then we plan. So it would have taken a few weeks. However, we now very much appreciate that we have protocols that can be immediate start, random start, dual stim, that shortens that time delay required to retrieve eggs and cryopreserve and still get good egg numbers to offer long-term options. Obviously, one of the concerns about stimulating ovaries is, what about estrogen receptor positive tumors? And, we now know that the concomitant use of aromatase inhibitors at the time of stimulation can be very effective at protecting against that risk. And studies in breast cancer patients show that for those patients that delayed and did an egg-free cycle, for example, between their surgery and their chemotherapy, there is no difference in recurrence and disease-free intervals for those patients who choose to undergo controlled ovarian stimulation. It is important to point out what may seem obvious, but the differences between embryo freezing and egg freezing. So historically, the treatment of choice was embryo freezing, simply because embryo freezing's been around since the early 1980s, and we were very effective at freezing embryos. So back in the 80s and 90s, this was really the only option. We created embryos and we froze them as embryos for future use. Yes, these days, if that was the treatment we were considering, we have options like in your late 30s, early 40s, where perhaps they could do PGTA to establish genetic capability, which would give us a better assessment on true probability of that embryo resulting in a pregnancy. And particularly in cases that maybe there was a window to consider a couple of retrieval cycles to be sure we had a couple of euploid embryos before she moved on with her cancer care. It's really important that we appreciate that the sperm choice in embryo creation cycles is fixed and ownership is joint. Now, comparing this to egg freezing, so egg freezing was incredibly problematic for a long time. We all knew that that was the holy grail, but effectively the egg has a high percentage of water in it, and it was difficult to crack the code of freezing with the older system to freeze. Vitrification, which is a rapid freeze technique, ultimately changed that, which came on stream really in about 2007. And it meant that it opened the window to be able to freeze eggs as eggs. From 2012, the title experimental was removed. And now the majority of egg freeze cases are actually social egg freeze, protecting for the future. What it does is clearly allow future choice of sperm. The other important part is that it also allows full control on future use and disposition to remain with the patient whose biological material is stored. The age at freeze and the number frozen is going to predict the chance of successful subsequent pregnancy. Yes, there is limited data on cancer patients, but we have very good data from the social egg freeze group and general IVF studies. So what happens when we thaw frozen eggs to create embryos? Well, the good news is that we now have about a 90-95% thaw or warm survival rate. And we would expect to have a 70 or 80% of those fertilize. But what's more important, if a lady chooses to do an egg freeze cycle, and one egg freeze cycle, what's the probability of her having a baby out of that? And on this graph, you're going to see that on the horizontal line, you have age going from the early 30s to the early 40s. On the left-hand side, vertical line, you've got the number of eggs that were retrieved in that one retrieval. And obviously that's going to fall as we go along through the 30s into the 40s. And on the right-hand side, you have the probability of a live birth from those eggs. So yes, you're going to see that if someone is under 35, we're going to get better egg numbers. And it goes beyond that. The probability that that egg results in a capable embryo is going to be better, and that's going to fall as we get older. So if someone freezes eggs and takes a step to do this for cancer under 35, well, she's got about a 70% plus chance that she's going to have a baby from there if she chooses down the road. On the other hand, unfortunately, if we get down towards, the 40s, then that patient may be falling in, depending on her AMH and depending on how many eggs we're likely to get, into a much lower odds. Next, just to talk about ovarian tissue cryopreservation. And I certainly remember going to many presentations in the early 90s where this was very much considered experimental and at the bench level at this stage. And the good news is, since 2019, it's no longer considered experimental. The type of patient that you would think about ovarian tissue over the other two choices is going to be your pre-pubertal, or if you have a cancer where there's an incredibly short window to consider cryopreservation before cancer treatment must be initiated. One of the most common examples of this would be your hematological malignancies. To put it into sort of pictures of what you do, you need to harvest the ovarian cortex, which is then cut into small strips and frozen. And on the other end of the scale, when it's time to use that material can be thawed and transplanted back into the body. Came across this algorithm, which I thought was quite good, of looking at where might you put it ultimately. And, if you have severe pelvic adhesions, poor pelvic vasculature, well, then you're going to be choosing heterotopic because you can't really get access to the pelvis. Obviously, in the case that these don't exist, orthotopic, and if you've got an in situ ovary, actually putting it back into the ovary where it will start functioning again is a way forward. Now, if we look at some of the data on this, I came across this 2022 systematic review, which was 189 live births from orthotopic placed tissue with about a 37% pregnancy rate and 28% live birth rate. What is important is, no, this tissue doesn't last forever. Ultimately, the transplanted tissue will last an average of about 2.5 years. So in terms of emerging strategies, IVM remains in the emerging bracket. It's not new, it's been around for a long time, and we're still trying to perfect IVM where you're going to be retrieving immature eggs for future use. I'm not going to talk at all about the second one because Bill is going to take over for me and talk about that straight after me on uterine transposition. I think it's really important that when we talk about cryopreservation for cancer patients, the ethical aspects are complex and patient choice is incredibly important. IVF consent forms traditionally are pretty extensive, to say the least, but consent must include choices on disposition in the event of death. It is also recommended that if a patient undergoes cryopreservation as a minor, that they are reconsented at the age of 18. It's very important that anyone understands that cryopreservation of eggs, embryos, or tissue does not guarantee future fertility, but it offers a chance. And I think there's crucial that we have an individual odds discussion to allow that patient to make an informed choice. Because as I said, you have a 43-year-old with a very low AMH with advanced cancer. Her odds of coming out with a baby from that step is very, very low. On the other hand, if you have a 32-year-old, then one egg retrieval offers her a pretty real chance of having a family from that step. Really important that we have a good communication chain between the oncology and fertility team, and not at the very last moment when the patient is about to start her chemo, which is unfortunately too often where it happens. That system should allow and facilitate a fast-track referral to new patient consult. And when that patient has that consult, it must be with an experienced team who can provide information, individualized odds, and very quickly followed with financial transparency of what that means for them as they look at their treatment choices. And obviously once decided, and the oncology and the fertility team are both on board, a very timely decision to move forward and actually make it happen. Now, for this slide, many of you in the audience are obviously from the UK, Ireland, and further afield, and you have many local units. But for those around the Caribbean and in Barbados, yes, Barbados Fertility Centre is the mothership. But we do have units in Cayman and Trinidad, and we are definitely committed to working, to do whatever we can, move heaven and earth if need be, for a cancer patient to give her that opportunity if she wants to take that step and at least get the information. For regional patients, you may or may not know, but we do a lot of, Vikash touched on this, 90% of our patients don't live here, so we're very set up to cope with people who are not on the island. We'll do a virtual consult, get that information, and at least then they can make a decision on this. So hopefully I'm helping Vikash catch up on time and keeping that short and sweet. I'm happy to take any questions or, yeah.
Thank you, Juliet. I'm going to invite persons to come to the center here by the mic to ask any questions. But a valid point that was raised. She's a Barbadian company. She has regional branches. But for North America, where fertility treatment is not covered by insurance, UK, Ireland, what best than coming to the Caribbean? These pristine waters, this lovely weather, the golf for the husbands. So not only do they have to come to just give a sample, they can enjoy the golf out here. Ian, make sure the Barbados Fertility Centre is on your radar when you're speaking to your patients. All right, I'm going to invite Professor Patsy Pressure to ask her question.
Yeah, sure.
Yes, I'm just saying that I'm retired pathologist, Caville campus. This is a personal question. I'm having young relatives now who are having cancers, and just recently, a 32-year-old, she's also a doctor, just married 2 years ago, breast cancer, lives in Jamaica. I want to know if there's any facility or service that you've been offered at your facilities. Is it available in Jamaica? Before she started chemo, I asked her about her plans for a family. And she said that she was not told about or this wasn't discussed with her before she started her chemo. So I don't know if anyone in Jamaica would have any information about this, just in case I have another
there
young
is an IVF
relative.
unit in Jamaica, obviously, as a local service for her. So, and again, unfortunately, this should have been discussed with her, because at 32 and breast cancer, she potentially would have been a good candidate for that. I would certainly assume that the unit there would be doing egg freezing. I can speak for us, which is absolutely, we can easily assist that patient. It would require her to come to Barbados for an egg retrieval, or to go to our Cayman unit, which is obviously closer, and freeze eggs there. But, if she wanted a consultation, so you can certainly ask her to reach out to us on the website, and we can at least talk to her.
Unfortunately, she just finished her course of chemo.
Yeah.
And I don't know if she's eligible for having...
Depending on what chemo she had and in time. But obviously, some chemos don't necessarily mean that you're going to wipe out ovarian function longer term, but, information is always, look, a consult for her individual case with medical records would be the way forward, is what I'd say.
Thank you.
Thank you, Professor Prussia. So you raised a good point. So you have a patient who's already completed chemotherapy. She's 32, she's young, so based on that graph that we saw, she should be a good candidate if she didn't have chemo for donor eggs and a successful outcome. Is there any way to answer Dr. Prussia's query to assess her ovarian reserve? So if you see her, she's 32, she's completed, she may be amenorrheic, the ovaries are not producing hormones. Is there any value in doing something like an AMH to say if she would respond to?
You can do that, but I think the optimal window would have been prior to her starting her chemotherapy, obviously. Yes.
So there was some discussion, I remember, that you can actually give the oral contraceptive pill when giving chemo. Obviously, if she has breast cancer, which may be estrogen and progesterone receptor, and it may be a contraindicated, but giving the pill to suppress the ovary function has been shown to limit the effects of chemo?
Questionable. Okay. There was actually a very good ASRM practice guideline on some of the use of this, and really not necessarily proven at this point. We go on with questions.
Introduce yourself, name,
Yes.
title, where you're from, and then you can give us your question.
Good morning. Thank you. Adam Balin from Leeds, UK. Juliet, thank you. Lovely overview presentation, raising a very, very important topic. And I think it's great in a gynae-oncology meeting to introduce fertility, because it's so important to our patients. And I think the last question highlighted this need for sort of communication. I mean, in the UK, we're having referrals on virtually a daily basis of people, because the oncologists know. But the point I wanted to ask you about, I feel this is always a very good opportunity to help support our patients in getting fit for surgery and for their cancer treatment, because there's a window of opportunity when people are referred to us for fertility preservation. Obviously, it's going to defer their cancer treatment, and that's often a major concern. And something that I'm very interested in is ensuring that we get people fit. And I know it's a big issue in the world of oncology as well, and just wondered what your thoughts are about using this as an opportunity, because there's that window when nothing is happening with the cancer treatment and we're providing fertility preservation, and I think it's a very useful time.
Yeah, absolutely. I mean, in terms of physical fitness.
Yes, and just getting fit for surgery, I think it's something that we miss out on a lot. And in all aspects of gynae surgery, actually, we see so many comorbidities, and people come for their treatment when we could be spending time getting them fitter.
Yeah, I mean, look, at the end of basically, I think we know that having someone medically fit is going to help you on the surgical side. Yeah. And luckily, reproductive age patients, generally are in a fitter, healthier side of the fence, but you'd encourage them to be fit and healthy as well.
I actually think that's a very good question because I read some guidelines recently for the use of GLP-1 medication preoperatively to kind of optimize your patient for surgery. Now, we know the impact of obesity and obviously GLP now, Ozempic, for those who don't know what GLP-1 is, basically those sort of medications that can cause good weight loss in a short period of time. I'm not familiar with this, and maybe y'all can help, but is treatment of obesity something that you would consider getting better outcomes for egg retrieval when you have obese patients coming to you? I mean, I know the obese patients has the polycystic metabolic syndrome attached to it, but just curiosity, when you say making them physically fitter for undergoing treatments, would that be one aspect that you would consider, or is there something else that you're alluding to with regards to fitness?
No, I think you're absolutely right. I mean, it's nutrition generally, nutritional health. Obesity is a massive issue, and we're just writing some new guidelines in the UK on obesity and fertility that I'm actually chairing that. The GLP-1s have a role, but of course they can be a quick fix, but there's a rebound weight gain. There are all sorts of issues. You lose muscle mass. I'm not sure how fit they make you for surgery, but yes, it's a very important point, and I think they're used a lot. They're probably overused as well.
Yeah, we see. I mean, it's amazing the extent of use, and certainly that we see it from our US patients that are on those medications, and obviously, they will need to stop them before we do a transfer.
Of course,
this is not in the cancer setting. This is obviously in the other patients.
And they're contraindicated in pregnancy, but some people are falling pregnant because they're losing weight, they're
correct.
regaining their fertility, and then there are plenty of reports of problems in the subsequent pregnancy. But enough on that. But thank you.
Thanks, Adam.
Thank you. This is Dr. Anna K. Taylor Christmas. She's a consultant obstetrician, gynecologist, mainly gynae oncologist at the Victoria Jubilee Hospital in Jamaica.
Hi, good morning. Just for information, what would be the estimated cost for a cycle?
Egg freezing is generally going to run about 5,000 to 6,000 US plus medications. Now, it will vary in the dose of medications depending on the age of the patient.
Okay, thank you.
This is Dr. Wayne Quinlan from Trinidad, also a trained gynae oncologist.
Hi, Dr. Skinner. How are you?
Hi. You promised me a difficult question now.
Thank you for a wonderful presentation. There's a clinical question I have for you. If you have a patient with bilateral, who did an ovarian cystectomy bilateral, and it came back as low-grade serous borderline, what would be your view on ovarian hyperstimulation and cryopreservation of ovarian tissue with that diagnosis?
I would probably defer that back to the oncologist to see what is your risk.
But she wants to get pregnant. So
and if you felt we could do that, we would do
it. Is there any concerns in stimulating her ovaries again, or?
Well, there would have to be in terms of if you've just done a cystectomy, you have obviously the tissue beside it was in direct proximity.
Yeah.
And the risk of recurrence there would have to be there. I can't say that off the top
of my head.
It was
completely excised, actually. And so she now wants to get pregnant. So we do need to send her to a fertility specialist. Yeah. But would you be concerned about stimulating her ovaries? Or I know it's a tough question because...
Yeah. Look, at the end of the day, basically, you have to accept that if, she had a malignant, even borderline malignant tumor, that there has to be some risk in theory. But it would come down a little bit to how long ago was that, what's been the monitoring since, has there any been predicted risk of, recurrence or what have you. But as long as that was in a reasonably safe zone, then absolutely you would.
Yeah, her image was quite good pre and post surgery, so she has a chance, maybe?
So I actually put it back at you, because if you thought you've excised this and she needs no adjuvant treatment, she's regular follow-up, you have deemed her good, fit, cured, whatever
the
not.
Medical oncologists don't want to give her any chemo.
So if you've deemed that you've excised the lesion, the only concern I would think for Dr. Skinner is possible adhesions, the location of that ovary, and then obviously you'll still do your surveillance. So I do think it's reasonable. I mean, Yeah?
Okay. Thank you.
You're welcome.
This is Dr. Paul Mitchell, consultant at the Victoria Jubilee Hospital in Jamaica.
So we have a 24-year-old with a rare leiomyosarcoma who desires future fertility, but the leiomyosarcoma is in the vulva. So how do we go about fertility sparing that young lady?
Well, I suppose it comes back to, can we, what's been naturally done, and can we get into the vaginal fornix to get access to the ovaries? If we can't, potentially then transabdominally going for an egg collection is an option as well.
Okay, the challenge we have is access to the vaginal interitus because of the mass
Yeah.
in the vulva,
Yeah.
which creates a problem. And then
Look, we do some
we don't have much
egg collections transabdominally,
You see, because it's a rare
and
tumor,
particularly in the
we don't
Caribbean with the number of fibroids we have, that sometimes we certainly have abdominal retrievals
okay.
frequently
Okay.
enough.
So abdominal retrieval will be the way to go.
Yeah.
All right.
If it's just only about access, it's certainly an option.
Okay.
Okay.
Thank you very much. See, I told you we're making up for lost time. We were still going to be on time. We're still on time. Our next speaker is presenting on uterine transposition, a surgical strategy for fertility preservation in pelvic radiotherapy. And William Boyd, is an accomplished gynecologist and gyne-oncologist with a career spanning over 3 decades as well in clinical practice, surgical innovation, and healthcare leadership. Billy earned his medical degree from the University College of Dublin in 1985. He completed extensive postgraduate training, becoming a fellow of the Royal College of Surgeons in Ireland and a member of the Royal College of Obstetricians and Gynecologists in the late 80s. His specialized training includes a fellowship in gynecological cancer and positions at prestigious international institutions such as the John Radcliffe Hospital in Oxford and several leading cancer centers in Toronto and Hamilton, Ontario. Beyond clinical practice, Billy has held significant administrative roles, including head of gynecology department and clinical director of surgery at the Mater Hospital. An active individual, Billy enjoys running, marathons, triathlons, sea, swimming, gardening. He is also a keen cook, having completed a 12-week chef course in 2023. I didn't know any of this about Billy. I actually met Billy at a fete in Trinidad at our last conference, and every time I think about that fete, I get nauseous. So you could just imagine what Billy had me doing. We're going to welcome Billy to the podium. He's promised to speak slow so that you can understand him. If not, I am here to help translate. Welcome, Billy Boyd.
How do you switch it on to there? I also do flower arranging. So how do you? So we turn on the same. Turn on there. Oh, it's there. It's not. It's good. Okay. Forward and back. Okay. Thanks very much. I thought. Thank you very much. I thought that second last question was a very mean question on Juliet, but you handled it very well. I'd like to thank Vikash for the opportunity to talk here. I'd also like to thank Ian Harley, who asked me to talk on behalf of one of the speakers on behalf of the Gynecological Club of Great Britain and Ireland. So it's a great privilege to be here. I thought Raleigh's few words, or well, it was more than a few words, but but I agreed totally with your. So I trained with, and my talk is quite short, so I'm trying to use up my time allocation. No, I'm very impressed that to go from 2014 to where you are now is really quick. I came back in 1996, having spent 2 years with Denny, and with the same vision that you had to try and mimic, copy and paste what Toronto, Sunnybrook, and the Henderson Cancer Centre had. And it's taken me much longer, well, not me, but it's a group, And now we finally have a fellowship program in Dublin between the Mater and Vincent's Hospital and UCD, our college. And we have 8 fully trained gynecology surgeons. We have a team of over 30, all just doing gynecology. But it's taken a long time, and you guys are way ahead that you had one of your own guys on the political scene. So you'd have to be inside to get funding. And it took me a long time to learn that. So I finally learned that and got into management, and it speeds up your becoming a proper centre. So I would like to actually thank Denny, similar to Raleigh, without your input, as rather than just training technicians and surgeons, it was the whole oncology image. And Dublin has benefit. And again, like the pipeline that you have, we've sent plenty of people over to Toronto. Rory McVeigh, even Ian Harley was probably a mistake. But you can't get everything right. But it's been it made a major footprint in Ireland, and we're a tiny country. Anyway, I'll get on to this. We started doing uterine transposition only 2.5 years ago, and probably didn't. And there's so little awareness of uterine transposition. How do you go forward? So this is a very simple talk. So this is a lady came to us 2.5 years ago, 36 years old, and she had a recent pregnancy loss. So she had all kind of funny symptoms, and probably some were underappreciated. She didn't have any abnormal bleeding, so didn't really make it to be assessed. She had no family history of cancer, but the pregnancy loss was still quite a big issue. And all she had was perianal pressure symptoms. And so, I think probably 90% of postpartums will have some sort of perianal pressure, so it wasn't appreciated. However, she came to our colorectal clinic, and a rectal examination showed a large rectal tumour and query primary. Bloods were unhelpful. So she was seen by colorectal and gynae, and she had an EUA, cervical biopsy, endometrial biopsy, biopsy of the mass to see where was the primary. Unfortunately, they come back as a 7 centimetre plus in size, mucinous adenocarcinoma, consistent with a primary rectal tumour in a 36-year-old in Ireland. So not similar to the last question with rare tumours, not a very common presentation. She went through the radio. You didn't have to read all the slide. I just had to fill it up. So the radiology was CT, thorax, abdomen, pelvis, dynamic MRI, and it unfortunately came back as she had more than 7 nodes, all less than 1 centimetre, and also perifascial fat involvement, and right down involving the internal anal sphincter. So quite a big jump from a pregnancy loss to this, and not what we were expecting. This is a tiny video of our CT. Sometimes you get a bit seasick looking at this, but as it comes into vision, you can see this circumferential. I don't have a thing here. You can see the circumferential tumor around the rectum. There's a sagittal image of the MRI, and it comes from the right side of the pelvis. You'll see it in a second. And so this is just feces with air in it on the posterior aspect. The white is the bladder, and as we come right into the tumour, here she has this long circumferential tumour around the rectum. That's a still image, easier to see it. And so it expands over 12 centimetres and right down, as I said, to the anal sphincter, and on digital examination, really close to the dentate line. So sphincter saving was never going to be an option here. So this was all discussed at the GI MDT, and the standard treatment for this is, unfortunately, chemoradiation to shrink the tumour with a protective loop colostomy initially prior to starting this, and with the view, if good response, get an interval abdominal perineal resection and a permanent end stoma. We were called into SEER, and again, similar to what Julia said, we go through the standard package that all patients get. Thankfully, this patient was in-house, so we have a great collaboration with our colorectal surgeons. In fact, we are part of a peritoneal group, so we go to their MDT, they come to ours. So it's we don't work in a silo. And just like the last question on breast cancer, so many groups work in silos, and then you get the phone call the day before the chemo starts. In-house, we've actually got rid of all that, so we're kind of lucky. So again, we were asked to see the patient, and again, the standard LH-RH analogues, plus or minus marina coil, ovarian transposition, probably is the standard that we've been doing for years. Ventral fixation that Julia mentioned, I don't think I've ever done that for a cancer patient. I've done it for a long time ago for different reasons. And again, we've an IVF unit in the Rotunda Hospital, literally 5 minutes walk from our hospital. And they give us a real rapid, well, actually, we don't actually. We used to have an IVF, it's moved. We used to have a very quick access to this, particularly for cancer patients, and they were never charged. That was all free. And embryo freezing or oocyte freezing, depending on whether, and this lady was married. So we've discussed all this with her. And again, we always mention right from the start, and we always, similar to everybody here, all your survival details should be discussed at the start. Don't leave it to the end. And again, surrogacy, adoption, and HRT. But they were kind of long-term issues. This patient was not keen for IVF, as she felt, given the size of a tumour, that this would potentially delay her oncology treatment. And it kind of made it, and ovarian transposition, this lady was going to have a laparoscopic temporary stoma prior to starting chemoradiation. So usually our standard treatment would be to move up both ovaries way out of the pelvic site and then bring them back. My experience with ovarian transposition, when you subsequently send them back for IVF, that they were really difficult to access. I don't know whether, Julie, you've had that, or any of the Adam Balin, that usually you find that they're buried among adhesions, and IVF doing transoscopic or transabdominal scans, that their success rate's been really low and technically very difficult for the fertility units. Maybe your experience is different. So we had read Dr. Ribeiro's reports on uterine transposition. So Donald Brennan, our professor, contacted Ribeiro and discussed the case to say, would this be a case? They've already done them, we hadn't. Would this case fit the criteria? We thought it did. So we discussed it with the patient, said, none's been done in Ireland. It's not a novel procedure. It's just technically there's no awareness of it, and none of us had done it. We've been doing radical trachelectomies for years, and even the old school one where you laparoscopically, devascularize the uterus from its uterine vessels, remove almost all of the cervix and reimplant onto the vagina. So we've been doing a similar, actually more difficult surgery, but very similar for years. So we felt really comfortable in doing this procedure. So therefore the plan was uterine transposition, the colostomy, and then as soon as she was fit to start her chemoradiation, and then her final surgery. And this was all done in-house in one hospital. This is just a picture to show you what it looks like. The left-hand picture shows the uterus in the normal position, the uterine transposition, where you actually do move the uterus, ovaries and tubes on the ovarian pedicles, but it's right up onto the rib cage. And then once you finish your radiation, you bring it back down at the time of definitive colorectal surgery. And then hopefully then with your gestational carrying machine, the uterus, you end up with a pregnancy at some stage. This just, again, the sideways views, I robbed this off Google Images. But it does show the temporary replacement, and you really do move the uterus right out of it. This is just a short video, if I can get it going, of this patient, and I was given permission to show this. So this is, so we're looking through the, so this is the, we're looking through the top port, through the umbilical port, and we're down at, so we've done the lower part. We've actually, I didn't want to show it too long for this. I just want to show you the fixation bit. So we've dissected the bladder down. We've dissected the peritoneum slightly on the posterior. We've put in a McCarthy tube into the vagina, and so that the cervix sits on that, and you push that right up, and you actually then divide both uterine vessels completely, and then we just oversew the top of the vagina. So now we have the uterus, and the hardest part of this operation is to really carefully dissect the ovarian pedicles, so that there's no stretch, no twist, no torsion, and you can't handle the vessels. You handle the peritoneum. You leave a peritoneal strip so that you only pull on that. Otherwise, you devascularize the whole unit. So this is the part where we've actually done the first part, so now we're transporting the uterus on its ovarian pedicles, or the IP, whatever you call it. Now we're up in the upper abdomen. You see the liver left and right with the falciform ligament in the middle. We've actually then sutured the round ligaments. We put a nylon suture through both round ligaments, We make a tiny cut just 2 centimeters below the rib cage, and we pop through a needle a grasper to grab that. There's the cervix, and there's the liver up on top. So at this stage, we pull them up, but we don't suture them permanently. And just prior to the final suturing, we let the gas down to about 6 to 8 millimeters, so there's no stretch on the uterus, or on the ovarian pedicles. This is only another 40 seconds. And there's our and that's it there. So what you do is when you're just before you tighten them up, you flatten the patient out. The patient's in T-Berg. You flatten the patient. You make sure the omentum and all the bowel is brought right down between the 2 ovarian pedicles, so you don't get your internal, bowel rotation or internal hernia. And so but you want to know the vascular supply. So we use Verdi. So it's just a simple IV push, and anything that's green is vascular. And so you can see the liver. This is excreted in the liver, so the liver is densely green. But again, all the uterus is green. There are different filters you can use on the. This is the laparoscopic stack, and you can see the vessels right down to the cervix are viable. Therefore, we have not devascularized the uterus, so it's now completely on its ovarian supply. We bring the cervix out through the umbilicus. So at this stage, we've got the laparoscopic port. It's in a suprapubic position now, and we're looking up. That's it done. No, how do I move on? We use a McCarthy tube. One of my colleagues, Tom Walsh, I think he's a member of our gynae club. He trained with Tony McCarthy in Australia and worked with Ian Hammond, who also came through the Toronto program. He designed this tube, which actually is a lifesaver. It makes laparoscopic hysterectomy much easier and markedly cuts down on ureteric and bladder injuries. So that's what we put in the vagina, which cups around the cervix. So immediately post-op, this lady had no problems. We inspected the cervix daily. She was sent home 3 days post-op, and it was adequately perfused. Immediately, we started on GnRH analogues. We don't use the pill. So I agree with Julia. We've stopped using the pill, and we've even had in another hospital, someone was put on the pill, and then fertility failed, and then sued the gynecologist for not using LHRH analog. So we don't. So it's kind of back. Anyway, that's a long story. We use the monthly GnRH analogs, not the 3 monthly, so we have more control over it. 3 weeks post-op, you've seen in the clinic, a tiny bit of debridement was needed, some antibiotics, but it was a success. That's the cervical. That's the 4 weeks post-op. That's for cervix, and we use permanent nylon sutures to make sure it doesn't slough off and remote. And you can see the stoma bag on her lower left, which is a temporary stoma bag. So so we were happy to do this. So we did the first one in 2.5 years ago, and we've done one since. The first one went really well. The second one, the patient came from a separate hospital, and just like you were saying about people ringing you at lastminute.com, the other person, the colorectal team, were really good, very successful, very similar to this, relatively straightforward. But they went ahead and did the definitive bowel surgery, but didn't contact us. No communications whatsoever. And about 9 months later, she appears for kind of checkup with her cervix coming out through her umbilicus, thinking, what's next, doc? And so we went in to do the second operation, much more difficult. Dense adhesion, no, not dense adhesions, it was doable, but it made it a much more difficult procedure, unnecessarily so. So I think if you're doing these operations, you have to almost get the patient to be the coordinator of her own care. Don't rely on some silo from another hospital, because teams are under a lot of pressure. So it's not a personal comment, but it's just pressure makes people move things along. And again, I think Adam and Julie, you might be more on this. The ovarian function sterilization, there's no one can tell you what's the exact dose that you can give when you're given pelvic radiation to avoid sterilizing the ovaries or sterilizing the uterus or the endometrium. And so this is a math modeling from a paper I read. It's a recent paper that infants are like 20 gray. You'll sterilize the ovaries completely, and the older you get, you need very little radiation to sterilize or knock off the oocytes and also the hormone side of the ovaries. And again, no one can tell you what dose, and I think it's individual. So it is, and that's just the ovarian function. This is a slide I like, but I'm not going to go through it all. People have always ignored the effect of pelvic RT radiation up to a dose of 45 gray, which is the standard chemo radiation dose to shrink a rectal tumour. But there are plenty of papers which will show there are increased miscarriage rates, increased intrauterine growth retardation, increased abnormal placental location with placenta previa. There's even some reports of uterine rupture because the myometrium becomes more fibrosed and can actually rupture in third trimester. So it's quite significant that it's not just the myometrium, but it's the endometrium. Both can have long-term and unpredictable post-radiation effects, even with a kind of an adjuvant dose of radiation. Now, 45 gray is not that high, but it can have a long-lasting effect, and it's unpredictable. That's the problem. Also, many of these patients are older, and so some of them have been heavily treated with drugs, and so you have to be careful in heavy pregnancy with cardiomyopathies from an obstetric point of view. And again, this is what I've said that. Ribeiro started publishing his results on uterine transposition in 2017, and again, it was mainly for people who've got rectal or anal cancer, where you just need to temporarily move the uterus out rather than just a standard, ovarian transposition only. There's been 5 live births published in patients who've had the uterus reimplanted. So at the time on our 2 patients, the first patient was a textbook one, whereas when their uterus was reimplanted, at the time she was having her definitive surgery. So there's no extra surgery. In their second patient, they went ahead and did their own colorectal surgery. It didn't include us, so it was an extra unnecessary surgery. So coordination is really important. But it can be used for vulvar cancer, any cancer that's going to need significant radiation. I said 5 live births. Complications, I know it's ischemia and torsion, but if you're really, I suppose anal is a poor word. Ironic, but you can avoid those. It is important these patients who've got in their 30s with bowel cancer. Is this a Lynch syndrome? So you do need genetics involved to make sure that you're not leaving the uterus, transplanting it back, and then someone may need risk-reducing surgery later on, where they might need their ovaries and tubes and uterus removed if they have a genetic predisposition as a Lynch. Our problem is there's very little awareness. Up to this patient that referred to us, and it's Donal Brennan, our prof, would have been the one pushing to this service. There's really no awareness in the gynae world in Ireland, and there's certainly no awareness in the colorectal world in Ireland that uterine transposition is a relatively easy operation for a gynae oncologist skill set. Unlike, say, uterine transplant, which is that's a whole other world, and that's reanastomosing arteries and vessels onto the external iliac artery and vein. And even harvesting a uterus to transplant is a really radical operation where you need a really long length of the uterine artery and 1 or 2 of the veins. That carries much more risk for a living donor than this set here. We have no register of what patients are told. I don't know whether IVF have a register of patients, of what they've been told and what they've been offered. And unlike the question, the prof in pathology, with their relative, people are not given information before they start chemotherapy. And it's a real gap in what we offer, that we don't have a register of what people are told, but also what are the outcomes 10 years later, 15 years later, and you need a long-term study. Just in Ireland, we're a small country, slightly bigger than you guys. We've 5.5 million people in Ireland, and colorectal cancer is on the rise. So in women we've 2,500 new cases per year in Ireland of colorectal cancer. Just over 1,000 of those are in women. And in women under the age of 40, we've approximately 20 cases per year. In women in our stats, women under 50, the incidence is increasing 1% per year. And I think the figures for Barbados are slightly worse. It's slightly more. It's up the list of more common cancers than we have. But overall, the numbers will not be very high. So therefore, in women under the age of 40, we probably have maybe 5-6 cases per year. So this service would not swamp a gynae oncology service. And should this be in 1 or 2 centres? I don't think so. I think we have 6 gynae oncology units in Ireland, 6 highly functioning ones. And I think this could easily be delivered in any of them, since as long as you have the colorectal team on board. And there's no reason why this shouldn't be offered and does not be referred to a kind of a bigger centre. So again, that's just a summary. The last point of this is the last line. I think this potentially is far superior to ovarian transposition on its own and LHR analogues on their own. It doesn't work, and I'm 40 years qualified, And I've had such poor results when you see the post-survival patient coming to you 20 years later, you know, and the emotional and psychological follow-through is really something. If you can avoid that, this is a relatively simple operation compared to radical trachelectomies, which I'm sure many of the gynecologists here will have been involved in. Thank you. That's the question.
Thank you, Billy. Not only was it short and sweet, I could actually understand it. And it was very good content there too as well. And it actually brought up a question in my mind when I think Paul Mitchell was asking Juliet about his vulval sarcoma patient. And I leave it open to either of you to answer with regards to surrogacy, because obviously we're trying to conserve the uterus, the reproductive organ, because you mentioned that we were looking at it before in terms of ovarian transposition, but now you're looking at uterine transposition. So you're trying to preserve the fertility aspect of this patient to allow her to conceive, I'm assuming, and give birth, which will probably be a cesarean delivery. But what is the role of surrogacy where you are from, in terms of in Ireland, people from UK, anywhere else, that they can give us some advice? Because that, in my mind, seems like a easier option versus having had 5 patients who had this procedure deliver.
Well, surrogacy in Ireland is a problem because if you have a surrogate mother, and so you have a birth mother and a biological genetic person given on the birth cert, it's the person who delivers the baby goes on the birth cert. Now that I know maybe someone may be able to correct me and say it's changing, but up to this has been a big problem. So Rona Mannion now is an ex-master of Holles Street and would have been involved in lots of difficult conversations. So you've got a surrogate mother on the birth cert, and yet it's your child, and you're not on your own child's birth cert. It causes a lot of issues. So it's not something that we struggle with in Ireland big time. And you know, people have come up. You know, it's sometimes the 3 is a crowd, and the one person doesn't go away, and it leaves a long legal ramifications. So it's not something we really promote or have been able to promote.
So just to extend that discussion, I know you can have a volunteer surrogate in certain locations, but I think they've discouraged paid surrogacy, or is that something, maybe Dr. Skinner can shed some insight? Okay, thank you. Question from the audience. Introduce yourself, where you're from, and your question.
Yeah, Marcus Bernardini from Toronto, Canada, Princess Margaret Cancer Centre. Bill, thank you, as many centres are trying to expand into this area, and it tends to fall on the gyne-oncologists. They come to us first. And a question about, you mentioned the first case, the reanastomosis afterwards was done at the same time as a definitive colorectal surgery. Just wondered your thoughts on, obviously, the advantage of doing one operation, but if there would be a problem with the colorectal procedure, increased risk of fistula, interfering with the uterine reanastomosis, is that a consideration?
So you don't actually, the suturing is like you just tack the cervix, or what's left of the edge of the cervix, onto the vagina. So it's not a water seal. So we would do 7 or 8 individual sutures. I know dehiscence is a problem, so we're very strict, but even stricter than benign gynecology, where there's no sexual intercourse or anything in the vagina for 6 to 8 weeks, because it is a high risk. It has been, the back of it has been will have radiation scatter. So yes, but no, well, in the ones, in the many of the, I'm sure you've done plenty of trachelectomies, and now we're much less radical in trachelectomies. But like in a trachelectomy, like you do a radical dissection of the uretary tunnels. You right onto get a 1 centimeter vagina, and you go right up to the internal os, and you divide the uterines, and at the same time, then you just parachute what's left of the cervix, the internal os, and we've had no experience of that.
Yeah, no, I'm not referring to just the anastomosis in itself. I think that's fine. But if there's a problem with the colorectal part of the procedures, a leakage at their reanastomosis,
I agree, yeah.
then that is going to impact likely and increase your risk of fistulization. Yeah. So I just wondered the consideration of putting the uterus back first and then, allowing that to heal and then them doing the definitive. You can't control the outcomes of another operation, obviously.
True, yeah.
Just reducing
we were keen. Well, we've only a small experience, so yeah. I agree with you. But from our discussion with Dr. Ribeiro, he's had none. But many of these patients, if they have low anastomosis in radiation field, they always get a temporary protective colostomy, and then that's delayed. That gets reversed. So the operation finally is over when you keep the loop stoma.
Okay, gotcha.
And so in those cases, that's what we would normally do.
That would make sense, yeah.
Despite using Verdi and everything's lovely and green, we would always opt for that.
Ian Harley, Belfast. I was the mistake. Thank you, Billy. No, I just
just before you ask your question, Ian is the youngest in his family, and he's, I think, 4 sisters.
Four
sisters, yeah. So he's the youngest in the family. So in Ireland, we refer to Ian as the shakings of the bag. It's a phrase it's not a derogatory term. And so I was skiing earlier in the year.
Could you turn his microphone off?
No. So anyway, start with your question.
No, I was going to ask you, I saw you use GnRH analogues, and those are obviously to help, suppress the ovarian function, etc. So if they're going to be amenorrheic, do you really need to bring the cervix up onto the surface with a cervical stoma? Because you're introducing another route of complication.
Yeah, no, I agree with you totally, and it's something we're thinking of stopping, because and it looks awful. To have your cervix through the umbilicus. That was the original one where you were under pressure to get this done to facilitate the starting of the chemoradiation. But also it means that instead of just depending on the 2 round ligaments, you'd have the cervix then, flopping down onto the front of the bowel and omentum, which may cause adhesions. So I would agree with you. Rather than just anchor it to the fascia underneath and don't have it coming out, I think is more than reasonable. I agree with you.
Hi, Vishal Bahal, Trinidad. Just a follow-up question to Ian. Would you give routinely GnRH prior to the operation to stop their periods, and then just, because if you were going to consider that, just to ensure that they're not...
Well, you never know that it's going to be a success until you go in. But there's no harm. No, we would always start as soon as the patients are referred. So, and again, we're lucky. The first patient went very smoothly because all in-house and all same multidisciplinary team. So the sooner you know you're going to do it, I agree, start as soon as possible. Don't wait to do the surgery. Okay.
Thank you very much. And that's very good questions. I actually saw Dr. Bennett raise her eyebrows when she saw the cervix anchored in the suprapubic area. And I'm sure the thoughts of how she would wear a pad in that area. But yes, it would make sense to stop the menses and keep it inside. Don't worry, I'm sure all of us had the thoughts in terms of how it would go. All right, so we're not doing too bad. Give me a second, some housekeeping. We have a lovely coffee break waiting for you, but before we go to that coffee break, I'm going to invite Lisa King from the Canadian Imperial Bank of Commerce just to have a 3-minute word or 5-minute word with you guys. We have to be appreciative of our sponsors, and Lisa is here especially just to address you guys. So welcome, Lisa.
Good morning, everyone. My name is Lisa King, and I am the Regional Mortgage Specialist with CIBC Caribbean. Joining me today is my colleague Dorian Winfield, our Business Banking Manager from our Barbados team. On behalf of CIBC Caribbean, I would like to congratulate the organizers on staging such a meaningful and impactful conference, and to thank you for giving us the opportunity to be a sponsor. We truly appreciate the chance to spend a few minutes with such a distinguished group of medical professionals.
Every day in a busy world, we have to do so much. Like if CIBC, to get that personal touch. Share your ambitions, let us help your dreams come true. At CIBC, we're at the heart of all we do. We're on your side, we're listening, we know the way you feel. CIBC, ambitions made real.
At CIBC Caribbean, we pride ourselves on being a partner you can trust. We are the regional bank with a strong and long-standing presence across the Caribbean, including Barbados, Jamaica, the Bahamas, Trinidad and Tobago, and several other territories. What sets us apart is we combine deep regional expertise with the strength, stability, and innovation of a leading international financial institution. We understand the unique economic environment, regulations, and cultural nuances that shape your financial needs. Most importantly, our approach is client-centric. That means medical professionals like you receive tailored financial solutions designed to support your growth, resilience, and long-term success, both personally and professionally. A dedicated service for medical professionals. We recognize that our profession comes with unique demands, responsibilities, and that is why we offer a dedicated service for our medical professionals through our Platinum Banking and Business Banking teams. Each of you is assigned a relationship manager, either a business banking manager like Dorian, or a Platinum Banking manager. This is our single point of contact for all your banking needs. For example, if you're overseas and need a credit card limit increase, if you spot an investment opportunity, if you're considering expanding your practice or investing in a property but don't have the time to explore all options, your relationship manager is there to help. They are well connected with realtors and other industry professionals, making your search and decision-making much easier. To show our appreciation for your invaluable work you do, CIBC Caribbean has developed a bundled offering called the Medical Professional Edge. This solution is designed to help Caribbean medical professionals take good care of their financial health, just as you care for your team, for your health of others. The Medical Professional Edge supports salaried professionals, startup self-employed practitioners, and established self-employed professionals. It includes a wide range of personal and business banking products, such as commercial mortgages, commercial vehicle financing, equipment loans, overdraft accounts, merchant services, personal vehicle loans and mortgages, land loans, and of course, credit and debit cards. In the interest of time today, I'll briefly focus on commercial mortgages. A commercial mortgage allows you to finance business use properties such as medical offices, retail or clinic spaces, warehouses, income producing or owner occupied properties. Owning your practice space can be a powerful step toward long-term financial security and business growth. Some of the key benefits include greater control over your office space. As the owner, you can design and customize your space to meet specific needs of your clients without the limitations of a landlord. This can enhance patient comfort, satisfaction, and overall wellness outcomes. Building equity and possible appreciation. Instead of paying rent, You are building equity over time. Depending on market conditions, your property may appreciate in value. When you eventually exit your practice, the sale of the property can become a significant liquidity event to support your retirement. Depending on your jurisdiction, you may able to deduct certain expenses related to owning and maintaining your practice property. And if you have extra space, you can rent it to other healthcare professionals such as specialists, labs, or pharmacies, creating additional income and even referral opportunities. There's so much more we can share, but I know that your time is valuable and that you are in the business of saving lives. For more information, please scan our QR code on the screen. Dorian and I will also be available during the break to answer any questions you might have. Thank you for your time, and we wish you a very successful and rewarding conference. And remember, at CIBC Caribbean, our purpose is to help make your ambition a reality. Thank you.
Thank you, Lisa. So little did I know, I bank with CIBC, and that they have a medical professional's edge, which suggests like I should be getting preferential interest rates and all those perks that you presented here today. I know I already have it, I'm just teasing. There's no harm in asking for more. So thank you, Lisa, and your team for coming here today, presenting. I saw some eyebrows raised in the audience, so we know you have a booth on the outside that they can come and have that personalized attention start now if they're not an existing customer, and if they're an existing customer, to see how they can grow their portfolio with the bank. Thank you very much. All right, see how we've made up for lost time? So what I'm going to allow you to do is have a coffee break, and this coffee break will carry till 11:30. Okay, so you get a good 18 minutes. And during that time, I'm going to invite the other presenters for the next session to bring your presentations to me here so we can upload it. But enjoy. Stretch your legs. Refreshments are at the back of the hall. Washrooms are by the elevator. And if you go outside past the sponsor's booth, on your left-hand side, there's a lighthouse if you want to take some pictures and a fantastic view of the sea. So see you back at 11:30.
Do we go to the back?
I'm going to get him to come.
Yeah.
No, just me controlling for the back. So just
okay,
bring
just
it
I
down.
can't see. Oh,
Just-
okay, that's fine.
Just move it down.
Yeah.
It's okay. Where's Casimir?
Casimir is a great guy with that jacket.
Right.
Who's now at Korea. So he's uploading. So I have to introduce you, right? So I'm going to speak to you, and I'm going to put you as the president-elect, or that can't be announced yet?
I have no idea. Talk to Raleigh.
Is right. Oh.
Sorry about this. It's just I've got to put my code in.
See you. How are you?
be here every year.
Okay. Oh, yeah. The pointer doesn't really work, does it? The pointer doesn't work, but it's okay.
Oh,
I
yeah.
don't need to.
I want to use it anyway. Hey.
Oh.
Sorry.
You like me to add?
Not really. That's fine. I mean, I'm going to introduce myself anyway as being privileged to be an international mentor to gynae-oncology trainees in Jamaica. And I'm actually going to show a slide of a case that Christopher Daly phoned me about last week.
Oh.
And yeah, because we actually discussed it last
Okay,
week.
that's good.
And he sent me some of the photographs of the patient. So I've actually put them into my presentation. Yeah, yeah. I'm just going to upload this if I can. No, great, Matthew. Fabulous, yeah. Sorry. I haven't done it yet.
Oh,
I'm
I
I'm
apologize.
just trying to get out of whatever he's done.
Okay.
But maybe I don't need to.
So, okay. I just need to close this.
This one? Oh, hang on. Oh, sorry.
No.
Sorry.
It's okay. This is the one.
Yeah.
GTN Club.
Yeah. Yeah.
Copy, desktop, presentation, paste. So this one is you, right? GTN
Yeah.
Club and cancer, pregnancy.
That's James. Yeah.
Okay. We had anybody else? I think there were
I have.
four.
I have Ian Harley.
Okay, let me eject this one. I'm safe to remove.
This is Ian
Ian
Harley.
Harley, okay.
And he's talking about. Let's see now. I'll find out what he's talking about. Surgical staging.
Personalized surgical staging. Oops. Microsoft? Okay. Is it? I left it on the table. If not, it's in my bag. Yeah. Okay. What he says?
PBDS, personalized surgical staging. He's just there. I can ask him.
Yeah.
Ian. Just to choose the correct one for you.
With your presentation.
Phil gave me his memory stick, so just to choose your one correctly.
Well, you can get the USB-C stick there. No, you do. Oh, I see. One of those weekends.
Where am I going to
Yeah, well, we'll get it out in a wee minute. Jesus. That's it.
Okay. Okay.
That's Susan's.
I thought you had to discharge them. Don't pull that out.
No, I won't. No.
Oh, you can use it, right?
Okay.
Can you just pull them out? Here.
I know I ejected.
Oh, he's going to put his top onto that.
Interview where I can
Yes.
see my notes.
Yes,
Yeah.
yes, yes.
That's right. Okay, I think that's in there. You can put it on the desktop, probably. Is that what you're doing?
Yes.
Strategy.
It's got, do you want it on a USB? It's got a USB as well as a USB-C.
See, yeah.
Okay, so talk is. Let me find it here. Hang on.
Should be, if you just do it by date, it should be the top one.
Oh, you know what though? I wonder if I took it out too early because it doesn't look like not enough free space in your computer. That doesn't make any sense. Hold on.
There should be loads of space on the disk.
Yeah. Okay, let's just take it out again. Let's try it again. I'll put it back on and see what it's showing on mine. Because it looks like it's not fully registered there. So just exit the
Eject.
eject. Okay. Well, that's the other option. There's something. So it's there. It's definitely on the disk. Confirm that.
Just in case, for whatever reason, it's...
Yeah, it's odd that it wouldn't. No, unless. Ooh, I hope it's not because I've used a new machine. So we know how to do it.
Well, we know it's on the file. You've done it on PowerPoint, you haven't done it on Keynote.
PowerPoint.
Is this it?
No, it's this one here. You see how it's not. So so let's see what it says when you click it. Double click on it.
This is it. Yeah.
Just open it.
Oh, I see. Okay, there's two versions of it. Okay, there you go. Okay, I'm not sure why there would have been two versions.
Well, as I say, I think one was corrupt, wasn't it?
Okay. Yeah, let me try one thing. Just bear with me on the presenter
Do
mode.
you want me to put my talk for tomorrow on?
Sure.
I just need to change the order of my slides slightly.
Okay, we can get it in the morning.
Well, no, it doesn't make any... I can't change the order of...
Where's the presenter view?
Yep.
This one here?
Yep.
You next.
Let me just...
Oh, I see. Yeah. Okay. Okay. Looks like it's all.
One love, one heart. Let's get together and feel alright. Hear the children crying. One love. Hear the children crying. One heart. Saying, give thanks and praise to the Lord, and I will feel alright. Saying, let's get together and feel alright. Whoa, 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 whoa. Let them out pass all their dirty remarks. One love. There is one question I'd really love to ask. One heart. Is there a place for the hopeless sinners who has hurt all mankind? Just to save his soul, believe. One love. What about a one heart? What about let's get together and feel alright? As it was in the beginning, one love. So shall it be in the end. One heart. Alright. Give thanks and praise to the Lord, and I will feel alright. Let's get together and feel alright. One more thing. Don't worry about a thing, 'cause every little thing gonna be alright. Singing, don't worry about a thing, 'cause every little thing gonna be alright. Rise up this morning, smile with the rising sun. Three little birds pitch by my doorstep, singing sweet songs of melodies pure and true, saying, this is my message to you. Singing, don't worry about a thing, 'cause every little thing gonna be alright. Saying, don't worry about a thing, 'cause every little thing gonna be alright. Rise up this morning, smile with the rising sun. Three little birds pitch by my doorstep, singing sweet songs of melodies pure and true, saying, this is my message to you. Meaning, don't worry about a thing. Worry about a thing, oh, every little thing gonna be alright. Don't worry, singing, don't worry about a thing. I won't worry, 'cause every little thing gonna be alright. away. Oh God, I got to take a leave from reality. I just can't dream. As a while staying with this real. Take it easy. Got to take it easy. Take it easy. Can take it easy. Tell you what. Jolly children, yeah. Jolly children, yeah. Jolly children, yeah. Jolly children, yeah. The truth is an offense, but not a sin. Is he who laugh last, children? Is he who wins? Is a foolish dog bark at a flying bird. One sheep must learn, children, to respect the shepherd. Jolly children, yeah. Jolly children, yeah. Jolly children, yeah. Jolly children, yeah. Fools say in their heart, Rasta, your God is dead. But I know, Jaja, dread, it shall be dread, a dread. Jolly children, yeah. Jolly children, yeah. Jolly children, yeah. Jolly children, yeah. Africa unite, cause we're moving right out of Babylon, and we're going to our father's land. Yeah. How good and how pleasant it would be before God and man, yeah, to see the unification of all Africans, yeah. Has it been said already? Let it be done, yeah. We are the children of the Rasta man. We are the children of the Maya man. Africa unite, cause the children wanna come home, yeah, yeah. Africa we're moving right out of Babylon, and we're grooving to our Father's land. Yeah, how good and how pleasant it would be before God and man to see the unification of all Rasta man. Yeah, have since been said already, let it be done. I tell you who we are under the sun. We are the children of the Rasta man. We are the children of the higher man. So some they say see them walking up the street. They say we're going wrong to all the people we meet, but we won't worry, we won't shed no tears. We found the way to cast away the fears forever, yeah. We'll be forever loving Jah. We'll be forever. We'll be forever loving Jah. Forever, yes, and forever. There'll be no end. So hold my river, don't cry for me. I've got the running stream of love, you see. So no matter what stages they put us through, never be blue. No matter what rages they put us through, we'll never be blue. We'll be forever, yeah. We'll be forever loving Jah. We'll be forever. We'll be forever loving Jah. Forever and ever, yes, and forever. 'Cause there's no end. 'Cause only a fool lean upon his own misunderstanding. Oh, yeah. And then what has been hidden from the wise and the prudent been revealed to the babe and the suckling. In everything, in every day, I say, we'll be forever loving Jah. We'll be forever. We'll be forever loving Jah. Holy priests, warriors, and traitors, be still, but Jah live. I don't want to wait in vain for your love.
Ladies and gentlemen, can you please return to your seats? All right, as we make our way back to our seats, anybody had chance to go by the lighthouse on the outside? Yes? Into the beach? No, by the pool? Yes, very good. So far, it's been so good. The morning session has been very enlightening. And for the second session, after this short coffee break, just remember we have a full buffet lunch available for the next session. And that's going to be upstairs, overlooking the sea. Air-conditioned room, so that you don't feel too hot while you're consuming. I'm going to introduce our next chair of the session. We're going to pass it over to the Vice President of the Caribbean Gynecologic Cancer Society to introduce our speakers. And that is none other than Dr. Matthew Taylor. Dr. Matthew Taylor hails from Jamaica. He is one of the gynae oncologists at the University Hospital of the West Indies. He is currently the university examiner for the University of the West Indies, and he was instrumental, for those who are familiar with MBBS exams, in introducing the OSCE system, which we all love so well, where they've standardized medical education and the assessment of medical education in the region. So as university examiner, he sets up the exams and oversees all 4 campuses, as well as still practices obstetrics, whether in a little way, gynecology, and gynae oncology at the University Hospital. He was my registrar when I worked at the Victoria Jubilee Hospital. He probably doesn't remember because you left us to do all the work, but it was only for what, 3 months? He said, yeah, man, you can manage that. You can manage that case. Go ahead, no problems. And everything in Jamaica is no problems. Welcome, Dr. Matthew Taylor.
Thank you, Dr. Shoshani. All right. Thank you, Dr. Shoshani, for those kind words. It's been a pleasure to attend this meeting today. And we've had some good talks so far, and I'm sure we'll continue to have some good talks today. And I really like to thank the organizers, particularly Dr. Shoshani, for organizing this wonderful meeting. So this morning we spoke about fertility preservation in cancer patients. And now, so our next topic is very needed, cancer in pregnancy. Our presenter is Dr. Castleman. Dr. Castleman, James Castleman, is a consultant obstetrician and subspecialist in maternal and fetal medicine at Birmingham Women's Hospital. His main clinical interests are in fetal intervention, prenatal genetics, and obstetric cardiology. Practicing in one of Europe's largest maternity centers, James cares for women and their babies affected by complex medical problems, including pregnant women with malignancies. His talk today will focus on the obstetric issues encountered by women diagnosed with cancer and the impact of oncology management on the pregnancy. And I just want to add, I don't know how this will fit into his talk, but apparently he has half a dozen chickens that he looks after, and it's a 16-week-old puppy? A 16-week-old puppy. But I'm sure there's some relation to pregnancy there. That's how he got those pets. I assume they're pets. So I introduced Dr. Castleman to come and do his presentation.
Thank you. That final bit of the bio was added when we were just chatting in the toilet, actually, and they said, what else are you into? And I said, I've got some chickens. But anyway, I'm going to talk about cancer in pregnancy, and as really just a broad overview of all cancer types affecting pregnant women, and then a little bit about gynecological cancers as well. There we go. Yeah. So we'll start with a bit of epidemiology, and then we'll talk about the maternal, fetal, and neonatal aspects that are important to consider. There's three main reference documents that I've used to prepare the presentation. So we've got the Embrace report on maternal mortality in the UK, which I'll describe a bit shortly. And then there's two useful FIGO practice guidelines and consensus statements about management of cancer in pregnancy. So pregnancy-associated cancer is cancer diagnosed either in pregnancy or within a year postpartum. And the incidence for that is 1 in 1,000 pregnancies. And we are seeing the incidence increase because of increased maternal age, more women are obese. The diagnostic methods to diagnose pregnancy in women, to diagnose cancer in women of childbearing age are improving, and also with increased genetic testing and family screening for inherited cancers, we're discovering more in our pregnant population. But of course, women who have had cancer previously, maybe in remission, can enter pregnancy and have a recurrence, and women may conceive while they have active cancer. So there's a range of different ways that cancer can present in pregnancy. And the diagnosis can be really challenging because a lot of the symptoms that women may first present with that ultimately are known to represent a cancer can also be features of pregnancy, so things like swelling, bleeding from the genital tract, nausea and vomiting, things like that. So I remember when I was just started obs and gynae, I actually did 3 months of gynae oncology to start with, and then went to the labour ward to balance out for the second half of the 6 months. And I'd been looking after on the oncology ward women with post-op complications, obstruction and stuff like that. And then we had a lady come in labelled as hyperemesis gravidarum, didn't recover post-natally, seemed to be obstructed after a caesarean section, and even the radiology report initially said the gravid uterus was retroverted and obstructing the rectum, and we all thought that's really unusual. And it was only when people started to think more carefully, why isn't she getting better, they reviewed the imaging and it was actually a rectal tumour. And it just shows we mustn't just attribute symptoms to pregnancy, that more unusual things can be happening, and to always consider cancer in young women. So just a bit of epidemiology to start with. So this is the female cancer incidence between age 15 and 49, so women essentially of childbearing age across the world, with the darker shades being an increased incidence and the lighter shades of blue being a lower incidence. And this is for 2022, when there are about 2 million diagnoses worldwide. And this is the Global Cancer Observatory that collecting the data. The cancer was the second most common cause of death in women of childbearing age, and the global incidence is between 17 and 27 per 100,000 pregnancies. And when we zoom up on the Caribbean, you can see that actually the incidence of cancer here in Barbados in women of childbearing age is actually lower than it is in the UK. But when we look at cancer deaths, there are more deaths from cancer compared to the UK or to the US. And then these figures are slightly different. Rather than looking at women of childbearing age, this is all people under age 75. And I don't know if the numbers perhaps don't project very well, but in the middle column, you've got the risk of a woman dying with cancer before age 75. It's actually 9% both in the UK and in the Caribbean. But when you look at Barbados, the risk is slightly higher, so 11%. And then when you look at the cancer type, so this is female cancers under age 75, you can see in all the countries, or UK, Caribbean, Barbados, breast cancer is the most common. But you actually have more uterine cancers in Barbados, and you can see both in the Caribbean and in Barbados more cervical cancer. And it was interesting just to hear in the intro and then see the programme running through the weekend that there'll be more talk about reducing those disparities and improving cervical cancer screening. So if we go back to the UK, we have the Embrace report, which is a surveillance system where all maternal deaths in the UK are looked at very carefully by a group of multidisciplinary assessors, and they report for 3-year periods that they call a triennium. So the most recent report last year was reporting on the 21 to 23 triennium. And actually, cancer in pregnancy was not one of the top 5 causes of maternal death. The most common cause was blood clots. But actually, VTE can be associated with cancer, so there is some crossover there. The 2024 report had a special chapter looking at cancer in pregnancy specifically. So I'm just going to go through a few of the lessons learnt from the assessment of those cancer deaths, of which there were 94, which gave a rate of 4.28 deaths per 100,000 maternities. And they were all so-called indirect deaths, so there were no death directly attributable to pregnancy, which would be choriocarcinoma. And you can see it falls into those indirect deaths, the purple bar in the middle. So things like VTE, cardiac disease, COVID, much more common. But actually, when you move into the deaths 6 weeks, between 6 weeks and 1 year after birth, these indirect deaths due to malignancies become a bit more common, accounting for 21% of the deaths. And then this table shows 19 early maternal deaths, so deaths during pregnancy or up to 6 weeks postnatally, and 75 late maternal deaths, so from 6 weeks to a year. And you can see that it's the breast cancer as the main subtype. And then this table just shows difference in time. So the last time that they looked at cancer deaths was 2017 to 2019 triennium. So that's the blue bar, and then the orange bar, the most recent 3-year triennium that they looked at. And the cancer deaths are sadly increasing. So you can see the GI cancers, for example, and the breast cancers, both more in the more recent surveillance period. And that's been shown internationally as well. So then this is an international network of cancer, infertility and pregnancy, a registry of 28 countries, including 1,170 patients with pregnancy-associated cancer over a 20-year period. And again, you can see that breast cancer is the most common type, then followed by cervical cancer, lymphoma, and then ovarian cancer. So the cervical cancer comes in when you include countries with that haven't got the well-developed screening program or prevention program. And interestingly, the colorectal cancers and the lymphomas tend to present at a more advanced stage. So the paler reddy pink bars show advanced stage, and the darker is early stage. And clearly later stage cancers would be more associated with mortality. Right, so that's a bit of scene setting and the background to the epidemiology of these diagnoses of pregnancy and cancer in pregnancy. So how do we manage this as obstetricians and as part of a multidisciplinary team? So early obstetric review is really important, and at that first appointment the aim is to build a relationship with the woman and with the family to guide them through the pregnancy and to navigate difficult choices. And obviously this is a really difficult part of their life for these two things to be happening at once, a pregnancy and a malignant diagnosis. There are lots of things to consider and lots of choices to be made. One of those choices might include termination of pregnancy. I know abortion laws are different in different jurisdictions, but in some cases, for example, a rapidly progressive hematological malignancy where early chemotherapy is really important, or just for somebody that doesn't want to encounter these two things at once, termination of pregnancy is an option. We need to plan careful fetal ultrasound surveillance, both for fetal growth, but also where there's been an exposure to radiation or chemotherapy, and we'll talk about that in another slide. Ultrasound also has a role in surveillance, for example, for things like fetal anemia, which can be associated with some sorts of chemotherapy, platinum-based. And for those of you who don't work in fetal medicine, we use the middle cerebral artery Doppler as a screening method to detect anemia in utero. Cervical length scanning is increasingly having a role in preterm birth prevention, and there's a few ways that that becomes relevant in care of women with cancer. So alkylating agents can cause uterine contractions and cervical shortening, so cervical length measurement has a role there. Some women will have had or will have excisional treatments to the cervix, which leads to cervical shortening, and other women may have a cerclage from previous cancer treatments. So measuring the cervical length and assessing the sort of competency of the cervix is important. And also in women with a short cervix in the clinic, we offer bacteriological screening with swabs of the vagina and testing the urine as well. And then women with cancer, because they're immunosuppressed, they should be encouraged to have all their vaccinations. So flu, COVID, herpes simplex, as well as the routine whooping cough and RSV that are more targeted at to help the neonates. And of course, psychological support can't be underestimated and is one of the key things. And actually working with formal psychologists as well as midwives who have special training in that is really crucial. So clearly it's a massive team and it's multidisciplinary. And one of our roles in maternal fetal medicine is to sort of project manage all that and pull everyone together and make sure there's a common strand and a clear plan that's well communicated amongst the whole team. And increasingly as well, we're working in networks. So in the UK, we've got maternal medicine networks. So that's really well-defined care pathways so that whether a woman lives in a rural part of a big county or in a big city right next to the big tertiary unit, there's equity of access to specialist care. And I imagine similar networks happen across the Caribbean because you can't possibly have experts in every cancer type or every aspect of maternal medicine in every single unit. So a few things I'll just bring in along the way, just in terms of things to think about in the management of cancer in pregnancy. So increasingly in fetal medicine, we're using cell-free fetal DNA. So the concept that some fragments of fetal DNA are present in maternal blood, and we can test that either as screening or diagnosis for chromosome or genetic conditions. And this test is actually not possible in women with cancer because the cancer cell fragments may have aneuploidy or other rearrangements that mean you would get false positive results. But interestingly, you can actually diagnose occult malignancies from a false positive NIPT. So for example, NIPT comes back as highly likely trisomy 21, but actually the aneuploidy comes from maternal tumour cells. And so in a fetus that's structurally normal, that's always something that has to be considered, and that there's a 0.01% chance of finding an occult cancer in the context of NIPT. So moving on to some obstetric outcomes for women with cancer. So there was a big systematic review and meta-analysis from the senior author was Ponce Wu, who's in my region in Stoke. And they looked at 59,000 pregnancies, 22 studies, and then the control population was 70 million pregnancies. And they found, as we would expect, that women with pregnancy-associated cancer have double the risk of adverse outcomes and a 42-fold increased risk of maternal mortality. But when we look at some specifics, the risk ratio for caesarean section was 1.58. So lots of reasons. Sometimes just due to planning and timing an elective birth, or stopping the pregnancy early to enable the woman to embark on cancer treatment that she wouldn't be able to have if she remained pregnant. Sometimes dealing with pelvic cancers, an operative birth allows simultaneous biopsy and surgical treatment, and then also lower genital tract or colorectal cancers can obstruct the birth canal, so caesarean section is necessary. Preterm birth, whether spontaneous or iatrogenic, is also much more likely, so risk ratio of about 3. Some of that's associated with fetal growth restriction, where there's been radiation or chemotherapy affecting placental function, and some of it is in order to deliberately cut the pregnancy short, either to allow the woman to embark on treatment, or sometimes, sadly, if the placenta as an organ is failing because of end-stage cancer and the woman needs to move towards end-of-life care. Thromboembolism, as you can imagine, a really significantly increased risk. And as I said at the beginning, the highest cause of maternal death in the UK is thromboembolic disease, and 30% of the women who died of cancer in pregnancy died of VTE. So VTE prophylaxis is a really important consideration. Interesting, when I was preparing this talk, I'd actually forgotten that women with active cancer don't need thromboprophylaxis through the whole of pregnancy according to guidelines. It's actually just from 28 weeks. But I think most will have an additional score for some other risk factor that means they would need it throughout. And of course, women who need thromboprophylaxis through pregnancy are also maintained 6 weeks postnatally as well. Women with metastatic cancer do have it throughout, and women with previous cancer are just assessed according to their generic risk scores. Their previous cancer doesn't have an impact on their risk unless there's a recurrence. Coming to fetal and neonatal outcomes, I haven't put all the charts up, but when they looked at this, there were actually no statistically significant increased chance of fetal growth restriction or low birth weight, or of congenital malformations, or of fetal death. But when they put all of the fetal neonatal outcomes into a composite, actually there was a 1.7-fold increased chance of having some sort of fetal neonatal adverse outcome. I'm not going to go through, just in the interest of time, the effect of pregnancy on the various cancer types that can present in pregnancy. But actually, pregnancy doesn't really alter the progression of cancer per se. It's more things to do with delayed diagnosis, masking of symptoms, like I said with the example at the start, and later stage presentations. And the key message really is to always think of cancer on the differential diagnosis for unexplained symptoms, particularly persistent symptoms, high analgesic requirements, and not to be reluctant to treat the woman as you would a woman who's not pregnant, or as you would a man. Obviously, men can't get gynecological cancers, but you know what I mean. It's a good question to ask ourselves in obstetric medicine: what would you do if she wasn't pregnant, and what would you do if she was a man? And then actually make a really good reason for not following what you would otherwise do. So a few points on chemotherapy. So the first trimester is the key time to worry about teratogenicity, because that's when all of the body organs of the fetus are developing. And then really after that, with a few exceptions, the fetus just has to grow. So the first trimester is the time to avoid chemotherapy if possible. And overall, there's about a 14% chance of congenital malformations when chemotherapy is used early. If it's accidental exposure for a woman who hasn't realized she's pregnant, which should be a rare event because we should be doing a pregnancy test, but if there has been accidental exposure, then we become involved as fetal medicine specialists in assessing for structural malformations. From the second trimester onwards, almost all chemotherapy is appropriate, and women can be maintained on it. Usually, if we're aiming for a term birth, then till about 34 to 35 weeks. And that allows a washout period for the chemotherapy, both for the woman's bone marrow to recover, but also for the fetus to recover, so that the bone marrow suppression is not present after birth. Breastfeeding, possible 1 to 2 weeks since the last dose of most chemotherapy, but breastfeeding on chemotherapy is usually not recommended. But women can be encouraged, for example, to express colostrum and bank milk in anticipation of restarting chemotherapy, so that some of those benefits are still accessible to them. Radiotherapy is usually avoided, but if it's distant to the pelvis and an expert radiation physicist and radiation oncology clinician has planned it, then it can be possible. But that's something that needs very careful planning in pregnancy to direct the beams away from the gravid uterus. There's a lot of myths, if you like, or long-standing concerns about radiation in pregnancy, and actually sometimes women come to harm because people have been reluctant to do proper imaging. And actually, when you look at the table here, the doses of radiation for the standard tests that we would use are actually very low. So unless it's something with prolonged multi-plane CT or doing fluoroscopy for a long time for some sort of interventional procedure, it's usually almost negligible risk. And we can usually say, in terms of the breasts that are preparing for lactation, the risk of breast cancer is very, very minimal, and the risk of the unborn child developing cancer relating to radiation is very, very small, and probably lower than the background risk of things like a long-haul flight. When we think about surgical management as part of the oncological plan, then it's ideal to delay it until the second trimester onwards if possible. And at that point, to reduce the aortocaval compression and to maintain the blood flow across the placenta, a left lateral tilt is part of the surgical planning and the anaesthetic consideration. Laparoscopy is preferred, although at lower pressures than usual if possible. And what we usually do is just listen to the fetal heart before the surgery and then in recovery. It can cause a lot of problems if we use continuous monitoring throughout the operation, and it usually wouldn't be appropriate to pause a complex operation to deliver a baby in the context of a major oncological procedure. So it would be unusual to do monitoring during, but that needs to be very explicit that the plan is to focus on mum and then assess the baby afterwards. Clearly at later gestations, when the baby has a good chance of survival without disability, that decision making may change. We also have to think about optimization of the preterm neonate. So particularly if the surgery is associated with an increased chance of preterm birth, maybe because of uterine manipulation or the drugs that are used, then if we think we set the cutoff at about a 5% chance to give steroids for fetal lung maturity, magnesium sulfate to reduce the chance of cerebral palsy. And if we think the uterus is being manipulated, we may use tocolysis to reduce the chance of spontaneous preterm labour. And then thromboprophylaxis, because we're giving yet another risk of thrombosis. I won't talk too much about the other modalities because new types of treatments for cancer are coming in all the time. But the important thing in this field with the more novel treatments is women during pregnancy and lactation are not included in oncological drug trials. And this is a big thing in obstetrics, that actually we do struggle to bring in new treatments because of the exclusion of women from trials. Now, clearly there's good reason for that sometimes, about fears of causing problems for the fetus. But at the same time, unless we do include women in trials, then they'll be excluded from the use of those drugs. Little bit about timing of birth. So ideally, we want to provide the family with a healthy term baby, and that in all of our work in MFM, that would usually be the default to get to term, and to support a vaginal birth unless otherwise contraindicated. There'll be some cases where caesarean needs to be recommended. So if induction of labour at a preterm gestation is unlikely to be successful, or aspects relating to the cancer itself. So for example, cervical, vulval, rectal, anal cancers that would obstruct labour, then a caesarean birth would be necessary. And then an iatrogenic preterm birth by caesarean would be necessary where there's poor disease control, the woman's extremely poorly and not physically strong enough for labour, or she's transitioning to end-of-life care. We mentioned that washout period for chemotherapy already. And then it's really important to think about postnatal contraception. It's something that might be missed, but what we don't want to be managing is an unintended pregnancy during cancer treatment, because of the woman may feel that she's too poorly, or the effects of the drugs that she's on may prevent a pregnancy, but actively recommending contraception is just as important in this group as in the other obstetric medicine patients that we look after. And breastfeeding individualised, but usually okay when not on chemo. We also have to involve our neonatal colleagues, so we would always arrange a consult to discuss how that period would be navigated and what the risks to the neonate are. Clearly that's gestation specific, depends on the weight of the baby and the sorts of cancer treatment that the woman's had. But there are aspects, for example, if they've had anthracycline chemotherapy, that's cardiotoxic and crosses the placenta, so the baby would need an echocardiogram. Hearing screening, if platinum chemotherapy is used, there may be risk of placental or neonatal metastasis, or there may be still effects of the chemotherapy like pancytopenia or risk of infection. So all of these things need to be borne in mind. I'm not going to talk about palliative care because there's a specific session later about that, but clearly in some cases, palliative care and discussing the priorities of the woman for the limited time with the baby would be really crucial. A few specifics about gynecological cancers, because there's a lot of gynecological oncologists in the audience. So as you know, for treatment of cervical cancer, conization and simple trachelectomy and node resection are all safe in the first half of pregnancy, but radical trachelectomy would not be recommended in pregnancy. And then for advanced ovarian cancer, the treatment, this is one of the cases where the management is different in pregnancy because it's usually restricted to biopsy and then neoadjuvant chemotherapy, and the major surgery is delayed until after the baby has been born. So just to pull things together and just think about some of the lessons from the Embrace report, just a couple of vignettes. So a grand multiparous woman, social and mental health complexities, never had a cervical smear, and this hadn't been recognised despite encounters with healthcare providers through pregnancies, multiple unplanned visits with vaginal bleeding, and I won't read the whole thing, but essentially examined by junior people, always attributed to benign pregnancy causes, and then only when she was examined by a more senior person, actually did a speculum examination, a vaginal examination, felt saw a tumour, was able to access colposcopy, and had very late stage cervical cancer. So things like repeated attendances, unexplained symptoms, no actual diagnosis made. These themes sort of run through some of the cancer deaths. And so colposcopy and biopsy should not be delayed just because a woman's pregnant. And then another example of a woman whose nausea, vomiting, weight loss was all attributed to pregnancy, and then despite then getting upper abdominal pain, still thought to be all pregnancy symptoms, and she died of metastatic colon cancer that could have potentially been diagnosed earlier. So again, we mustn't always just be thinking of the gestational disorders. They should be diagnoses of exclusion, and we should always be trying to make a diagnosis and not just say it's not that, you know. So the classic would be chest pain. We worry about a pulmonary embolism, we exclude that, but we often don't actually say what is the cause of the chest pain, and we should be doing that. This is just a slide to show that there is support available for these women. This is a UK and Ireland charity called Mummy's Star, but I checked before I showed the slide in the Caribbean because they do also offer support for women around the world, and doctors who are either affected by cancer or doctors managing difficult cases of cancer in pregnancy, and they've got a really good website with lots of support. So just a few closing messages, key things from the Embrace report. So 21% of women who died from cancer in pregnancy entered pregnancy with a history of past or current cancer. We need to provide pre-pregnancy counselling to women with cancer, so they know the risks and actively are choosing to embark on a pregnancy with optimised health at the beginning, or be given a chance to delay pregnancy until their health is optimised. All of the women should be receiving consultant-led care. We've talked a bit about the importance of investigating new, persistent or unusual symptoms and making sure senior people are involved. Imaging modalities, really if you're not providing the imaging that you usually would to a non-pregnant person, that needs to be clearly justified, because there's very few times when the usual radiological investigations wouldn't be appropriate. Discuss end-of-life care where relevant. Think about the risk of thrombosis and guard against it. And then the questions I go back to in all through obstetric medicine, as I said before, is what would you do if she wasn't pregnant? What would you do if she were a man? And then also, as a third thing, just think about her priorities, because it's all very well us thinking what we think a nice package of care is, but actually what's important is what is important to the woman and the family and how they want to navigate. And that's, we've seen a lot of nice sunsets in Barbados, so that's the sunset in Birmingham to close. Thank you.
Thank you very much for that talk, Dr. Castleman. I mean, in the Caribbean, although we're all at this meeting predominantly gynae oncologists, we all manage obstetrics still, on the side. So, we are involved with patients directly. So it's a very useful talk for us. Any questions? Well, I have a question for you as well. We've found that recently endometrial carcinoma is on the rise, in Jamaica certainly, and I think in the other Caribbean islands. Have you come across any pregnancies with coexisting endometrial carcinoma?
I actually haven't, but then interestingly, although we're the regional centre for maternity, the gynae oncology unit is actually in a different part of Birmingham. So that's probably why they haven't come through my practice. But I think with the increased obesity, they are becoming more common. Yeah.
What about patients who've had endometrial cancer? I mean, like I said, we've seen a lot of younger people with endometrial carcinoma. So women are having fertility preservation procedures done for endometrial carcinoma. Have you found any who have had fertility preservation treatment and then subsequently gotten pregnant? If there's anything different in the management of the pregnancy?
Well, I mean, it's a long time since I did gynae-oncology, but I would imagine it's more pre-cancer than cancer, right? If they've had it previously, because they would the management of overt endometrial cancer would usually be hysterectomy, would it not? So it would be women who have had a progesterone coil or something for pre-cancer, and then some like temporary resolution.
Actually, for early stage endometrial carcinoma and the well differentiated ones, we do fertility preserving.
Okay.
We give them high dose progestogens.
Okay.
I mean, majority of them will have either Lynch syndrome or PCOS, so they end up going for fertility management afterwards.
Okay. And they carry their own children after that? No. Okay. No, I've never looked after any of those.
Anybody in the audience? No? But I think your talk was very comprehensive. That's why. No question. All right, so our next presenter, the topic that we're going to talk about next is the management of gestational trophoblastic disease. I mean, this has always been a challenging topic for both when I was in training and for nowadays. It still is a challenging topic, and we always like to refer to the experts, to the experts to help us, guide us in the management of these patients. So that's why our next speaker is coming, Dr. John Coulter, a gynae-oncologist. He's a clinical director of the Irish National Gestational Trophoblastic Disease Centre. He's an executive board member of the European Society in Gestational Trophoblastic Disease, EOTTD, and the International Society, ISSTD. He's a chair of the EOTTD Education Committee and has contributed to establishing the published European and World Management Guidelines in Gestational Trophoblastic Disease, GTD. This one call him TD. He's a co-chair of the IGCS Global Curriculum Committee. We know Dr. John Coulter out here in the Caribbean. He's been instrumental in our gynae-oncology program that we started in Jamaica. He's been one of our mentors through the IGCS, and he's helped mentor a lot of our fellows who have graduated, and he continues to guide us in the management, especially of gestational trophoblastic disease. So I'm pleased to introduce Dr. John Coulter today to speak to us.
The first slide, please. Thank you. And thank you to James for talking to us about cancer in pregnancy. And I'd like to talk about cancer of pregnancy, or potential cancer of pregnancy. This is a disease we know cannot occur unless you are or have been pregnant. Now, 99% of patients will be pregnant or will have a known pregnancy leading to this, but about 1% of patients will never have a known pregnancy, but will be diagnosed with gestational trophoblastic disease sometime in the future. Our incidence in Ireland is about 1 in 325 pregnancies. It was always thought to be about maybe 1 to 2 per 1,000. Now, whether that's because a lot of the women of childbearing age now present much later with their first pregnancy, for many reasons. This disease is known as God's first cancer and man's first cure. We cure almost 99 to 100% of patients with trophoblastic disease, even those with ultra high-risk disease. One of the new innovations in the last 5 years or so, and some of you might see this coming through in pathology reports, has been the new atypical placental site nodule. We always knew that placental site nodules per se were benign, but now the pathologists have found an atypical form of placental site nodule. This has about a 15 to 18% chance of transforming into a malignant form called epithelioid trophoblastic tumor, which is quite chemo-resistant. So it's something that's going to come through more and more in your pathology reports and need to be registered with either a local or regional or national gestational trophoblastic disease service. Trophoblastic disease can follow any gestational event. And as I mentioned, it doesn't necessarily have to be a known gestational event. This is a woman who delivered twins at 35 weeks 2 years ago in Waterford. And she went to her GP with some swelling and bruising around her left eye, which got worse. They thought it might be thrombocytopenia due to postnatal preeclampsia, but it wasn't. This got worse and they sent her into the ER and they did a CT. And up on the left eye, high up, you can see an arrow pointing to a tumor in the left orbit. So they CT'd her brain and there was a left occipital lobe metastatic tumor. You can see the rest of the CT. She has lung mets, she's liver mets, and she's got a very abnormal uterus. So they phoned me because she was only 6 weeks late, and I said, don't do anything. The pathologist, of course, had asked for a biopsy to be done. I said, don't biopsy this. These women can die from hemorrhage if you biopsy, especially brain or liver. Wait for the HCG. But unfortunately, they had gone ahead and had biopsied the liver. Now, thankfully, she was okay, but her HCG came back at 542,000. Diagnosis made without any biopsy. So I phoned the emergency room physician who had asked for the HCG to congratulate him. And I said, how did you know to do a HCG? I was your intern back in the day. She had a FIGO score of 16, which is ultra high-risk disease. And these are the women who were associated with early deaths. When a lot of colleagues went in with high-dose chemotherapy, multi-agent chemotherapy, a number of these women would die from hemorrhage due to tumorolysis. So Michael Seckel and the team in Charing Cross, etc., decided, let's go in with low-dose induction chemotherapy with etoposide and platinum over 3 weeks, and a lot of those early deaths now have been avoided, and that's what we gave this woman. Then went in with multi-agent chemotherapy. She's 2.5 years out and absolutely fine with a normal HCG. So this works, and we now avoid those early deaths. Fast forward, this is hot off the press. Christopher Daly in Jamaica phoned me last week about a case that had presented in Jamaica. This is a woman who was 52, thought she had perimenopausal bleeding, but it was heavy perimenopausal bleeding for about 6 or 8 weeks before she was able to access any care or went for any care. Her ultrasound, you can see on the left-hand side, is typical of a uterus filled with complete mold. By the time she got to the hospital, she had actually miscarried this complete mole herself. This is only last week. So we talk about what we do in other parts of the world and how we get ultrasounds done within days or hours, and we get patients on to treatment, etc., straight away. But this is happening all around the world as well. I'm aware that there is some data from the Caribbean that up to 50% of women diagnosed with molar pregnancy are just on routine histopathology of miscarriages rather than on ultrasound, whereas we have the benefit of very early ultrasound in anyone with bleeding who's got a positive pregnancy test. About 50 years ago, when Ken Bagshaw and Park up in Dundee, the pathologists, were setting up the National Trophoblastic Disease Service in the UK, 1975. At the same time in Ireland, some of you will recognise the SHO's name on the right-hand side from the RCOG. So Patricia and James Fennelly, who was a medical oncologist, wrote a paper in the Irish Medical Journal about trophoblastic disease and its management in Ireland. And at the time, almost half of the women with choriocarcinoma were dying of disease. Late referral, having to send HCG to Sheffield, etc., etc. And the management with chemotherapy was not great at the time. And that, in the Irish Medical Journal, James Fennelly made a plea that GTD would be centralised and these women would be looked after by an expert centre in Ireland 50 years ago, exactly at the time when Ken Bagshaw was setting up Charing Cross. And they celebrated their 50-year anniversary last year. So the first step in setting up something like this is to publish guidelines. Because if you publish guidelines and they're endorsed by the government or they're endorsed by the health service wherever you are, funding should and has to follow if these are endorsed properly. And this is what we did in Ireland back in 2015. And based on that, we were able to get funding and went live in 2017. So what I have now, and what you aspire to in any regional or national centre, is to have clinical nurse specialists who work in the centre, proper secretarial support. We modified the breast cancer database so we didn't have to reinvent the wheel for our database and created our website. So if you just Google Molar Pregnancy Cork or Molar Pregnancy Ireland, we're the first website that comes up. And that website has information for clinicians as well as patients, because these poor patients, not only have they lost their pregnancy, they've now been diagnosed with a disease which in some cases has a 15 to 18% chance of needing chemotherapy. So they need adequate information, and they need it from the right people. A lot of the patients that our clinical nurse specialists talk to have not had very good counselling or information as to what's going on and what the follow-up will be. So giving them ideas like this, you know, what causes the molar pregnancies? Myself and Ray were talking last night, and Ray turned to me and said, you know, this is fascinating. We all hated it, especially when they started getting genetic on us back in the day. You know, so you've got the diandric or a complete molar pregnancy that has both sex chromosomes from dad, and of course, the paternal chromosomes, etc., will code for the placenta. So a very abnormal placenta grows, and that's what causes the problem. And of course, the triploidy then, which is diandric as well in the partial molds, can have a little fetal bit of tissue present, and very often they're just diagnosed at a routine miscarriage or ERPC. So it's very important that these patients know exactly why this potentially happened, and that wasn't necessarily their fault or anything they did wrong. The ultrasonographers who have developed great experience in this are superb, especially at calling the complete molds. 80 to 90% of the time, the good ultrasonographers will get this right. So if that's the case, there is no reason why these women shouldn't be counselled even prior to their ERPC that they're very likely going to have a complete mole diagnosed. So you can talk to them about what the follow-up will be, about how important it is that they have adequate contraception immediately following the ERPC. A few innovations that have occurred over the last number of years. We always thought when we were training that you did not use oxytocics either prior to or during the management at ERPC. We now know that is not the case. There is no significantly increased risk of needing chemotherapy, because I suppose the theory is that if you use an oxytocic on the uterine muscle, it could potentially squeeze trophoblastic cells into the venous sinusoids and either implant in the myometrium or become metastatic. That is not now the case. There is not an increased risk of needing chemotherapy. So you can use misoprostol prior to ERPC, and you can use the oxytocin infusion during the ERPC, which helps a lot, obviously, because we know how terrifying it can be when you're losing a litre or two of blood. And a lot of the time, especially those who are training, tend to stop with the suction curette and compress the uterus. Whereas what we know is that you need to keep going and get the uterus empty as quickly as you can, very often under ultrasound control. I'm always telling the teams, alert the histopathologist that this complete molar tissue is coming down, because we need a rapid report from them. Things can go from very little to lung mets and brain mets within weeks in trophoblastic disease, as you can imagine, it being the quickest growing tumour of all. So it's very important that the pathologist knows that this is coming down and is not going to delay the report for many weeks. The next step should be to register this patient either with a national, regional trophoblastic disease centre, or at least let somebody know who's got expertise in trophoblastic disease that this patient has the diagnosis. It's fine, as I said, for 85% of the complete moles and 99% of the partial moles. They will normalize themselves if you did nothing. But what do you do, and how do you get the help if they need treatment? Because once they plateau or rise, they need chemotherapy, full stop. The Royal College, as we know in the Green Top Guidelines, if you look at the bottom line, this is in black and white for everybody. It's the minimum standard of care that a patient with trophoblastic disease would be registered with an expert centre, full stop. This is the form that we use. This was the Charing Cross form. We just use it ourselves and put a different few bits and pieces. One of the things we insist on is that the patient signs consent, which means she has to come back to the clinic following the diagnosis to have the diagnosis explained to her, rather than just sending a form off and saying somebody will contact you. We insist on written consent from the patient, who also gives us consent to hold her data, her blood, and all her follow-up. And the histopathology report has to come with this document, because sometimes the histopathology is not correct. And we get second opinions very often from our pathologists in Cork. As I said, the patients are really scared. They think they have a cancer instead of their pregnancy. So informing them of what a complete and partial mole is incredibly important. So following registration, our clinical nurse specialists phone every patient and spend about an hour on the phone telling them exactly what has happened, explaining why it's happened, and explaining exactly what the follow-up will be. We send out stickers to the patients. We find out which biochemistry laboratory their HCGs will be going to on a weekly or 2-weekly basis. And we send out stickers, so when the GP or whoever takes their blood, or the early pregnancy unit, that sticker goes on so the laboratory knows she's a GTD patient, and our clinical nurse specialist will be phoning on the day to get the result. When they get the result, they phone the patient with the result, which is very unique. A lot of areas around the world will just send a letter to the patient saying, your HCG was satisfactory, please let's do it again in 2 weeks, send us back in 2 weeks. Which is fine, and that works, but it's the minding of the patient that is always the feedback from our patients. They feel minded by our clinical nurse specialists, and it makes such a difference when they're going through this journey, because they know there's a risk that there may be cancer. One of the recent innovations, which I think is going to help hugely, is that some of the data from Charing Cross that was presented at the World Congress 2 years ago, is that if you normalize your HCG following complete mole within 8 weeks, the risk of recurrence is only 1,200. And if you normalize after 8 weeks, the risk is only 1 in 520. So why would we follow these patients up for 6 months if that risk is so low? So now we've stopped following up these women for 6 months, which makes a huge difference when you're 41 or 42. And the next thing you want to do is try to become pregnant as quickly as you can, despite being told previously you've got to wait 6, 9 months, a year, or whatever. We've now stopped that. For the complete moles, all we ask is that they have one confirmatory HCG a month later, and we've stopped completely once they normalize in partial moles. So that's a new innovation only in the last year or two. So how about those who get into trouble? Well, 15 to 80%, 18% of complete moles and about 1 to 2% of partial moles will get into trouble. So their HCG is either plateaued or risen. They need chemotherapy. So what we do is that I will phone the obstetrician gynecologist who's registered the patient with us and said, I need you to get an urgent CT of abdo-pelvis and chest x-ray. We don't CT the chest because it picks up loads of small metastatic disease sometimes, which they're not part of the fecal staging per se. So we just ask for a chest x-ray. If there's nothing on that, there's nothing in the lungs. If there is something in the lungs, we MRI the brain. And very often I have to say to them, I need to know who the radiologist is, because sometimes they come back to me 3 weeks later, we still haven't had the CT done. The radiologists also need to know the urgency of getting this done ASAP. So once that is done, then I'm the one who will do the score. I'm the one who will work out these 8 things, 4 of which we know already, and the other 4 we don't know yet. The site, size, and number of metastatic disease is important as part of the scoring. So then I will decide whether she is low risk of single agent resistance or high risk of single agent resistance, and then decide which type of chemotherapy she needs. And I'll make personal contact with a medical oncologist. If it's single agent chemotherapy, methotrexate is what we use very often. A lot of medical oncologists locally around the country will be happy to do it. If it's multi-agent chemotherapy, we usually centralize it to Cork, Dublin, or Galway. But interestingly, over the last 10 years, a lot of the registrars in medical oncology worked in Cork, Galway, or Dublin, and now have gone to other centres like Limerick and Waterford, and they have developed experience in managing trophoblastic disease. So now we can have multi-agent chemotherapy given in a lot of different places. We don't just hand the patients over to the medical oncologist. We monitor the HCG during their chemotherapy, because if any escalation needs to be done, we need to be involved in that decision, not the medical oncologist alone. We use the 8-day methotrexate regimen, which is 50 milligrams IM of methotrexate on days 1, 3, 5, 7, and 15 milligrams of calcium folinate on days 2, 4, 6, 8. That would be one of the most common around the world. A lot of the Americans would have used a 2-weekly actinomycin D IV push. Very often patients will say to us, how long is this going to take? And our answer in truth is, as long as it takes. The average would be about 5 or 6 cycles of methotrexate every 2 weeks. But I've had patients that have needed 13, 14 cycles of methotrexate. I was talking to Michael Seckel in Charing Cross, and he said he once treated a woman up to 17 methotrexates. So it's not a case of that if you don't get a good result in 3 or 4, you change to actinomycin D. You just keep going, because ACT D has other myelotoxicities and thinning or losing of the hair, which makes a big difference compared to methotrexate. When I was training, I remember that if your HCG didn't go below 100 on your methotrexate treatment, if it plateaued under 100, you changed to ACT D. If it was over 100, you changed to combination chemotherapy with Emico. Then that went up to 300. And then that went up to 1,000. And now we're at 3,000. So we'll still salvage many patients if their HCG is above 3,000 when they fail methotrexate. And 1/3 of patients will fail methotrexate. But now the new data coming out of Charing Cross is that they're actually going to consider changing to 10,000. So we'll still salvage patients with a HCG of over 10,000 who have failed methotrexate. If Emico fails, we have lots of other things up our sleeves. That includes platinum-based chemotherapy. And now, even for those who are failing chemotherapy, we're using the checkpoint inhibitors like pembrolizumab and getting long-term survivals with those. So things are changing rapidly in trophoblastic disease all of the time. We follow patients up for 2 years after the chemotherapy. Charing Cross follows them up for life. We follow them up for 2 years. Of course, there's going to be a washout of about a year after combination chemotherapy, so we don't allow them to become pregnant. But sometimes after a year, if somebody's 41 or 42, and they say, look, but can I consider becoming pregnant? There's no harm in bending the rules. And I'd say to them, look, our advice is 2 years. But of course, if you're of that age and you've washed out your chemotherapy, the chance of a recurrence after a year is very, very small. That's up to you. Off you go if you wish. Just some of our results. We've had about 1,300 patients registered with us in Ireland since we went live in 2017. 2 to 1 is the ratio of partial moles to complete moles, which would concur with the international data, about 1.7 to 1. We've had about 18 choriocarcinomas, and now the atypical placental site nodule that I mentioned is becoming more and more popular as a report from the pathologists as they see more of it and they diagnose it. We've had 6 already this year of atypical placental site nodules. So that's going to become more common. And as obstetricians, gynecologists, you're going to get these reports back from the pathologist. We also concur with the international data. About 15% of our complete moles needed chemotherapy. 0.5% of our partial moles needed chemotherapy. And one of those was of the consultant cardiac surgeons in the country. No pressure. But thankfully she was cured. But you can imagine how that went down. Because number one, her risk of getting a partial mole was so small. But number two, 0.5% risk of needing chemotherapy. And she was the one. What's also interesting is that only 8 of the 18 choriocarcinomas required chemotherapy. Not all chorios require chemotherapy. Some of these are found as intraplacental choriocarcinomas. We've had a few cases of women who've developed a lung nodule or a liver nodule that's been resected and it's been gestational choriocarcinoma, and we just monitored the HCG and it's come down to normal. So you don't have to always give chemotherapy to chorio unless it's a postnatal choriocarcinoma with metastatic disease. One of the great benefits is looking at genetics of these choriocarcinomas that are resected, because not all of those are gestational. You've got non-gestational choriocarcinomas, like germ cell tumors. So we have the ability of getting the geneticists to find paternal alleles in the tumor to tell us it's gestational chorio, and then we know which type of chemotherapy to use. So innovations in care. There's been a huge discrepancy around the world, as many of you will know, in the management of trophoblastic disease. The Southeast Asians do it completely differently, using different chemotherapy regimes that we would use in Europe and North America, etc. So we've tried to actually get the world together and come up with European and world guidelines. And the first thing we did back in 2020 is that we published our European consensus guidelines, with everyone getting together and saying, these are the minimum standards of care, and this is what everybody is going to use. And I'm not going to go through those, but then subsequently, we had consensus meetings to develop our world guidelines in trophoblastic disease, which we launched 2 years ago at the World Congress in Lyon. We have a monthly cross-border MDT in Europe, so if we've got any very difficult cases, we have friends. We can phone friends, and we have our European multidisciplinary meeting every month, which is very helpful. And one of my SPRs, Aoife Corcoran, is now doing her MD on looking at core outcome set, which has never been done in trophoblastic disease. It's been done in diabetes and pregnancy, and a lot of other diseases, looking at a core outcome set for reporting trophoblastic disease. Management innovations, as I said, the women who tended to die were those with the ultra-high risk disease where chemotherapy went in too strong. And now, as I said, we have induction etoposide platinum, low dose for 3 weeks, and then go in with the higher chemotherapy. I mentioned pembrolizumab, which we've used. We don't have good fertility or pregnancy outcome data following pembrolizumab yet, so we don't know how safe it is to give pembro, cure the woman, but then we don't know what our pregnancy outcomes or fertility are going to be like just yet. We're looking at home capillary blood sampling so that women don't have to come to the GP or the early pregnancy unit, because a lot of them complain about the fact that they have to organise childcare or they have to leave work to come in having their weekly or 2 weekly blood tests. So we're looking at piloting circulating DNA at home, or capillary blood sampling, and also DNA genotyping as well to try to distinguish the gestational from non-gestational disease. And we're looking in Ireland now at centralising our HCG monitoring to our particular laboratory in Cork, which will have great advantages. Number one, we know exactly which platform it's on, because beta HCG is the pregnancy HCG. HCG in trophoblastic disease has 5 different isoforms, which need to be monitored on the correct biochemical platform that we have in Cork. Also, our clinical nurse specialists, it'll save them probably about 2 or 3 hours a day phoning laboratories around the country looking for biochem results. So they will have it straight away on the computer. Voluntary registration is the norm around the world. The only country in Europe that has mandatory registration is Sweden and the team in Karolinska. Everywhere else, it's voluntary. So we have to keep encouraging registration. And thankfully, our faculty of pathologists in Ireland decided that they would recommend registration with our National G2D Centre, and they put that on the end of every report. So there's no reason why our colleagues shouldn't adhere to the clinical guidelines that we produce in the country and register the patients with it. It's been a challenge, but it's improved year on year on year. I'm never shy about talking or inviting myself to meetings, as you can imagine, to try to spread the word. But patients are also very savvy. They're on social media. They're phoning our nurse specialists saying, why am I not being managed by your team? We've heard from others. And the answer, because you haven't been registered by your clinician. So they go back to their clinician and insist that the clinician register with us. Unexpected elevated HCG. Now, how often do we get a phone call from an orthopedic surgeon or somebody to say that I'm about to do an arthroscopy and this woman's pregnancy test is positive? What the hell do I do? Then you measure a serum HCG, and the question is, where is this coming from? Well, there are 7 reasons why your HCG would be elevated as a woman. You're either pregnant, you have trophoblastic disease, you have a HCG-producing tumor. You can have a false positive, which is because of human and anti-mouse antibodies. If you're perimenopausal, your amino acid sequences with luteinizing hormone is 80% analogous. So if you're perimenopausal, you can have a pituitary source of HCG. Usually it's under 100, but it can persist. Some bodybuilders and some women with Munchausen's take HCG. You can take it intranasally as a bodybuilder. Okay, so that could be a reason. And one of the other reasons is that, and I'll show you the algorithm, familial, which is very rare. So this is an algorithm we've put on our world guidelines map to help diagnose the reason for an elevated HCG in someone that isn't, especially isn't pregnant. Okay, so there's a step ladder of going how you would actually try to isolate it. And having gone through that, we've had about 3 or 4 patients over the years that we've settled on the fact that this must be gestational trophoblastic disease because everything else is negative. And we've actually treated them with chemotherapy and they've responded to chemotherapy, which means it must have been that. But I think this is a very helpful algorithm. So in conclusion, there are some new practical tips and hints that I've mentioned that we put into our guidelines, especially about the early management with regard to the ERPC, with regard to following up the complete moles, that they don't have to wait their 6 months anymore. We still cure, thankfully, 98 to 100% of these women. So it's very important that they're managed by a team who've developed experience and expertise. It's a minimum standard of care that these women will be looked after by specialists who have developed regional or national centres. And as I said, global centralisation and European centralisation and the help to all of our communities is the aim of what we're trying to do at EOTTD and ISTD. Delighted for your attention. Thank you.
Thank you so much, Dr. Coulter, on giving us elucidation on that topic. I think the important thing there is consultation, consultation, consultation. Dr. Chatrani?
Hey,
you have a question?
Vikash Chatrani, everybody met me already, from Barbados. The question for you, you made an interesting comment. Do not biopsy. That's what you told the resident in A&E. Now, obviously, we work in a setting where we don't see too many of these, and our oncologists do not take referrals unless they have a histology result. So while you were presenting, I messaged one of the oncologists here, and she says, well, apparently so, you don't need to do a biopsy. But we've had a standard where patient comes in, we have a high HCG, they still want tissue. They have some pathologists in the audience here today. Does the histology make a difference in your treatment guidelines, or is it just treating HCG?
Well, the first thing is education, education, education. So if the HCG is going to be 500,000 and she's got a CT looking like that, the diagnosis should be obvious. We don't go looking for tissue. Whether it's choriocarcinoma or whether it's metastatic molar pregnancy, it doesn't really matter. Her HCG, I mean, if she'll be given chemotherapy for something like that, so it's her HCG that matters, not the pathology. If we've got someone who's had a complete molar pregnancy evacuated and her HCG plateaus or rises and goes up, are we biopsying the tumor that we see on CT there? No, we're not. Doesn't matter to us whether this is persistent and it comes back as complete molar or whether they're saying this is choriocarcinoma. It's all due to the HCG.
The pathologists and the oncologists are in here, so I'm just making sure that they heard that, because the clinical dilemma falls on us on the ground. And when we get the intervention, I remember the last patient we had like this that passed. She was waiting for a biopsy, but one of her liver mets ruptured and she basically bled down. It was unrecognized.
Yeah,
so
I've given
to hear 100% cure rate, to promise that.
Yeah, some of the groups I've invited myself to talks with have been the radiologists. Both in Cork and St. Vincent and Dublin, I gave a talk to them because up to then, very often they see a CT like that. Of course, the report is going to say, suggest biopsy. And now they've said to me that what they will consider is ringing the team, calling the team and saying, do you know her HCG before we recommend the biopsy?
But even Matthew had mentioned when you were presenting, if they have resistant to treatment and the HCG plateaus or doesn't decline, he said, I would have probably done another DNC, to get tissue. Because we believe so much from the oncologist that tissue is essential. I'm just throwing it out there because obviously this is the anomaly, right? You're giving chemo without tissue diagnosis. But thank you.
That's why it's such a different disease.
So maybe we have to look at a society now as, because of the rarity of the diagnosis of these sort of tumors in the region, maybe coming together and having a little help from you guys with your 3 nurses and your 20-hour hotline that we can.
Yeah, well, I mean, the colleagues in the Caribbean who I've been in contact with and done MDTs with, etc., all know. They have my phone number. And we're delighted to get calls, requests to try to help anytime.
Thank you.
Philip Hobson, Birmingham. John, great talk. I was caught when you said about giving oxytocin. Firstly, I felt quite guilty because I'd always given it, but it made me think about a question about any other tips and tricks. I've always told people to do a cervical block in the same way you do with colposcopy, but you then made me feel, am I guilty? Is that bad advice, or what are your tips for doing the ERPC?
I think the biggest tip is do it under ultrasound control. I think helps a lot. Make sure the senior obstetrician is doing it. I think or as senior as possible is very important, rather than letting one of the registrars do it. And I think the other tip is not to stop. It can be terrifying to seeing all the blood coming out, and you'll see it come down under ultrasound control. I've never used a cervical block, but my misoprostol priming has helped a lot. It's a lot easier to get in, and of course you're worried about perforating the uterus, with the suction curette, and that's the way we do it: priming and the oxytocin infusion and ultrasound control. The biggest curette you have, yeah, suction curette, yeah.
I think we should thank John and all the Johns of the world who've taken an interest in trophoblastic disease, because it is not a disease of internal medicine. They do not understand the biology of the disease. You have to have one person who understands the biology of the disease, and today's, with the transmission of information, so easy on any social media and everything else, everything can be handled by probably 10 people, in terms of information. And you just have to understand that and try to convince the internal medical people that it belongs in the hands of gynecologists. It doesn't have to be a GYN oncologist, absolutely not, because they're not really interested in this type of thing. It has to be a gynecologist who is interested and knows the biology of the disease process. Thank you very much.
Richard Smith, obstetrician and fetal medicine specialist from Norwich. Thanks, John. A great talk. I had a referral a couple of months ago from one of our referring hospitals, 16 weeks with a normal fetus and a coexisting mole. Sonographer thought the placenta looked a bit funny at 12 weeks, but not funny enough to refer. And she opted to interrupt the pregnancy. And I wondered whether that would be an option in countries where pregnancy interruption is restricted, and if you've got any experience of those pregnancies that have continued.
Yeah, we've had 9 coexistent complete moles and normal pregnancies as twinning. You double the risk of everything. You double the risk of preeclampsia, you double the risk of antenatal hemorrhage, you double the risk of persistent disease afterwards needing chemotherapy. It's about 30%. But we've had live babies born. One of the difficulties the obstetricians have sometimes is that the uterus grows so big that there's a worry it's going to rupture, which it doesn't. So if you can keep your nerve, and this woman hasn't got significant preeclampsia or antepartum hemorrhage before 25, 26, 27 weeks, then you're on a winner. And even if you need to deliver the baby at 28 weeks, we know our neonatal colleagues are so good, and that less of these babies have any disability as they go through schooling, etc. If you can keep your nerve, the outcome is actually very good for these. So, of course, it's a choice. All of the women we've had have continued their pregnancy with support from us to the obstetricians, saying, hold on, is she doing okay? Blood pressure, urine, etc., etc. Going, now, usually there'll be a bailout at around maybe 26, 27 weeks. That's not uncommon. But it is possible. It doesn't have to be terminated.
Thank
and
you.
And there's good evidence for that.
John, fantastic talk. Thank you very much. I'm Caroline Overton from Bristol. My interest was early pregnancy, and I just wanted to draw attention to now with so many women miscarrying without any surgical or medical intervention, that a reminder to do a urine pregnancy test for any woman who's had a miscarriage, so that you can pick up those women who might have a molar pregnancy and it hasn't been spotted on the ultrasound.
Yeah, the risk of missing a woman who's had a complete molar pregnancy who should have required chemotherapy is 1 in 3,400.
Okay.
So
Good-
even if
good
so,
statistic
yeah, and I
to
think a lot of the early pregnancy units have as part of their protocol that they come back or do a pregnancy test anyway if
Yes.
they've miscarried at home or if they've had a therapeutic abortion at home, etc. But even if they come back late, Caroline, that's one of the beauties of the disease.
Yes.
We'll cure them very likely. We'll
Well,
cure them.
thank you.
Yeah.
And thank you for all your work on this.
Thank you.
Sorry, last one. You had mentioned something about with your discussion with colleagues in the region, 50% of us don't send off histology for incomplete miscarriages or don't get scans. What was the
No,
comment?
I think the data was that 50% of molar pregnancies are diagnosed on routine histopathology of miscarriages.
Ah.
So they haven't had ultrasounds to
Okay.
diagnose the potential, not diagnosed.
And how does that compare? Because we do, yes, in the hospital setting, when we do it incomplete and we evacuate, we send it for histology. But otherwise, you may not see that in the private sector in Jamaica and elsewhere. Am I correct, Matthew, in saying that?
Yeah, I agree with you there. Because we have more ultrasounds in the private sector.
Right, okay.
Thanks again, Mr. Speaker. So, our next presenter, our next topic, slight change now, will be on personalized surgical staging in endometrial cancer, the role of sentinel lymph nodes and molecular profiling. Dr. Ian Harley, who is well known to most people here. So I'm supposed to be doing the official, read the official biostats, and I'll be good and read that first, and then we'll talk about the real Dr. Harley. So, Dr. Harley is a consultant gynecological oncologist at the Northern Ireland Regional Cancer Centre. He graduated from the Queen's University of Belfast in 1993 and completed his gynae-oncology fellowship at the University of Toronto in 2006. Dr. Harley is an honorary lecturer at the Cancer Research Centre, Queen's University, Belfast, with an interest in high-grade serous cancer, biomarkers, and hereditary cancer genetics. Surgically, his interests include minimal access surgery in gynecological malignancies and prevention. Paradoxically, he's also one of the lead cytoreduction surgeons with minimal access working at the Cancer Center. So that's his official biostat. So, Dr. Harley has Caribbean and Irish heritage. So you know what that means to those two regions. So his outside interests include sailing. That's true. We've had consultations on his sailboat. We've had exam consultations on his sailboat. Skiing. I can't really speak to that one. The triathlon, yes. Music, medical history, and perhaps his biggest one, spending time with family and friends. So Dr. Harley has been around, from the inception of this Caribbean Gynae Cancer Society and involved in our gynae oncology program in Jamaica from inception. And the spending time with family and friends, I have come to know him on both personally. We went to visit him in Northern Ireland to stay at his center. And both in the Caribbean, in Jamaica and Belfast, I've been introduced to a lot of pubs where we spend time with family and friends. And I'm sure he's engaging in those activities out here in Barbados. But for now, on to serious things. He's come to speak to us today, and I ask you to give him a warm welcome.
Just to let you know, I am standing. I'm not kneeling. Can you bring up the first slide there? Thank you, Matthew, for those kind introductory words. But I have had no pum runch since I arrived on the island. But lots of rum punch. I'd also like to thank Vikash for allowing us to integrate the Gynae Club of Great Britain and Ireland into your meeting. And we're absolutely all delighted to be here on this fabulous island. And we've had a great time to date. And we know we're going to continue to have a great time. And it's lovely to be with you, the Caribbean Gynae Cancer Society, here in Barbados. So I'm going to talk about personalizing surgical staging in endometrial cancer, the role of sentinel lymph nodes, and molecular profiling. I have no disclosures, except that we built the Titanic in Belfast, and it did sink. So, and some of us are going sailing after this meeting, and I hope we stay on the right side of the ocean, on the upper side. I'm going to give you just an overview, introduction, risk stratification of endometrial cancer, what the molecular profiling involves, surgical staging for endometrial cancer. It's actually got very complicated, but I'm going to try and simplify it. What we do with the sentinel lymph nodes and the omentum, who we decide gets what surgical intervention, and really we're using some sort of algorithm where we personalize surgical staging. But I wanted to tell you who we are first. The Gynecological Club of Great Britain and Ireland. We were founded in 1929, and we're known as the club amongst members of the GYN Club or the Gynae Club. So we are. It's now in 2026, calling it the club or the Gynae Club doesn't have quite the same ring to it, especially to the taxman. When you're submitting your tax returns, they think you're just on a jolly. There's no way we would just be coming here on a jolly. It's a serious bit of education. And you may see some of us wearing the club tie, which has the walrus on it. So the walrus was introduced as the logo for the club in 1936 or shortly after 1936. And I know Rona knows a lot about this as well, because she actually gave a talk on it. But the logo comes from the baculum of the walrus. So the male walrus has a bone in its penis. And in 1936, the American Gynae Society gave the Gynae Club a baculum as our, gavel, as our gavel. So that's where the logo came from. We started off with the bone of the penis, interestingly. So this actually is one of the founding members. This is C.H.G. McAfee, who was one of the first Gynae Club members in 1929 at the inaugural meeting. And I can see Shirley Jagru in the audience there recognising the name, because CHG McAfee came from Belfast. And he may be known to some of you who are obstetricians because he revolutionised the management of placenta previa across the world. He's certainly very well known in Belfast, but he was globally known at that stage of his career for his management of placental previa. And the little cartoon, I actually have the original of that, which I found in my father's sort of effects after my father passed away. And McAfee's management of placenta previa, he used to say, just sit on them, just sit on them. So somebody's drawn a picture of him sitting on a pregnant tummy. You may, though, be more familiar with this guy, who also was a member of the Gynae Club, Victor Bonney, and I can see Denny nodding his head there. So Victor Bonney, born in 1872, he was a Gynae Club member made it in 1937. And the other thing you may or may not know about Victor Bonney, he was very opposed to the formation of the Royal College of Obstetricians and Gynecologists, because he was a member of the Royal College of Surgeons. So he objected to the formation of the RCOG. When he was a member of the Gynae Visiting Society, which is one of our rival clubs, but they're no fun. They're no fun. They're all pretty boring. So he left the GVS because the GVS were the people really that set up the Royal College in London in 1935, 36 or so. And when was it? 29. So he left the GVS because he didn't approve of the formation of the college, but we were fortunate then to sweep him up into the Gynae Club. All right, so that's enough about us, and that's who we are. So endometrial cancer is probably the commonest gynecological malignancy in the Western world or the developed world, whereas in some countries or less developed countries it's cervical cancer. But the incidence in Barbados is very high. It's 24 per 100,000. And look at that opposed to the UK or New Zealand. It's 14 per 100,000, and the USA, it's 19 per 100,000. And it's all related, obviously, to, it's already mentioned today, endocrine, diabetes, overweight, obesity, etc. And that's probably why it's so high in Barbados. Barbados has one of the highest incidence of diabetes in the world, so it does. So the map is tiny there. You can just about see Barbados on the east side of the Caribbean there, but a very high incidence of endometrial cancer. So why do we surgically stage these patients? Well, you can see from this that a grade 3 endometrial cancer with some invasive disease into the myometrium has a 34% risk of having pelvic lymph node metastases. So for the adjuvant treatment, we want to know who has lymph node involvement and who doesn't have lymph node involvement, to see what adjuvant treatment to give them to improve survival by reducing recurrence rates. So it can all get quite complicated, and the next couple of slides will show you how complicated sometimes the management of endometrial cancer has been in the past and is still evolving as quite complicated. So there's now, if you just look at actually the bottom, there's three main risk groups. There's the low to low intermediate group, the high intermediate risk group, and then the high risk group. And it depends. The main features that make you high risk are the tumor grade, whether you've got lymphovascular space invasion, and how deeply invasive the tumor is in the myometrium, and obviously if you've got a higher stage as well. So this is purposely another complicated diagram. Don't look at it, because this is in the ESGO guidelines with regards molecular testing. But as I know my colleagues in the Gynae Club, you got to make it simple. So this is it simplified. So the molecular testing is on the diagnostic endometrial biopsy, and they can do this pretty quickly just with immunohistochemistry, looking at mismatch repair genes, and also for p53. So using immunohistochemistry, they can tell whether there's a mismatch repair dysfunction or whether there's a mutation from p53 without actually doing any mutational analysis. On the other side there, you see the poly mutation. That actually requires the sample, the tissue to be sent for next generation sequencing, and then they'll do an analysis of pol or for poly mutation. So if you have a poly mutation, again, it's color-coded for the Gynae Club. Green's good. So if you have a poly mutation, that's actually a favorable diagnosis. So it is. So you wouldn't think that a poly mutation, or sorry, a mutation was a good thing, but in this case, it is. If you're MMR deficient, that's increasing your risk. There's what they call no specific molecular profile. So that means they've not detected any poly mutation, and that you have normal mismatch repair in p53. So that's also a high risk or an intermediate risk. And then the worst risk is, or the highest risk is if you have a p53 abnormality. They've further subclassified the non-specific molecular profile to those that are ER positive, which again takes you towards the right, higher risk. And then if you're ER positive, you go towards the left, towards the green side, which is more favorable. So this again is how confusing endometrial cancer can be, because these are the different staging systems that have been used over the years, and the most recent is 2023. We don't use the 2023 classification because it's too confusing at the moment. Now we do use the molecular profiling that for delivering the adjuvant treatment, but we're going to potentially use it more and more, as you'll see in later slides, for stratifying and in an algorithm for sentinel lymph nodes. So we're still using the FIGO 2009 classification. So confused, it's very confusing. So again, to make it pretty simple, the new 2023 system uses FIGO staging. It's really applied to stage 1 and 2, and there's 2 molecular defined stages. So if you have a POL-E mutation of any stage 1 or 2, you're downstaged because of the favorable outcome, and you're downstaged to what is known as a 1A-M, which means 1A mutation of POL-E, and you're referred to as a POL-E mutant. So that's a favorable prognosis. And then if you have P53, any stage, or P53 mutation or immunohistochemistry, it's abnormal P53. With any stage 1 or 2, you're upstaged and you become a stage 2C M P53. So you've got a mutation. So those are the only 2 things that are really worth picking out of the new system, but it can be very confusing. So what does the molecular testing actually imply? It does change your risk of nodal metastases. So if you have a POL-E mutation, you've only got an approximately 4% risk of the tumor metastasizing to the nodes. So you're pretty low risk. If you're mismatch repair deficient, you've got a 13% chance of pelvic lymph nodes or lymph node metastases. And then if you're P53, which is your highest risk classification subgroup, you have a 20% risk of developing nodal or having nodal metastases. And then if we look at the non-specific molecular profile, if you're ER negative, that's a higher risk group, and you have a 10 to 15% chance. So you can see why it shifts the patients to the right. And then the ER positive ones, they've similar risk profile to the POL-E mutants. So surgery, and I'm not going to talk about the adjuvant treatment because it's way beyond my intellectual property. the surgery in endometrial cancer is pretty straightforward. It's surgical staging with a hysterectomy, bilateral salpingo-oophorectomy. I've said plus or minus sentinel lymph nodes. The current ESGO guidelines are that all endometrial cancers should get sentinel lymph nodes. But if they don't map for a sentinel lymph node, then they should get a bilateral pelvic lymph node dissection. And the problem with that is it carries a significant morbidity for some patients. And then some patients will get an omentectomy. And again, omentectomy is not without its morbidity as well. So you can be selective on who gets an omentectomy based on histology grade and molecular profiling. So can we reduce the surgical morbidity? Well, we tend to do minimal access surgery on all the patients that we operate on rather than open. And we have, rather than doing full lymph node dissections as we did for a long, long time, including paraortic lymph nodes on a selected high-grade patients, we now almost exclusively attempt sentinel lymph node biopsy. I never give a surgical talk without putting this up. When I was Denny's fellow in Toronto, he used to start any lecture or any tutorial by drawing this diagram. So some of you have seen this before. I call this the dipetrillogram. So Denny taught me so much with regards surgical decision making, and as he said, he used to say, you can teach a monkey to operate, but you can't teach them to make the decisions that they need to make during the surgery. And so this just really reflects that we're trying to achieve uncomplicated success and really try to avoid complicated failures. So who gets an infracolic omentectomy in stage 1 and 2, which are the main ones that you would do a biopsy or an infracolic omentectomy on. If they're a more advanced stage, a 3 or a 4, you're talking about cytoreductive procedures, which would include your omentectomy. But stage 1 and 2, we can do most of those procedures laparoscopically. So it's the serous endometrial cancers, the carcinosarcomas, and the undifferentiated carcinomas, and potentially those with P53 mutations of any grade. But the sentinel lymph nodes, you're probably all familiar with sentinel lymph node mapping in endometrial cancer. We use indocyanine green, and we inject that into the cervix. There's other protocols that inject it into the fundus of the uterus, but most people now just inject the cervix at the start of the operation, and then we have infrared sensitive cameras that can pick up the green dye. And here on the left, you can see the dye actually going along the lymph channels. That's the right pelvic side wall with the iliac vessels and the ureter there, etc. And then the lymph node that you get basically a hot lymph node, and you can take it out, and you can use the different. There's different modalities. I think Bill showed the different modalities of your ICG or you were looking for perfusion. You can have the black and white mode. There's a heat map, etc. And it's revolutionized what we do. The other thing we use ICG for is in cervical cancer. We'll use it. Currently, our guidelines are that the patients with cervical cancer get a full pelvic lymphadenectomy at the time of their radical hysterectomy, which is now done by an open procedure following the LAC trial. But we use sentinel lymph node biopsy to make sure when we're doing the pelvic lymph node dissection that we have included the sentinel lymph node in that dissection, because your sentinel lymph node can be outside of your actual surgical field, can be above the pelvic brim, etc. So it's a useful technology for that. So where does molecular testing come in with sentinel lymph nodes? And it's really with the failure to map. So 25% of sentinel lymph node mapping, it'll either be just unilateral, so only one side will map and the other side fails to map, or you get no mapping at all. So that's quite a significant number. And that can be due for various reasons. One is obesity, increases your risk of failure to map, advanced stage or non-endometrioid histologies. So the very patients we want to use sentinel lymph node mapping on would be the high-grade non-endometrioid histologies such as the serous carcinomas. So you want the mapping, but they have a higher failure rate. If there's extensive LVSI, that's self-explanatory. So if the lymph channels are blocked with disease, you're not going to get as much ICG dye going up the channels to the lymph nodes. And if there's grossly positive lymph nodes, it's relatively contraindicated to do the ICG testing if you know ahead of time. If they're over 65 years of age, you've also got a higher failure to map. I'm not too sure why that is. It's probably because of the way our tissues develop with age, and our lymph channels maybe aren't as productive or as patent. But one of the biggest reasons actually is the technician. So not injecting the dye properly. We inject it at 3 o'clock and 9 o'clock. You put 1 mil of ICG dye superficially and 1 mil deep, and then you're ready to go. So what we're trying to do actually ourselves in Belfast is develop, use the molecular testing for trying to strategize which patients who have a failure to map you still need to do the full lymph node dissection on, or which ones you can avoid. So as I've already said, if you've your sentinel lymph node testing, your molecular testing done, and it's very important that the molecular testing is done on the diagnostic specimen, so the papel biopsy or the DNC. You do your molecular testing so you have that information when you go into surgery. And it's probably the POLE mutation testing that is the slowest with next generation sequencing. It takes it's about 4 weeks, and our operating waiting list is about 4 weeks. So some patients we don't always have the test available, but we're going to try and speed the POLE mutation testing up. So basically, if you just look at that algorithm, if you've got a POLE mutation and you have a failure to map, you don't really need to do a full lymph node dissection and all the morbidity associated with it. But if you have those other molecular abnormalities, particularly the P53, you'd probably want to do a full lymph node dissection. And I mean, you take other things in as well. We do MRI scans on all our patients so that we know the radiological staging or the MRI staging, and then we also know the pathological grade. So we take all those factors into account, grade, MRI stage, and the molecular profile, and then we can strategize intraoperatively if we fail to map. So it's very useful. So in conclusion, FIGO staging can be pretty confusing at the moment. I think there's going to be a sort of settling in period because some institutions are using the 2023 staging. Some aren't. The pathologists, some pathologists will quote the stage as per 2009. Some will include it as the 2023. So it starts to get a bit confusing. But it's very important for the adjuvant treatment that the radiation oncologists or the clinical oncologists know all these bits of the jigsaw so that they can give the most appropriate adjuvant treatment, in particular immunotherapy, which is used to treat endometrial cancers now, but specifically ones with a particular molecular profile. And the ESGO guidelines recommend sentinel lymph nodes in all endometrial cancers. I was talking to Vishal there to see what guidelines they use. I think you're using the NCI or NCC guidelines, and they don't necessarily recommend doing sentinel lymph nodes on all endometrial cancers, but I think it's definitely coming because it is of benefit. But it's It's, as I said before, it's what to do with the 25% who don't map properly to avoid the unnecessary morbidity. There is a 3 to 13% false negative rate recorded, and it is also very important when you're doing sentinel lymph nodes that you monitor your own monitor your own false negative rate so that you know what that is, and it's basically quality control. So thank you very much. And any questions?
Thank you so much, Ian. Questions?
Barbados, Medonk. So, very good presentation. Thank you for that. I just wanted to highlight a problem we have in the region is that polymutation is not standard. We can't get that locally. And when I've tried to request it as an individual test, most of the labs we send to overseas, we have to do a full NGS panel, which is upwards of $1,500 US. So it's not as accessible. MMR, we can get that more, it's more readily available, but we don't always have all the mutations, and we always don't have the lymph node status at the time. So I know you mentioned, you have one or the other, ideally both, but in situations where we have none, planning adjuvant treatment, as you can imagine, becomes very difficult. So in resource-limited settings like this, what approach would you recommend for the adjuvant or handling of that?
I think you probably base that on the grade and the staging. Just the way we used to do it. I don't think, unless you've got the full gambit of molecular profiling, it's very hard to plan your adjuvant treatment.
Are you able in the UK, in Ireland, sorry, to get the polymutation separately without running a full panel, or is this on NGS?
Yes, we can. Yeah. Okay. They do run a separate panel in addition, but the poly one is the priority.
Okay, so I guess we'd probably have to engage with our pathologists more to see how we could get that. Thank you very much again.
No, thank you.
Good afternoon, Saida Bo from the Bahamas. So you mentioned in doing your ICG, checking your own false negative rate. So would you suggest in your first couple cases actually doing sentinel lymph nodes and then a full lymphadenectomy to see before you just rely on doing the sentinel lymph nodes?
Yeah, because it does take a wee bit of time to set that sort of protocol up, and that's what we did as well. We started off by doing the full lymph node dissection, and then we were trying to establish what our false negative rate was.
Okay, thank you.
Uh-oh.
Marcus Bernardini.
It's never going to be an easy question.
So I think we all feel that sentinel lymph node advancements has really improved the morbidity of patients, and it's been a lot of positives. I guess one of the potential negatives has been sort of the death of the periodic lymphadenectomy, which used to be a fairly standard thing that we would do, and now it's a rare thing. I guess I'm just wondering how you manage that locally, and from a training perspective for trainees, how does that fit into the whole equation?
That's a very good question, very true, because I can't really remember the last time I did a full, periodic lymphadenectomy laparoscopically for endometrial cancer. What we do, our current protocol, which doesn't include the molecular stuff, or this protocol, we're going to introduce the molecular profiling to manage patients that fail to map. But our current protocol, if they fail to map, is that they get a full lymph node dissection in the pelvis and up to the IMA. So they do. But we don't. We used to go all the way to the renals, but I think actually we've de-skilled ourselves is what we've done, as you said, because of sentinel lymph nodes. And you don't want to be doing all the way up to the renals now if you've not been doing them every week. But good question. I knew it would be a tough one. Just if anybody doesn't know Marcus, I always introduce Marcus. Denny, you'll know this as well. Marcus is the chief of gynae oncology in Toronto, and Marcus and I were fellows together. But Denny, you know that if I'd stayed in Toronto, I'd be the chief, and not Marcus. Bill?
Just to take on, we started Sentinels quite a long time ago, and I know we spoke about this a good number of years ago when you started, that if you're doing the dissection, just a surgical tip, don't dissect when you have the green filter on, because you can really damage the ureter. Like if you're trying to decrease surgical morbidity, anytime you use the filter, the green filter, to identify what you think is the node, and then flip back to the normal site.
Yeah.
Otherwise, ureteric images are significantly raised. And the second thing is the pathology. We had a change in our pathologist a good number of years ago. I never assume that the pathologist knows that this is a sentinel node and the dissection is ultrasection, not just a quick H&E, and therefore you're not actually assessing the node properly. So we had one or two cases where we actually had to ask, was this analysed as a sentinel node? I said, no one told me. So unless it's your own pathologist and who knows exactly as part of your team, you can grossly under stage the patient and miss.
Got to be nodes have got to be ultra staged. Good point you made. Actually, we in Belfast we learnt our sentinel lymph node a technique from the guys in Dublin and girls. We went down to Dublin, and Bill's dead right there. So our protocol for doing it surgically is you identify all the anatomy first before you switch the lights on. But there's now, I don't know if anybody here uses it for identifying the ureters in endometriosis and stuff like that. Absolutely brilliant. I was watching some of our endometriosis surgeons, and they put a ureteric catheter in and inject 5 mils of ICG up both each ureter, and then they switch the light on, doing it laparoscopically, and all you see is 2 green strips running down with the endometriosis, or not with the ureters, and it's brilliant. So the problem there then is if you use sentinel lymph nodes biopsy as well as the ureter, then you don't know what's what. But there's new dyes coming in, and the new dyes have different color. So there's going to be a blue, and I think the other one's red. But you should try it. If you've never tried it, try it. It's unbelievable how good it is for identifying the ureters in really difficult cases. Yep.
Hi, great presentation. So in a resource-limited setting, which lots of us practice in, if I'm lobbying the government to introduce IHC, should I push for POLI or should I push for MMRP 53? What would you recommend?
I think I would go for MMRP 53 because it's identifying your really high-risk patients. So it is. And all it's not, by not doing POLI, you're not identifying the low risk, but you want to identify the high risk, don't you?
Thank you.
Thank you again, Ian, for a wonderful presentation. Oh, Ian, sorry, I forgot. My slip. Yeah. You're going to pay for your sins, sorry.
You're going to pay for your sins. That's what he said. So, you're here today, partly, and majority actually, because of this gentleman. 1 year ago, he approached me and he asked, I have a group of consultant OBGYNs, specialists in their respective fields, and they're planning a golf trip to Barbados. And they want to make it a tax write-off. So can you arrange an academic session for them so that we can say that we're coming here to get some points and teach and enlighten? And we can write it off as a business expense or a hospital expense. Probably the other way around. But no, Ian has been with us from the very beginning, from inception, when the Caribbean Gynecological Cancer Society became registered. He's been influential in training our fellows. We've had fellows actually go to Ireland. 1, 2, 3, 3 of us? 4? And this is even during COVID, right? So that's to show you how far back. And he's on our group chat for the CGCS. He partakes. As you said, Matthew knows him because he's been on his yacht with Zoom sessions, family running around. So we didn't want him to come all the way here to Barbados. without recognizing the efforts, the WhatsApps that he sent me, the emails. You can respond when you can, or now, that would be better, when you want the food choices for the restaurant. Him and Heather have been coordinating all of this. I know all your spouses are on the golf course or at the beach enjoying, and you've been suffering here today. And we appreciate the efforts that you've made, and we want to just give Ian a small token on behalf of CGCS and him as the chair of the Gynecological Club of Great Britain and Ireland for your participation. I invited Vishal to come up here because Vishal was one of the first fellows. Vishal Bahal from Trinidad, consultant gynae oncologist, one of the first fellows to go to Ireland. And he has a lot more personal things to say about his time with Ian. We thought you'd be happy to hear about these things. So I welcome Vishal.
Hi. So, as Vikash would have mentioned, so I was did my fellowship in Ireland, Northern Ireland, in 2015 and 2016. Now, one thing I would say is that it was a life-changing experience. It took a lot to go to Ireland. I went there alone for the 2 years, left my family back home. But I must say that, you know, the hospitality was unbelievable. And the first person I met before I left, actually, for Northern Ireland was Ian. I met him in Barbados for the first time. And then we continued our relationship in Belfast. And Ian is a person, not only professionally, but socially, but he treated me not like a friend, or I'm probably too old to be a son, but a nephew. You're too young. But he actually took me out to help me find a place. He signed his name to my apartment in order to get a place. So it was, he really went out of his way. And then professionally, I learned a lot from him. And then raised in the audience, I operated with both of them on a Thursday. And it was unbelievable in terms of just learning my surgical skills, as well as he showed me the parallelogram very early on, and the importance of decision making during your management of patients. And even as a fellow, when you need that motivation, you need that reinforcement if you have a complication, he's always there for you together with the other guys there. So Ian, you know, from the bottom of my heart, you really, you know, inspired me, changed my life. And by, you know, teaching me all that you have, I have translated those skills back to Trinidad. And you'd be happy to know that, you know, by extension, you're helping a lot of women in Trinidad and by extension in the Caribbean. So thanks a lot.
I think I'm still paying the rent for your apartment. I think it's still coming out of my account.
So I actually thought Vishal would come up here and talk about how his liver took a hit when he went to Northern Ireland. But I guess he'll leave that one for later. So, as a token of our appreciation, I'm giving him some extra luggage to carry back. I'm going to show you what it is. For those who don't know, this is the shape of Barbados. And the wood that is used to make up this clock is from the mahogany tree. This tree takes hundreds of years to grow. There is a company in Barbados that anytime one of these trees fall, they use the wood from it and they make these invaluable pieces. So I'm hoping that Ian will put it up. Every time he looks at it, he remembers Barbados when it's cold outside, the shape of Barbados. He has a good heritage here. Come, let's get a picture with Vishal and Matthew, the Vice President of Ian, accepting this on behalf of your society.
So we have one more talk left before lunch. And we're going to talk on an old foe, ovarian cancer. So the talk will be the secondary site reduction in ovarian cancer. Don't remove the patient and leave the disease behind. Dr. Marcus Bernardini. That's pronounced right? I'll just introduce. It's a problem with technology. Disappears sometimes. All right, Dr. Bernardini is a graduate of Western University. He did his residency at the University of Toronto, as we heard before. During that period, Dr. Bernardini obtained a master's degree in laboratory and pathobiology, which was followed by a combined fellowship in gynae oncology at the University of Toronto and Duke University Medical Center. He's currently the head of the division of gynae oncology at the University Health Network and Sinai Health Systems. Dr. Bernardine is an associate professor at the University of Toronto. He leads the UHN Gynecological Robotic Surgery Program and is the director of the Women's College Prevent Ovarian Cancer Program. His research interests include improving outcomes for women with uterine and ovarian cancer. This includes minimizing morbidity related to surgery and risk stratification for women at risk for developing ovarian cancer. His research interests also include understanding the pathophysiology of uterine sarcoma. In collaboration with Basic Sciences, Dr. Bernardi has acquired research funding from several national agencies, including CCSRI and CIHR, and has been an author on over 150 peer-reviewed manuscripts. He developed the comprehensive ovarian tumor program at the University Health Network in 2018 to standardize the management of patients with ovarian cancer. Dr. Bernardi has held administrative positions in both national and provincial organizations in Canada. So I think he's well versed to speak on us on the current topic. Thank you for presenting.
Thank you. Thank you, everybody. What I'm going to be talking about is really about judgment and making good decisions. Things like my decision to befriend Ian in the first place, my decision not to bring hair product to Barbados, my decision to agree to give a talk right before lunch. These are all decisions that I'm questioning at this moment in time. So I'll obviously try to give the topic its due, but be conscious of time. I don't have any disclosures when it comes to this given topic. So what I thought we would do is review it from this 5 perspectives. One is understanding the right question. Do we have sufficient data that can really understand this question for us? Can the patient help us in making this decision? Where does personalized medicine fit in? And what is our approach at UHN? So I thought I would begin by just going over 4 potential scenarios. I think all of us would be familiar with these. So the first one is a 57-year-old woman. She has stage 3 high-grade serous ovarian cancer that was diagnosed in January 2024. She was treated with primary surgery and had complete gross resection. Then she completed 6 cycles of chemotherapy, completed in August 2024. Now she has a solitary recurrence of her spleen. What should we do? Second patient is an 82-year-old woman with a stage 4 high-grade serous ovarian cancer diagnosed in January 2025. She was treated with neoadjuvant chemotherapy, interval surgery, had complete chemotherapy in September 2025. She did receive bevacizumab. She now has multifocal disease and evidence of carcinomatosis. Patient number 3 is a 66-year-old woman with stage 2 endometrioid adenocarcinoma of the ovary that was treated in January 2023. She had surgery and then ultimately also had completion chemotherapy. That was completed in August 2023. She's had several sites of recurrence, but they're at the level of the sigmoid colon. And then patient number 4, 71-year-old woman who was diagnosed with stage 3 high-grade serous ovarian cancer in May 2024. She underwent primary surgery, had complete gross resection, again had 6 cycles of chemotherapy, completed in December 2024. She now has multifocal recurrence with disease in all 4 quadrants in the abdomen and pelvis. So I want you to think about these 4 and what you would do in these situations. So as I said, we begin really by trying to answer the right question. What are the questions that we have when we see patients? So we ask them, can I delay your cancer from coming back? And by doing some kind of intervention? Or can I make you live longer? Can I make you feel better? Can I help you attend your daughter's wedding? We've all been in these situations where our patients will say, listen, I have this big event that I really want to participate in. What can I do? So it is interesting to look at the evolution of endpoints. A lot of this has really come from pharmacological studies. But really up until the 2000s, the primary endpoints when it came to studies were overall survival. And why is that? Because it's unambiguous. Basically, if I'm going to do something to you, can I make you live longer? Let's say things became more complex, that included people living longer, there being multiple lines of therapies and interventions after the intervention for which someone's trying to make a decision about, crossovers in terms of trial designs, there was a shift, and suddenly the primary endpoint wasn't really overall survival, but progression-free survival. And some of the first studies that we know of that did that were GOG 218 and ICON 7, looking for bevacizumab impact in our patients. So there was this meta-analysis that was published in 2023 that asked the question, can we correlate progression-free survival with overall survival? This was a meta-analysis. They looked at 50 studies and ultimately showed that there was good association between these two endpoints. And, you know, ultimately, you have progression-free survival on the left and overall survival on the right. They both could be used, understanding that there are disadvantages to both when you're trying to make your decision, as well as advantages to both. So that brings us to the question about sufficient data. There are three major prospective trials that have really tried to address this issue. I'll go through each one of them. There's the GOG 213, Desktop 3, and the SOC1 trials. The GOG 213 trial, which was published in the New England Journal of Medicine in 2019, looked at patients that had platinum-sensitive recurrence. They defined that as greater than 6 months from the completion of their last chemotherapy. To be enrolled, the investigator had to feel that the disease was resectable, so this was subjective in a manner of speaking. The patients had to have good performance status. There was no formal selection algorithm. And the primary endpoint for this study was overall survival. So it is important to note that people who were not included in this study are those who were not medically fit for surgery, or those that had diffuse carcinomatosis. And again, I think diffuse carcinomatosis and multifocal disease can have some grayness in terms of the definition. Extra-abdominal disease were also excluded, as were those that had ascites. What did they find in this study? The progression-free survival differences in the surgery arm, 18.9 months, compared to 16.2 in the no surgery arm. The overall survival in the surgery group, 50.6 months, and in the no surgery, 64.7 months. The conclusion that they came up was not universally beneficial. I'll bring attention back to the overall survival, and it is correct that in the no surgery group, the survival was better than in the surgery group. So ultimately, it was deemed to be not beneficial from surgery, but one could look at this and really question what's happening. When you look at the two curves that they put on in the study, and the curve at the top is the overall survival, the one at the bottom is progression-free survival, it is a bit difficult to reconcile these two graphs. And we do wonder, with the famous caricature that you see here, which was first presented in a German postcard in the late 1800s, some of you are seeing the lovely woman looking in the distance, and some of you are looking at the older wise woman, pensive, looking down. But is this really an optical illusion that we're looking at these two graphs? So if you look at the 48 months, for example, and you were in the no surgery group, you would say that it was less likely that your cancer recurred at that moment in time. But at the same time, if you take the same time period at 48 months, it was also more likely that you'd be alive. So again, difficult to kind of put those two together. And I think to try to understand that, we really have to look at it and say, if we wanted to do a study and look at the behavior of sheep, well, the first thing we want to know, looking at these sheep, and say, are the gray ones going to be different than the brown ones? Or a corollary would be, if you wanted to do a study of American presidents, okay, I think you get the point. You know, so what are some of these characteristics that we want to look at and say that really would confound the question that we're trying to answer? How many of those patients were high-grade serous ovarian cancer? How many of them had oligometastases versus multifocal disease? How many of them were HRD positive or BRCA? What was the time range and completion of the chemotherapy to surgery? And what is the behavior of those cancers? Because we all know that that is a critical part of the story. They do provide us with some information in the GOG 213 trial. They told us that more than half the patients had 2 or fewer sites of disease. That was not shown in the manuscript, but they described that. And the median platinum-free interval is 20.4 months in that group. They did a subgroup analysis, but of the subgroup analysis of the total 485 randomized patients, there were only 197 that were represented. And there are certain factors that were deemed to be more favorable for the no surgery group. And one of them I want to bring your attention to is the greater than 12 months from the time of completion of chemotherapy. We'll talk about that subsequently with the next trial as well as something there. And then you can see that serous behaves differently than the other histotypes, and that wouldn't be a surprise. There's also about the U.S. on there, which those that were treated in the U.S. more favored the most surgery group, but I don't think we can make too much interpretation there. Ultimately, what did they find in this study? 63 of the patients that went to the operating room had complete gross resection. And that complete gross resection did ultimately have improved overall survival compared to those that went to the OR that did not have complete gross resection. That was 56 months to 37 months. So we'll move on to the desktop studies. Before desktop 3, there was desktop 2. Desktop 2 was really the study to help inform the authors about how they would proceed with the desktop 3 trial. So they introduced the AGO score. And so that's different. If you remember from the 213 trial, there was no specific scoring to look at inclusion criteria. It was a bit subjective. In this case, they're trying to bring some objectivity to the table. ECOG 0, ascites less than 500 cc's, and had to have had complete resection at primary surgery to participate. And really, this was a study to look at the feasibility of having metrics predict for complete surgical cytoreduction. So these were patients that had a recurrence of invasive epithelial ovarian cancer, fallopian tube or peritoneal cancer. Most of us will put that all into the same category. Any initial stage, and again, a tumor-free interval of 6 months. What is critical is that they needed to have had primary surgery at their initial treatment. So if they had neoadjuvant chemotherapy, then all bets are off. They would not be included as part of this. And as you know, the incidence of neoadjuvant chemotherapy to treat advanced ovarian cancer is increasing around the world. And the primary endpoint of this study was positive prediction of complete resection with a 2/3 prediction. So getting back to our presidents, I meant to put the red mark on there, but it looks like it got moved. So what was the median CA 125? It was 76. Again, when we think of these individuals that we have in front of us trying to make decisions around doing surgery at recurrence, 1/4 of the people included in this study had a range, had a value of less than 35. The tumor distribution, this was preoperative, as 51% of patients had a single tumor, and 21% of patients had 3 or more tumors. Their complete resection rate was 75%, and the rate of second look laparotomy because of complication was 11%. So I'll leave that to you to say if that's acceptable or not. This is what they found intraoperatively, and I only bring this to the attention to say that they underestimated preoperatively about what they would find intraoperatively. Again, I think most of us would have the same experience in our settings. They showed that they were able to completely, accurately predict resection in 75% of their cases, and really, for them, that validated this AGO as a objective selection tool. So for the desktop 3 trial, this was a randomized prospective trial published again in New England Journal of Medicine in 2021. They had the positive AGO score, platinum sensitive recurrence, and disease considered resectable. Now, this study did provide us more information than the GOG 213s. For example, 20% of the patients had stage 1 or 2 disease at the time of the initial presentation. 84% of the surgery group were high-grade serous ovarian cancer. That compared to 77%. It was deemed non-significant, that difference, but one might say it is something to look at. 15% of the patients had bevacizumab. 75% of the patients had a progression-free interval of greater than 12 months, and the median CA 125 in the surgery arm was 61 and 73 in the chemotherapy arm. In this case, the graphs are easier to reconcile. They match each other in so far as improvements of both the surgery for progression-free and overall survival. Again, you can see that the difference from the progression-free survival is modest, but we have a more significant difference in the overall survival. These were significant, and again, a complete resection rate of 75% was obtained. They did a subgroup analysis, again, in trying to understand some of the predictions with a hazard ratio of 1 and those that would favor cytoreductive surgery. I highlight some of these. Patients that were greater than 65 seem to favor the surgery arm. Those that were stage 3 or 4 at diagnosis seem to favor the surgery arm. Those that were high-grade serous, those that did not have prior angiogenic treatment. And interestingly, they found those that had a platinum-free interval of 6 to 12 months seemed to do better than those that were greater than 12 months. And we'll reflect on that a little bit later in the talk, because I think it does speak to something in our whole ethos and concept of cytoreductive surgery. So the last of those trials was the SOC1 trial that was published again. This was in 2024 in Nature Medicine. Again, they wanted to use an objective measure as opposed to subjectively selecting these patients, so they used what they call the I-model score. They also allowed PET-CT as part of the assessment criteria. So the I-model variables are stage at diagnosis, progression-free interval, the CA 125, the ECOG, residual disease after primary surgery, and ascites at recurrence. There's a bit of an algorithm to use these, so it's not simply plugging in numbers, but essentially a score of 4.7 or lower predicts potential a complete resection. They did allow for cases where it wasn't entirely clear, if you will, but the surgeon felt that they should be included, and if they looked at the PET data, they could then still include them. The results from this study, it was important to note that they had quite a crossover. 37 of the patients who were in the no surgery ultimately did go on to have surgery. As I mentioned, they did allow those that had unfavorable I-model scores and certain criteria to be eligible upon review, although they don't provide exactly those numbers. Again, you can see the median progression-free survival numbers of 17.4 and 11 months, and then the overall survival data of 58 months in the surgery group and 53.9. In the safety population, 5% had grade 3 or 4 surgical morbidity at 30 days. Just to compare the studies at desktop and the SOC, again, these were the two scoring systems. One used the AGO, one the I-model. Ultimately, I would say that the results of the studies were actually quite similar, and certainly the AGO scoring is simpler to use than the I-model scoring. There was a systematic review published in 2024 looking at this question, and they ultimately identified the following conclusions. Patients with relapsed platinum-sensitive epithelial ovarian cancer may benefit from complete or optimal cytoreductive surgery. The trials are really undivided, reporting a low risk of mortality and morbidity and a transient decrease in patient-reported quality of life in the postoperative period, but that further prospective trials are essential in refining the selection criteria. So when you look at the GOG 213 and the desktop SOC1, there was no overall survival benefit, as I said, in the GOG 213, but there was in desktop and SOC. SOC and desktop use algorithm-based, and bevacizumab use was high in the GOG 213 and not the other two trials. Robert Coleman, who I'm sure many of you are familiar with, was the lead author of the GOG 213 and did write a response to an editorial about why the results were so different. He comments in his editorial response that there was a difference in methodology for patient selection. He did indicate that the 3-year overall survival was actually similar among the three trials. GOG 213 had a more diverse population. The crossover was less than GOG 213. And one that probably is the greatest difference between the two trials is the very high use of bevacizumab. I think internationally there are differences in terms of the use of bevacizumab at primary treatment. In Canada, it is not funded for every case of ovarian cancer like it is in the United States and some parts of Europe. It does lead to a difference, if you will, in how these patients are treated at that first recurrence. Ultimately, again, what did Rob say? We need a closer evaluation of the preoperative disease volume, look at genomic status, and looking at some improvements of how we're selecting for these patients. So the final takeaway of the data, surgery is not universally beneficial. Selection tools can be beneficial. Complete ghost resection is really critical if you are going to take someone to the operating room. The progression-free survival improves consistently overall survival in the context. And then understanding the variations of these patients is limited. The last thing I'll say is that all these three trials in the no surgery arm had what I would describe as very favorable median overall survival. Remember, at the time of randomization was at the time of the recurrence. And so when you think of median survival for patients with advanced stage ovarian cancer being in the order of 48 months, these are patients that had median overall survivals between 46 and 65 months, did not have surgery at recurrence. And that recurrence, as you could see, the median was 20 months from the initial diagnosis. So I would propose a more favorable patient population. So how can the patient help us? I'm sure that you have. I ask it in this way, but I'm sure people in the audience have asked their patients this. And I will do this occasionally. Usually it's in the context of a pharmaceutical intervention that we have to potentially introduce. And I will tell them that we have this new type of treatment. It has shown promise. There are some side effects. They tend to be temporary. And, I ask them, what kind of a difference are you looking for? Like, what do you want to see as a difference if you do this intervention or not do this intervention? And in my experience, their answer is never in months. So no patient has ever said to me, well, I'm looking for a 4-month difference for when my cancer would come back if I do something or not do something. Their response is almost across the board in years. A 3-year difference. And that's when we have to have that discussion and really understand with the patient about what this disease is and how do we guide them through it. I would propose that we don't understand the wants and needs of our patients as well as we might think. We spend a lot of time talking about data. We have our meetings. We spend 90% of the meetings talking about data and outcomes. And typically there will be a small section on patients' well-beings, what their goals are. And I do think we need to consider these factors. Side effects, the time spent in hospital, travel distance for patients, what their wishes are, because it's uncommon that these interventions ultimately will cure patients. I think the next slide, just in the conversion from map, is off, so we'll just skip that. That's fine. So personalized medicine, where does personalized medicine fit in? We know that when it comes to pharmaceutical interventions, it's all about personalized medicine now. But when it comes to decisions around surgery, I'd propose we're a little bit behind when it comes to that. So things like oligometastases and multifocal recurrences is something we're going to have to really try to understand. Improvements in systemic treatments, what does that mean as we get better with our systemic treatments, and where do biomarkers fit in? So again, I think I mentioned earlier, our understanding of surgical cytoreduction, in essence, what we're doing with ovarian cancer is chasing the tumors. I find it interesting that in the last 10 years or so in the lexicon of gynecologic oncology. There's a lot of studies that talk about R0 resection. Depending on the mood I'm in, I'll usually come to the podium and ask a question and ask them how do they get their pathologist to give margins on every single sample you give them from ovarian cancer debulking. And that's usually the point where they'll say, yes, you're right, it's an actually R1 resection. But it is an important distinction because that is what we do. We do R1 resections. We don't really remove disease along the surgical oncology principle of removing disease, which was to say, you have a cancer, you have to cut it out, you got to make sure the margins are clear. And we do that because we have good systemic treatment. And so when you think I just provided 5 examples of different cancers, we don't typically do cytoreductive surgery of colon cancer. Now there are exceptions, and that typically is low-grade mucinous tumors. They're very slow growing. And so that there may be some benefit of doing cytoreduction. Obviously, that's where HIPEC originated. Metastatic breast cancer, we don't do cytoreductive surgery for metastatic breast cancer when it's in the abdomen and the pelvis. We know that it's relatively resistant to chemotherapy. Metastatic granulosa cell, well, we do cytoreductive surgery in those cases, even though, again, it's resistant. Metastatic papillary serous, yes, we do. They tend to be resistant, but again, the rate of growth is variable. And we heard just earlier today, metastatic gestational trophoblastic disease, we seldom would do any kind of surgical cytoreduction to 0, and then we know that it's exquisitely sensitive to systemic treatment. And so where does ovarian cancer fit in this paradigm? And I would say, again, it's not entirely clear. So how do we navigate the improvements in systemic treatment? Do we double down and be more aggressive and say, yes, we have better systemic treatment? And this is long-term data from the GOG 172 trial, which we know is Deb Armstrong's trial that looked at intraperitoneal chemotherapy. And so if you look at the blue line, this is overall survival for patients that were BRCA, had primary cytoreductive surgery, had IP chemotherapy, and you can see they're not even hitting the median survival at 84 months. And dare we say that these are patients who are potentially cured with an operation? Or the flip side, do we consider surgical systemic advancements the real evolution in the management of ovarian cancer? And you look at this, again, going back to the desktop trial, where you saw that they had the real benefit in those that were 6 to 12 months. And so arguably one could say if you have patients who recur 36 months after the completion of their primary chemotherapy, they are so sensitive that you're not likely making a huge difference with the surgery that you're going to do. And I always ask the question, if you're going to do surgery and you resect all the tumors, why follow it up with chemotherapy at that moment in time? Why not keep that tool in your pocket? You've accomplished what you wanted to accomplish, which was to remove the disease. And invariably, no one ever agrees to do that because we know that we're not really removing every single bit of disease. And finally, how do the biomarkers fit into the discussion? Well, we know BRCA, many of us now who are able to go back and look at our very long survivors, overwhelmingly a high percentage of them are BRCA carriers and often BRCA2 carriers, which we know do the best. And so this is important. And where do PARP inhibitors fit into it? How is that going to impact our decision on surgery at recurrence? Folate receptor alpha testing, homologous recombination testing, and again, where do the non-serous cancers fit in? Because they're a completely different paradigm. So what is our approach at UHN? All of these patients are discussed at multidisciplinary board rounds, and that includes presenting what the patient story is, because that becomes as part of it as anything else. We all know how badly we can feel if a patient is taking a longer time to recover from these kind of big operations and they don't have a lot of support, and you look back and you wonder, did you really have a good enough discussion with them as you would have hoped? And so that is, again, a really important part. We don't use formal AGO criteria or iModel, but we use, obviously, the components of them. ECOG, platinum-free interval, the extent of disease and likelihood of resection, and the patient's understanding, and of course, if there's any other clinical trial options for them at that time. So we can go back to our patients. If you recall at the beginning of the talk, I think most people would say that that patient number one with a solitary recurrence, a reasonably long disease-free interval, yes, I think it's reasonable. It's a low morbidity operation. I think most people would agree that the 82-year-old with stage 4 disease, very significant amount of disease of recurrence, relatively shorter interval, we would not operate. Our patient number 3 that had relatively localized disease around the sigmoid colon that could be resected, again with endometrioid histology that arguably could be more favorable. And I would say that the one that is really the one that is the biggest challenge was that really that patient number 4. Well, I still put a question mark, and I don't think the 3 randomized trials have actually given us the answer to that question, because that's the one that we're not really sure how much of a difference we're making. We have to be sure to clear all the disease, and we have to be sure that the patient understands what the price is to pay and what the potential benefit it is. And that's it. Thank you very much again for the invitation.
Thank you so much for that talk. Any questions? I have more a comment to make. I find certainly in Jamaica, that 2 factors come into play when for advanced endometrial cancer and ovarian cancer is one, a lot of patients fear chemotherapy. They don't want chemotherapy anyway, right? And the side effects, they hear about it, and I think the chemotherapy is going to kill them rather than disease will kill them. The other thing too, which is a factor which plays a role, is cost. So a lot of these patients, like patients you presented at that age, they look and they will say, boy, like you said, you made a comment about, a patient looks at years instead of months. So they look at it in terms of what can the funds, because the reality is that the patients have to pay for these things out of their own funds, so that they will say what can they give their grandchildren to go to school or their children to have a better life, and they will forego the chemotherapy. So, it's just something that comes into play when you're making a decision, when you're advising these patients on the thing. So the point you made about what is important to the patient versus, the data is very important.
Yeah, maybe just I'll address that. I mean, I think if you're looking for maximum bang for the buck when it comes to patients with, we'll talk about high-grade serous ovarian cancer, it's probably single-agent carboplatin. I mean, I think you have a patient like that, it recurs at, 24 months after initial treatment, single-agent carboplatin. It may not be better than some of the other alternatives, but certainly from a cost perspective would be quite low. And as we all know, single-agent carboplatin is a very well-tolerated medication, and the side effect profile is actually quite low. And certainly for our patients, we often get this, especially in the elderly that might say, I'm not going to go chemo. What am I going to, we'll usually tell them just try one cycle and see how you feel, because most people's understanding is not in keeping with what the reality is, for example, just with single-agent carbo. But I agree. I suppose in certain circumstances, surgery might be a less expensive alternative, or it may be a more expensive, and depending on the jurisdiction that comes into play.
Thank you for that presentation, Marcus. Matthew's point, especially in Barbados, is quite apt too as well. Not really the economic side of it, but the theatre usage cost. And I'm not talking about the cost to the administration or the hospital, but theatre time is very precious. We have one main hospital that deals with majority of the island's cancer cases. And when you have to prioritize where you only have 1.5 or 2 lists a week, you would obviously know how complex these cases can be when you're doing optimal debulking and the impact it has in terms of your resources, the utilization of blood in a blood bank that may not be as robust, and ICU services where you have limited beds. So we do have this dilemma sometimes where, and majority, I think in Barbados for sure, I just had a chat with Vishal and Matthew, we do send them for chemo up front. And it does make surgery easier when you get neoadjuvant, but you're quite right. I mean, as surgeons, we like to operate too as well. And we like the challenge of being able to operate, but what does it translate to in terms of, is it months? And And does it make a difference in terms of quality of life? How many weeks are they spending in hospital and how much care?
Yeah, I mean, I think if you take all the data, and there's lots and lots of it, going back from primary treatment, neoadjuvant chemotherapy. I mean, there's now 5 randomized trials looking at neoadjuvant primary surgery. The best way that I would describe it, I think there's a small percentage of patients where your decision makes a fundamental difference. And I'm going to say that number is probably about no more than 15%.
So if you were to choose one factor, to me, the ones I fight for are the ones who are young, the age. And I'm not sure if I'm doing this based on evidence-based medicine, but those are the ones that you see when they're coming up 40-something, right? Versus the late 60-year-old, who you want to give the best chance of debulking and then obviously adjuvant. But then obviously it's only a difference of months.
Yeah, I think it's natural to do that for younger patients to think, I don't want to use the word to be more aggressive, because in a way then what's your definition of younger, and why not be more aggressive to the person who's 1 year older than your definition of younger kind of thing. But I think it's probably more a function of they can absorb what, there's potential complications with these kind of operations, and I think that is what comes into the equation in terms of making that decision. Often younger patients might be more likely to be BRCA positive, and again, we know they respond very well to systemic treatment, and I think it's not entirely clear yet. As I said, do you double down on those patients? Are those the ones you can cure? If you take that surgical mentality, plus they have this super favorable response to systemic treatment, the combination of the two is that group of patients that you're going to cure? Or is it the flip side and say, well, no, in fact. I mean, when you look at our patients who are BRCA2 positive, who are alive 8, 9, 10 years after stage 3 ovarian cancer, well, they were going to be alive anyways because they've responded so well to systemic treatment. And I think that is, the jury is still out on that. I think, but, I think when you're operating in a resource-constrained environment, and you're having to make decisions, again, I think the culmination of all the data is that you're probably not doing harm necessarily. I mean, when I say that, again, it's not that you're curing someone or not curing. We are talking about months in terms of the overall management strategy. And I think when you would actually probably, if there was a way to make an equation of a patient's wish and quality of life and time, and you put the whole thing together, there's probably very, very little difference in terms of
you actually hit the nail on the head. It's the quality of life to them too as well, because when that patient comes to you with abdominal distension, bloating, respiratory compromise, keep getting tapped, and you give them chemo and they respond very well, majority of them forget that they have cancer and just happy to get that relief that they can sleep at night, eat properly, and then to hear, well, let's consider surgery, they look at that as, no, that's going to be downtime again, I'll take my chances and see what happens when it comes back. But yes, you're quite right. You have to look at all these factors. It is individualistic, and look at our resources and then plan accordingly.
The last thing I guess I'll just say is there is increasing consideration around the world that these are not necessarily procedures that should be done at every gyne-onc center. The European group has created a formal ESGO accreditation for advanced ovarian cancer surgery. We at our center, in fact, are becoming a member of that. And even amongst ourselves, we're a group of 8 people. We have made the decision not all of us are doing advanced ovarian cancer surgery. So there's only a small number of us that are doing it. So I do think what is the key to these operations is you can't be 90% good enough. Like, it really has to be a complete resection for whatever that means in our context.
Matthew made a comment to me sitting down there, we're not going to be doing ovarian cancer surgery in the next 10 years. What are your thoughts on that? I assume he meant, you might want to clarify, with the advancement of chemo, immunotherapy, put Matthew on the spot. But we're doing good for time, everybody. Just to let you know, we're at lunch shortly. So, Matthew, you want to answer that or just let that go off into the sunset?
After lunch. After lunch, I think everybody wants to go to lunch. Thank you for that great talk. as introduced, it's lunch.
So housekeeping, lunch is at the Lighthouse Restaurant, which is up the stairs on the outside. The presenters for the next session, can you please bring forward your presentations to the podium? We have sponsors outside, make sure you engage with them. And can we aim to get back here at 3:15? 45 to 50 minutes lunch, that should be okay? All right, thank you.
Hi.
Introducing you in the next round.
Oh,
Is
okay.
there something I need to say about you that is different from what is on? I know your bio status is.
No, I'm just like
Okay.
just another one of it, just like everyone else.
What do you do for fun?
What do I do for fun? I just hang out with
Don't treat me like a puppet on a string. 'Cause I know how to do my thing. Don't talk to me as if you think I'm dumb. I wanna know when you're gonna come. See, I don't wanna wait and wait for your love. I don't wanna wait and wait for your love. I don't wanna wait and wait for your love. 'Cause it's summer here, I'm still waiting there. Winter is here, and I'm still waiting there. Bless my eyes this morning. The sun is on the rise once again. We heard that things are going. Anything can happen. You see, men sailing on their ego trip. Blast off on their spaceship. Million miles from reality. No care for you, no care for me. So much trouble in the world. So much trouble in the world. All you gotta do, give a little, take a little, give a little, one more time, yeah, 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 yeah. So you think you found that solution? Oh, it's just another illusion. So before you check out this time, don't leave another cornerstone standing there behind. Yeah, we've got to face the day. Ooh, we come what may. We the street people talking. Yeah, we the people struggling.
run away from yourself? Can you run away from yourself? Can you run away from yourself? Must have done something wrong. Said you must have done whoa, something wrong. Why you can't find the place where you belong? Running away. Running away. Running away. Running away. Ooh, yeah. Woy-oy, woy-oy, woy-oy. Woy-oy-oy-oy-oy. Spill it into one drop, and we still find time to rap. We're making the one stop. The generation gap, so feel this drum beat as it meets within, playing a rhythm, resisting against the system. Ooh-wee. I know Jah never let us down. Will you right from wrong? I know Jah never let us down. Oh no, oh no, oh no. They made their world so hard. Every day we got to keep on fighting. They made their world so hard. Every day the people are dying. Yeah. For hunger and starvation. Lamentation. But read it in Revelation. You'll find your redemption. And when you keep us the teachings of His Majesty. But we no want no devil philosophy. How you can keep us the teachings of His Majesty. But we no want no devil philosophy. Feel it in the one drop, and we still find time to rap. We're making the one stop, and we're filling the gap. So feel this drum beat as it beats within, playing a rhythm, fighting against ism and schism, singing. I know Jah never let us down. Will you right from wrong? I know Jah never let us down. Oh no, oh no, oh no. They made their world so hard. Every day, every day. They made the world so hard. Every day. I want to make them a monster. Check out the real situation. Nation war against nation. Where did it all begin? When will it end? Well, it seemed like total destruction, the only solution. And there ain't no use, no one can stop them now. Ain't no use, nobody can stop them now. Give them an inch, they take a yard. Give them a yard, they take a mile. Once a man and twice a child, and everything is just for a while. It seemed like total destruction, the only solution. And there ain't no use, no one can stop them now. There ain't no use, no one can stop them now. There ain't no use, no one can stop them now. Ain't no use, no one can stop them now. Rasta man live up, yeah. Natty Dread no give up. Yeah. Dready got a job to do, and he's got to fulfill that vision. Yeah. To see his hurt, will be their greatest ambition. Yeah. But we will survive in this world of competition. 'Cause no matter what they do, let's keep on coming through. And no matter what they say, tragedy they ever make, Natty Dread rise again. Through the mystics of tomorrow, Natty Dread rise again. Have no fear, have no sorrow, yeah. All in all you see a one is the fight against the Rasta man. And so they build a world in great confusion to force on us the devil's illusion. But the stone that the builder refused shall be the head cornerstone. And no matter what game they play, and we've got something they can never take away. We've got something they can never take away. And it's the fire that's burning down everything. Feel the fire, feel the fire. Only the birds have their wings. Yeah. No time to be deceived. Oh, brothers, you should know and not believe. Just say this judgment would that never be with water. No water can put out this fire. This fire. This fire. This fire. Ayagayo. Right, natty, right. Go there, ready, go there. 'Cause now the fire is out of control. Panic in the city, wicked creeping for their soul. Everywhere fire is burning, destroying and melting their gold, destroying and wasting their souls. Go right, natty, right. Go there, ready, go there. Tell you what, now the people gather on the beach, and the leader tried to make a speech, but the dragon can tell them that it's too late. Fire is burning and pull your way. There's a natural mystic flowing through the air. If you listen carefully now, you will hear. This could be the first trumpet, might as well be the last. Many more will have to suffer, many more will have to die. Don't ask me why. Things are not the way they used to be. I won't tell no lie. One and all got to face reality now. Though I try to find the answer to all the questions they ask, though I know it's impossible to go living through the past. Don't tell no lie. There's a natural mystic flowing through the air. Can't keep him down. If you listen carefully now, you will hear. That's a natural mystic flowing through the air.
Yes, this little song here is called Old Pirates, you know.
redemption song. All pirates, yes, they rob I, sold I to the merchant ships. Minutes after they took I from the bottomless pit, but my hand was made strong by the hand of the Almighty. Forward in this generation, triumphantly, won't you help to sing another song of freedom? 'Cause all I ever have, redemption songs, children, redemption songs. Emancipate yourself from mental slavery. None but ourselves can free our mind. Have no fear for atomic energy, 'cause none of them can stop the tank. How long shall they kill our prophets while we stand aside and look? Some say it's just a part of it. We've got to fulfill the book. Won't you help to sing another song of freedom? Is all I ever had. Redemption songs, redemption songs. I remember when we used to sing in a government yard in Trenchtown. Over serving the hypocrites as they would mingle with the good people we meet. Good friends we have, oh, good friends we've lost along the way. High. Give thanks and praises so high. He will not deceive us, my brethren. He will only lead us heaven. Oh, take that veil from off of your eyes. Look into the future of real life. Noah had 3 sons, Ham, Shem, and Japheth. And then Ham is known to be the prophet. Glory to Jah, the prophet is come. Glory to Jah, the prophet has come. When my soul was hurted deep within, and I'm hurrying to be free, desperately, yeah. So guide and protect I and I, oh Jaja, through all these ages. Guide and protect I and I, oh Jaja, through all these stages. Rastafari is his name. Rastafari is his name. If Jah didn't love I, if I didn't love I, if Jah didn't love I, if I didn't love I, would I be around today? Would I be around to say feeling out, feeling down? This feeling wouldn't leave me alone. Then up came a one that said, hatred, hatred, flying at the dread and smile. You're in Jamaica, come on and smile. In Jamaica, y'all, get it together, y'all. In Jamaica, get it together now. In Jamaica, y'all. Soulful town, soulful people. Said I see you're having fun, dancing to the reggae rhythm. Oh, island in the sun, oh smile. In Jamaica, come on and smile. In Jamaica, y'all, get it together right now. In Jamaica, get it together, children. In Jamaica, y'all, we're gonna help our people, help them right. Oh Lord, help us tonight. Cast away that evil spell. Throw some water in the well and smile. In Jamaica, come on and smile. In Jamaica, y'all, get things together right now. In Jamaica, get it together right now. In Jamaica, y'all. Rhythm wise, double wise, another wise. Can't criticize our smile. In Jamaica, you're gonna smile. In Jamaica, y'all, get it together right now. In Jamaica, get things together right, y'all. In Jamaica, y'all, help the people, help them right. Oh Lord, help us tonight. Still we striving for better. And we not gonna stop till the battle is won and we get justice. Cause if you lose your stand, anyone will try to push you over, over and over. Lift up your head and hold it up high. We know that we'll win the prize. Lift up your head and hold it up high. We know that we'll win the prize. Don't be discouraged by the pitfalls and their worries. Pain endure for one night, but joy cometh in the morning. And if you lose your soul, there's nothing to gain. It will be over. DJ Wiz. Over. Lift up your head and hold it up high. We know that we'll win the prize. Lift up your head and hold it up high. We know that we'll win the prize.
DJ Wiz.
Higher, we stepping higher.
DJ Wiz.
It's a get up people song, only them can sing this world. It's the song for the poor in space in separation. It's a get up people song, only them can sing this world. It's the song for the poor in space in separation. Malaras, have down pressure. Why you only terrorize the poor? Believing the fact they are human, who one day will not take it anymore. Whoa. Take it from your brother, Everton Blender. Now is the time for you to get stronger. Wise up, and temper your anger. It's a ghetto people song, only them can sing this song. It's a song for the poor who is facing separation. It's a ghetto people song, only them can sing this song. It's a song for the poor who is facing tribulation. Give a little, even a little, just make it trickle. Know who you give to. I'm talking to you, Mr. Fortunate One. Hey, hey, hey. Do it in a hurry, or you'll be sorry. Others first, we must help to carry. Ababa Janai made everyone. Hey, hey, hey. Get up people song, only them can sing this one. It's a song for the poor who is facing separation. I won't hide. Mr. Junior, Mr. Junior, Mr. Junior, If Jah is standing by my side, then why should I be afraid of the pestilence that crawleth by night? If Jah is standing by my side, then why should I be afraid of the pestilence that crawleth by night? Your best you try to harm I and I, aiming to kill, but I love you still, cause you are here to make prophecy wish I know what's to know, what's to know. Are you satisfied? Wipe the tears from your eyes. I'm all alone, still you know I was telling a lie. Are you satisfied? No one's with me tonight. Only Jah, and He's always by my side. Pretty little woman, don't you trust me no more? You don't have to break down my door. I'm all alone. Come inside and you will see there's no one here but me. Told you I'll soon be over, still you refuse to believe. Are you satisfied? Wipe the tears from your eyes. I'm all alone, still you know I was telling a lie. Are you satisfied? No one's with me tonight. Only Jah, and He's always by my side. No looking back, no turning back. I decided to serve Jah.
DJ
No
Wiz.
looking back, no turning back. I know I got to be stronger. No looking back, no turning back. I decided to serve Jah. No looking back, no turning back. I know I gotta be stronger. I am so sure about this folklore spreading to shores more than before. Although sometimes temptation come your way, don't give up now. Go on your knees and pray. Such a difficult task of finding food today. Jah is the will to show you the way. No looking back, no turning back. I know I must serve Jah. No looking back, no turning back. I know I gotta be stronger, stronger. I sing, oh Jah, keep on strong. I sing, oh Jah, to carry on for my love, Jah. All I'm receiving is hate. I sing, oh Jah, keep on strong. I sing, oh Jah, to carry on for my love, Jah. All I'm receiving is hate. I know they see and they just don't care. I can't continue to follow their way. All I wanna do is praise Jah every day. Judgment is drawing near each time. People can't seem to realize. Going around telling those vicious and dirty lies. I sing, oh Jah, keep on strong. I say, oh Jah, to carry on for my love, Jah. All I'm receiving is hate. I sing, oh Jah, keep on strong. I sing, oh Jah, to carry on. Come one piece of the blender. Do anything to be a fan club member. Everyone is now willing and able to play a blender on them turntable. Them a run. Come one piece of the blender. Do anything to be a fan club member. Everyone is now willing and able to play a blender on them turntable. So long blender a ram down so. Promoter never pay me no money at all. Walk from give me bit to Lionel down. Trying to reach home before I drop down. And I have my family to face, cause I know there's no food in the place. I was away all night, but I knew everything would be right. Now them a run. Come one piece of the blender. Do anything to be a fan club member. Now everyone is willing and able to spin a blender on them turntable. Them a run. Come one piece of the blender. Do anything to be a fan club member. Everyone is now willing and able to spin a blender on them turntable. Back in the days they used to call me Boobaloo. Shirt it here and me never have no shoe. I pray to Jah for a brighter view. Anja link me with the Star Trail crew. Them a run. Come one piece of the blender. Do anything to be a fan club member. Now everyone is willing and able to spin Descend upon them, turn them, turn them. Sit up on the throne in the Mount Zion, my Lord. Rumor them a spread, just the last dead. How the body be function without dead? Said Marcus Garvey and Emmanuel gone. Without the Trinity, say life couldn't go on. Rumor them a spread, said Selassie dead. How the body be function without dead? Said Marcus Garvey and Emmanuel gone. Without the Trinity, say life couldn't. In a Psalm 87, that's where me see clear his foundation is in the holy mountain. Glorious things are spoken of thee. Mention of free up on Babylon to me, Ethiopia, city of the Almighty. The most I was born, there is majesty. All the musicians say my springs are in thee. But I better sing this song to be free. Why? Rumor them a spread, say Selassie dead. How the body be function without dead? Said Marcus Garvey and Emmanuel gone. Without the Trinity, say life couldn't go on, go on, go on. Hurt the heart, but you can't hurt the soul. Trusting of the Almighty more and more. Me no under no devil control. God does me guide when me a play life role. Hurt the heart, but you can't hurt the soul. Trusting of the Almighty more and more. Me no under no devil control. God does me guide when me a play. Baby love him all him kingdom ya go tour. Love me so much me no have to kick off no door. Just for receive him more and more. Every day he then broke out like a sword. Good over evil and Tony be sure. Now live up Kingston but me live up Portmore. When me meditate upon the seashore. Talking to the rich and also to the poor. Hurt the heart but you can't hurt the soul. Trusting of the Almighty more and more. Me no under no devil control. God does me guide when me a play life role. One thing I can do, one thing I can say. Almighty God that lead the way. He's my guide and protector, night and day. That I will never fade away. One thing I can do, one thing I can say. Almighty God that lead the way. He's my guide and protector, night and day. That I will never fade away. Night time when I lay myself to rest. Take from me pillow, meditate godliness. Pray for the cripple, dumb, the blind and the deaf. Pray for the animal, the bird in the nest. Pray for the man, them think about safe sex. Pray for the youth in the school round the net. Pray for the world cause it's really in a mess. When me get me wisdom from burning the cess. Whoa, one thing I can do, one thing I can say. Almighty God, I lead the way. He's my guide and protector, night and day. That I will never fade away. One thing I can do, one thing I can say. Almighty God, I lead the way. He's my guide and protector, night and day.
Blending under roots and culture. Blending, Everton blender. Blending under roots and culture. Me used to sing a dance, we never get no money. I was spreading good words to every goodie. Now we are spread it universally. There's a lot more you gonna hear from me. Blend them, Everton blender. Blend them, under roots and culture. Blend them, Everton blender. Blend them, under roots and culture. Some may try to criticize me, but I'm walking in the footsteps of the Almighty. You know you with them I say, I hold the barrel in my mash up the place. Hear the next few I say, long time in my sing, make him go and go away. Blend them, Everton blender. Blend them, under roots and culture. Blend them, Everton blender. Blend them, under roots and culture.
Every day I love her just a little bit more, little bit more, little bit more. Every day I love her just a little bit more, and she loves me the same. Yes, she loves me the same. 'Cause my love, it's her love, and her love is my love. Yes, she gives me loving at the right time, daytime, nighttime. Yes, she gives me loving at the right time. Every day I love her just a little bit more, just a little bit more. Every day I love her just a little bit more, and she loves me the same. Every guy that walks around the street, they say she's sweet. Oh, my baby, can I throw some flowers at your feet? She's young, fresh and green, she loves me the same. Yes, she wants me. Whoa. Oh, whoa. She wants me. She wants me now. Now, blow your nose and not your mind. I know that you are not blind, so please make up your mind. Mankind, if a man do wrong, and you do it too, Judge is gonna beat you for true. There's an unseen eye watching you. Any little thing that you do, you and you. Why I, so blow your nose and not your mind. Cause we are living in a tedious time. Jaja is turning back the hands of time. Mankind, righteous man, Jaja want in the sky. Yet a righteous man is so hard to find. So I wonder, who's gonna stop the war and crime? Whoa, there are some people can't do things on their own. Yes, they have to wait till mom and dad come home. Yes, you got to learn, then you will earn. Why, so blow your nose and not your mind. I know that you are not blind, so please make up your mind. Mankind. Coming harder, ain't looking back, feeling stronger. Ready to launch the attack, do you remember? When we were the cream of the crop, is the Bible. At the carbon we got, they took us away from Africa with an intention to kill our culture. But through the power of the Most High, our mental capacity get wider. Coming harder, ain't looking back, feeling stronger. Ready to launch the attack, do you remember? When we were the cream of the crop, they stole our Bible. At the carbon we got, this is the time to live as one. Help your brother man from out of the slum, it's no crime. If blood have you run, to liberate yourself you have to live in some. Coming harder, ain't looking back, feeling stronger. Ready to launch the attack, do you remember? When we were the cream of the crop, they stole our Bible. At the carbon we got, emancipate your mind from slavery. I know one day Jah will settle. Nobody want to plant the corn, everybody want to read the band. Who you are go blame it on when it's a next man you are depend pan? Well, you're wrong. Nobody want to plant the corn, everybody want to read the band. Happy sing your own a song, can't compete with Kelly's John. I was looking a start, just a little ease off. No one would help me push that old and can't them a laugh. Never take me serious, so many goals and tasks, potholes I pass every day. My Lord, I have to pray on my way. Them never realize with a little cooperation we could have unify, relieve the frustration. Instead them want to ride up on them bread back. No tears, no cares if him even did stop our job. Nobody want to plant the corn, everybody want to raise the barn. Who you are go blame it on when he's a next man you are depend pan? Well, you're wrong. I've been here all day of my life. Works good and queer, I be on with my sight. Some will share, others do as they like. Some you flesh them want here with them fork and knife. Some don't care, their heart is like ice. After killing under them retice, but I'm holding firm. I've been here all day of my life. Works good and queer, I behold with my sight. Some will share, others do as they like. Some you flesh them want here with them fork and knife. Some don't care, their heart is like ice. After killing under them retice, but I'm holding firm. Every man deserves to earn. Jaja come a plant with success. Holding firm. Every man deserves to earn. You won't think I'm.
All right, good afternoon, everybody. Good afternoon, everybody. Thank you. So we have our Java, what's it called? Java coffee. You know, we suffer from something in the Caribbean called ethnic fatigue, right? After we have such a good lunch. So our next speaker is coming from Spain, and he's on a time clock, obviously because of the time difference. But I'm going to welcome our treasurer of the Caribbean Gynecological Cancer Society, Dr. Ian Bambury. Dr. Ian Bambury is a gynae oncologist based at the University Hospital of the West Indies. He did his fellowship in Ottawa under Michael Funky Fung and came back to the University Hospital and was instrumental in being one of the first trained specialists at the hospital in setting up, or not really setting up, but continuing the gynae oncology service. He was later joined by Dr. Matthew Taylor, and they make up, and they run the fellowship program down there as well from the CGCS UE IGCS collaboration. And I'm going to let him come to the podium to introduce our next speaker. Welcome, Ian Bambury.
Thank you, Vikash. Good afternoon, everyone. Hope you're still awake after such a lovely lunch. All right, so our next speaker is actually a Spanish medical oncologist with expertise in breast and gynecological cancer. He currently serves at the Breast and Gynecological Cancer Unit of Hospital Universitario in Madrid, Spain. In addition to his clinical role, he is a medical advisor at SOLTI, Salty Cancer Research Group, and coordinator of the SOLTI, the Salty Young. He is the scientific secretary of the Spanish Society of Medical Oncology. Dr. Sanchez has been a member of the ESMO Young Oncologists Committee and committee chair since January 2025. He completed his medical degree at the Universidad de Navarra, where he also pursued a biomedical research diploma at the Center of Applied Medical Research. Following his medical studies, he undertook a residency in medical oncology at Clínica Universidad de Navarra, complemented by the Cancer Prevention and Survivorship Program at the MD Anderson Cancer Center in Houston, Texas. In 2020, he completed his PhD focused on breast cancer epidemiology. His research primarily focuses on precision oncology, liquid biopsy in breast cancer, and pharmacogenomics. He's a principal investigator of the PROCURE project, focused on the pharmacogenic variants and the risk of toxicity in patients treated with antibody-drug conjugates. As a principal and sub-investigator in numerous clinical trials, he contributes to improving therapeutic approaches in breast cancer. His work has led to the publication of more than 50 peer-reviewed articles in indexed journals. It gives me great pleasure in opening the floor to Dr. Rodrigo Sanchez, as he speaks to us, advancing precision oncology, the role of HRD, and BRCA testing in clinical decision-making. The floor is yours, Dr. Rodrigo Sanchez.
Hi, hello everyone, and good evening from Spain, and thanks so much for the warm welcome and for your kind words. I just would like to confirm if you can hear me all loud and clear.
Yes, we're hearing you loud and clear.
Okay, thank you. Thanks so much. So, thanks so much for the invitation. Today we're going to be discussing in the upcoming minutes, I think, one of the main key relevant topics in breast and gynecological malignancies, specifically in ovarian cancer, which is the use of one of the probably top 3 biomarkers that we have in breast cancer, right? If we think of the evolution of biomarkers in oncology, specifically in female malignancies, apart from the estrogen receptor, HER2 positivity, probably BRCA mutations, and all the homologous recombination pathway, It's one of the key areas in the development of targeted therapies that we have experienced in the past decade. So in the next slides, I'm gonna try to share with you an overview on what is the rationale, what is the importance, and what are the clinical implications for testing, the relevance of testing BRCA and HRD status in our patients with both breast and ovarian cancer. So here you can see my conflicts of interest. I will start with breast cancer. Uh, BRCA mutations in breast cancer are very relevant, although the known prevalence of BRCA mutation germline carriers can vary a lot among different populations. There is like a very well-known proportion of around 5 to 10%, depending on the populations of germline carriers, and in patients already diagnosed with breast cancer, we can estimate that around 1 out of 20 patients will carry a mutation in BRCA1 or BRCA2. But this homologous recombination in breast cancer specifically, very similar that we will see in ovarian cancer, that does not only depend on BRCA1 or 2. There is a plethora of genes that can be involved in these DNA repairing pathways like TEC2, PTEN, ATM, P53, and many of them even as part of a more comprehensive syndrome like a Lynch syndrome. One of the key differences here, of one of the pillars when discussing about BRCA biomarkers, is that both have a very strong genetic counseling implications. Probably we as physicians, when we are addressing a patient for the very first time that is probably suspicious of big carrier of a germline mutation, it's very important to understand the relevancies of the genetic testing. So many of these situations also we need to take into consideration what is the family history, what are the family considerations. If the patient has or hasn't any relatives that have a prior diagnosis of cancer, specifically breast and ovarian cancer, but also some personal considerations, because part of the discussion with the patient is what are we gonna do next if we diagnose a germline BRCA1 or 2 mutation. Because, of course, it's not only about discussing prophylactic measures, but also what's going to be our surveillance strategy in these patients that may have risk for other malignancies apart from breast and ovarian cancer. So I think this is a very good example now that we're in the era where we work as a multidisciplinary team. I think oncology cannot be understood if we don't work together as a team, right? It's not only about medical oncologists. Here we're working together with breast surgeons, with gynecologists, with pharmacists, with genetic counselors, of course, with all our nursery team. And all this team takes part in the germline BRCA testing. What do the guidelines recommend us on who to test and when to test? So patients diagnosed at any age with breast cancer that may help us to decide or to stratify the risk of relapse and decide on the use of a specific adjuvant therapy such as olaparib. We're going to be reviewing very shortly the evidence of the Olympia trial. But for example, if we think of a patient that is diagnosed with a triple negative breast cancer or a very high risk luminal breast cancer, or patients with a family history of a lobular breast cancer, diffuse gastric cancer, even male diagnosed with breast cancer, or when a patient has one close relative that was diagnosed at a very young age, younger than 50, or a relative that was a male diagnosed with breast cancer, or a very close relative diagnosed with ovarian cancer, of if the family burden of malignancies is very high, all these patients need to be referred to a genetic counseling. And guidelines are trying to adapt, are trying to evolve. since we are having more and more evidence that the more patients we test, the more chances we have to detect germline mutations. Specifically, this is very important not only for therapeutic strategies, but also for family counseling and for prophylactic strategies. If probably we are all familiar with the age criteria, and if we are visiting a very young patient that is age 30 years old, of course we all think of a potential germline mutation. But what about a woman diagnosed with breast cancer at the age of 50 years, for example? So probably there are like two different approaches. One is what we call is the mainstream testing, that it's only based on adjuvant therapeutic strategies, like is my patient a candidate or not for an adjuvant PARP inhibitor. And the advantages of this mainstream testing is that the more patients we test, the more chances we have to detect a germline carrier. And the other approach is an approach only based on family or genetic counseling. And it's very difficult to compare both strategies head to head, because both have pros and cons in terms of the implications for the patient, but also for our healthcare system. But it's very important to keep in mind that sometimes we may see an index case. That meaning that we can see a female that has no relatives with cancer, or even family that is not informative. And it's very important to keep in mind that it's not only about prior history in the family. But if we see a patient with a TNBC or with a luminal breast cancer, we need to always think about these potential germline carriers. So who should we test? This is a very practical slide. So we should test those who are eligible, potentially eligible for PARP inhibitors, both in metastatic disease and high risk early breast cancer. And also, if we consider this family history, test those with a history of breast cancer with maybe not an immediate therapeutic implication, especially if they are diagnosed at an age under 60 or 65. And how should we test? So the first approach should be to consider a healthcare physician directed testing, this mainstream testing for BRCA1 or 2 if the treatment decisions are very time sensitive. For example, think of a patient that is undergoing neoadjuvant therapy and she's gonna undergo a mastectomy, and you need to decide whether the patient is a candidate for a bilateral mastectomy, including the contralateral prophylactic surgery. But the second approach is to involve, of course, genetic counselors and to work very closely with them when we may need support when how to interpret a multi-gene panel testing, but also interpreting the results of these variants of unknown significance that can be a bit challenging for us as physicians. Can we somehow differentiate, or can we see any difference in the type of tumors when we diagnose an sporadic breast cancer compared to a germline mutated carrier with breast cancer? Probably these are like the 3 or 4 main characteristics. For BRCA mutated carriers, we will see at younger age at diagnosis, probably tumors with higher grade. There is a higher chances of being de novo metastatic disease, and also patients with bilateral breast cancer at the moment of diagnosis. I told you that we have now the possibility of administer adjuvant olaparib to our patients, and the main reason is this phase 3 clinical trial, the Olympia trial, that led to the approval of adjuvant olaparib in patients with early breast cancer with high risk of relapse. And there were 2 different cohorts: the neoadjuvant cohort, that meaning patients with TNBC that did not achieve a PCR after neoadjuvant treatment, and also patients with hormone receptor positive disease that did not achieve a PCR, but with an additional high risk criteria that we're going to be reviewing now, is the CPS-EG score higher or equal than 3. And the other cohort was the adjuvant group, those patients with TNBC with tumors higher than 2 centimeters, or patients with nodal invasion. And for the hormone receptor positive cohort, the criteria of high risk was considered patients with 4 or more positive lymph nodes, that meaning N2 disease. So patients were randomized in a one-to-one fashion to olaparib versus placebo for 1 year duration of treatment. Here you can see presented differently, but to reinforce this idea of which were the criteria of high risk in the Olympia trial, remember, TNBC patients with non-PCR, irrespective of tumor size or nodal involvement, and for patients with luminal disease, non-PCR, plus the CPS-EG score equal or higher than 3. And for patients that underwent upfront surgery for TNBC tumors higher than 2 centimeters or any nodal involvement, and for luminal disease, 4 or more positive lymph nodes. Here you can see the CPS-EG score. This is a very relevant score that has been validated for patients after neoadjuvant chemotherapy as a very good prognostical stratification factors that includes clinical stage, ER status, histological grade, but also post-treatment pathological state. It ranges from 0 to 6, and a higher score indicates a worse prognosis. And here you can see the original validation of this CPS-EG score, that you can see clearly that depending on the score, the higher the score, the poorer the prognosis, so the highest are the chances of having a recurrence in early breast cancer. So this score is very useful to stratify our patients that have undergone neoadjuvant chemotherapy in terms of when should we escalate adjuvant therapies based on this. The main endpoint of the trial, the primary endpoint, was invasive disease-free survival, but also a very important endpoint was overall survival. That is, of course, a main goal, specifically in early breast cancer in the curative setting. Here you can see the baseline characteristics. The trial enrolled more than 1,800 patients, and we have 50% of the patients coming from adjuvant therapy and 50% of the patients treated in a neoadjuvant fashion. I would like to highlight and to put your attention on the use of a platinum-based chemotherapy. 1 out of 4 patients treated in the Olympia trial received platinum-based chemotherapy. And why is this relevant? Because you know that classically the use of platinum salts has been associated with potential cross-resistance to PARP inhibitors, because remember that PARP inhibitors are applying this concept of synthetic lethality. Sorry. So there might be somehow some cross-resistance between the use of platinum salts and the use of a PARP inhibitor, but 1 out of 4 patients in the Olympia trial were treated with platinum salts in the neoadjuvant setting. And in terms of the subtypes of breast cancer enrolled in the trial, the vast majority of the patients enrolled in the Olympia trial were TNBC, but 1 out of 5, that meaning nearly 20% of the patients, were hormone receptor positive, HER2 negative. The trial met its primary endpoint with a clear statistical and clinically meaningful difference in terms of invasive disease-free survival, reaching 85% compared to 77%, with a hazard ratio of 0.58, statistically significant. And in the subgroup analysis, in the forest plot, you can see that the results were consistent irrespective of the prior use of a platinum, irrespective of the adjuvant or neoadjuvant approach, but also irrespective of hormone receptor status. Here you can see that the confidence intervals are wider when the subgroups have a smaller sample size. In terms of statistical significance, it makes sense to have a wider confidence interval, but the estimation, the punctual estimation, was consistent with the primary analysis. So we cannot say that there was a strong statistical evidence to see any heterogeneity in the different subgroups included in the trial. So, which is very relevant is that olaparib demonstrated an overall survival benefit. It's very challenging to demonstrate an overall survival benefit in the curative setting, in the early breast cancer arena, because there are so many things that can influence the overall survival of a patient after a diagnosis of an early breast cancer, that the use of a very low number of drugs can influence and can have an impact in overall survival. Indeed, not even many endocrine treatments that we currently use and that have expanded use worldwide, some of these endocrine therapies have not demonstrated any overall survival benefit at all, but we are using them. But here we are in an era where we are using targeted therapies based on a biomarker selection. And probably this is one of the key aspects of the clinical trial, that if you use targeted therapy based on a pre-selection of a specific biomarker, because the main relevance of BRCA in breast cancer is that it's not only prognostic, it's prognostic and it's predictive of a benefit of a specific therapy. That's where you have a higher chances of success when administering a targeted therapy in the adjuvant setting. And here you can see also the consistency in the forest plot for overall survival. And in terms of recurrence, the type of events, it's very interesting to see that, for example, olaparib not only improved IDFS and OS, but also the number of events of distant recurrence. And I think this is critical, because once a patient relapses with a distant recurrence, that meaning a metastatic disease, the aim of the treatment is not curative anymore. So we have we have only one chance to cure our patients. Yeah, and it's in the early setting, right? So if we as physicians aim to cure the higher number of patients, the highest number of patients as possible, our best chance to cure these patients is by using these new drugs on a biomarker based strategy in the curative setting. And also you can see the distant CNS recurrence. That is also very, very important, because if we think of a patient with a TNBC in the early setting, many of them, more than half of the patients, will experience CNS progression as part of their disease journey. So if we have a drug in the early setting that can diminish by half the chances of developing CNS recurrence, I think this is fairly relevant. And in terms of adverse events, we have been using PARP inhibitors in gynecological malignancies, specifically in ovarian cancer, for many years, and we know that the toxicity profile is specifically dependent on the hematological profile, right? So what we could expect in patients treated with olaparib is, of course, anemia as the main adverse event, and also some GI toxicities like nausea and vomiting. But the vast majority of the patient did not discontinue the drug because of these adverse events. And also the real world evidence, the real world practice demonstrates that we can support, we can empower our patients to keep and to be adherent to the treatment, because we know that in early breast cancer, adherence to therapies is the key to success. So indeed, the vast majority, 75% of the patients, achieved and completed the 1 year per protocol olaparib without any dose reduction. And for those patients that had a dose reduction, that meaning 25% were due to an adverse event, and once you reduce the dose, the adverse event completely resolved, and only 11% of the patients had to discontinue olaparib due to an adverse event. And this is coming from clinical trials that you all know that the protocols in clinical trials are very strict in terms of when to discontinue a drug. So you can imagine that in the real world setting, in the real world practice, this proportion of patients discontinuing olaparib in the adjuvant setting is even lower than what we know from the Olympia trial. There are some controversies before we move to the ovarian section. There are some controversies that we all know, because there is always this research gap, since clinical trial is designed and from the readout of the trial, since the standards of treatment are rapidly evolving, rapidly changing. For example, for TNBC, we know that now the vast majority of patients are treated as neoadjuvant strategy with a combination of chemotherapy plus immunotherapy plus pembrolizumab, right? We have the Keynote 522 trial, but the proportion of patients with a known BRCA mutation in the Keynote 522 was very, very, very low. So how do we apply the evidence we have with adjuvant olaparib in BRCA mutation patients that received prior chemo immunotherapy in the neoadjuvant setting? Well, we don't have prospective evidence addressing this issue in early breast cancer, but what we know in other trials, for example, in gynecological malignancies, but also in metastatic breast cancer, it's that it's completely safe to administer concurrently a PARP inhibitor plus an immune checkpoint inhibitor. So we can administer pembrolizumab plus olaparib, and it's completely safe. And also, if we think of another option, the use of capecitabine, what we know is that in the metastatic setting, probably those patients with a BRCA mutation, the intrinsic subtyping of those tumors is basically a basal-like tumors, and those patients were the ones that did not really get a benefit from the use of capecitabine. So I would not recommend to use adjuvant capecitabine for a patient with early breast cancer in the adjuvant setting. Thinking of the CREATE-X study that led to the approval or to the incorporation in the clinical guidelines of capecitabine in those patients that do not achieve a PCR after a neoadjuvant setting. And also, we have some evidence from the metastatic setting, the Olympia AD and EMBRACA trials, but in both trials, a PFS benefit was clearly seen of a PARP inhibitor over treatment per physician's choice, and capecitabine was indeed the most frequent chemotherapy used. So again, we have another argument, another element to be taken into consideration, that probably capecitabine can be underperforming in these patients in the curative setting. So our guidelines for TNBC, if we have a clinical stage 2 or 3 and the patient did not achieve a PCR, there is a recommendation for 1 year of adjuvant olaparib plus minus immunotherapy. Why do the guidelines say plus minus? Because there is no prospective evidence, but I must confess that we here in Spain, at least at my institution, if I have a patient with a BRCA mutation and she underwent chemo immunotherapy, we commonly administer adjuvant olaparib plus pembrolizumab in the adjuvant setting. And for those patients with a clinical stage 1 that underwent surgery, and if they meet the criteria of having a tumor greater than 2 centimeters or in any nodal involvement, those patients are also treated with 1 year olaparib. And for hormone receptor positive, HER2 negative patients, we know that now we are in an era where we are administering adjuvant CDK4/6 inhibitors. So maybe an interesting clinical question is, can we think of a potentially of doing a sequential olaparib and abemaciclib? Well, this is something that needs to be discussed with the patients. Again, we don't have any prospective evidence supporting this, but I think that probably eventually for some considered very high risk patients, we can do this. And I can share with you very recently, I have done this. I have applied this strategy. I have a very young patient. She's only 34 years old, and she has a BRCA2 mutation, and she was diagnosed with hormone receptor positive, HER2 negative, T3N3 disease at diagnosis. That meaning a very high risk, very locally advanced disease. And my strategy with her was neoadjuvant chemotherapy, surgery, 1 year of olaparib, and currently she is receiving. She's in the first year of abemaciclib, so my intention is to administer the 2 years of abemaciclib according to the monarchy. But it's very difficult to compare both drugs, olaparib and abemaciclib, because different trials, different inclusion criteria, different selection. But what is the main key difference? For a PARP inhibitor, we have a biomarker-driven strategy. For an adjuvant CDK4/6 inhibitor, we don't have any biomarker beyond ER positivity. So if we want to be coherent when we talk about precision medicine and biomarkers in oncology, well, we have a biomarker in breast cancer, right? We have BRCA. Why should we prioritize a CDK4/6 inhibitor to a PARP inhibitor when we have a clear biomarker as BRCA that is prognostic and is predictive? So I think it makes sense to start with olaparib in these patients, but of course, again, and this is the same idea I mentioned previously. If we do not test, we won't get any chance of diagnosing these patients that are potentially germline BRCA carriers. So it's very important. Probably we all think of BRCA when we treat triple negative breast cancer, but please remember that also patients with hormone receptor positive, HER2 negative breast cancer can have a great benefit overall survival with adjuvant olaparib. And here you can see what could be a proposed algorithms by our colleagues from Dana-Farber Cancer Institute. And for those patients with nodal involvement, olaparib plus endocrine therapy should be considered, and also for those patients with very, very high risk, also the sequential use of olaparib plus endocrine therapy followed by sequential abemaciclib. And also for those patients that do not achieve a PCR and have residual disease in the nodal sampling, I think that I would also consider those patients candidate for sequential olaparib and abemaciclib. And here you can see what the ESMO guidelines recommend for any patient with a germline BRCA mutation 1 or 2 and a stage 3 or high risk according to the criteria of the Olympia with a non-PCR. The guidelines are very clear, recommending olaparib for 1 year. And you can see there that in the green box it says SCAT1A, and probably you are familiar with the SCAT scale from ESMO. Is the clinical actionability of a molecular target, and only those drugs that have an SCAT tier of 1, the clinical implication is that access to treatment should be considered a standard of care. And here you can see that for olaparib is SCAT1A, that meaning that according to ESMO, adjuvant olaparib should be considered a standard of care for these patients. So remember, who is eligible for adjuvant olaparib? TNBC with non-PCR or patients with upfront surgery, tumors greater than 2 centimeters or any nodal involvement. And for luminal breast cancer, those who underwent upfront surgery and had 4 or more positive lymph nodes, and those who underwent neoadjuvant chemotherapy and had a CPS EG score equal or greater than 3. And now let's move to ovarian cancer. As I previously mentioned, the relevance of PARP inhibitors is because they engage and they synergize with this synthetic lethality of altering the main mechanisms of repairing DNA damage. And probably the history of homologous recombination is beautiful, right, in gynecological malignancies, because ovarian cancer has led the development and also the understanding of the relevance of this DNA repairing pathway as a main engine of promoting tumorigenesis. But very similar to what I mentioned in breast, is not only HRD, is not only BRCA1 or 2, because there is a plethora of genes that take part in this very complex mechanism, which is called the HRD status, right? You can have BRCA1 and 2 wild type status, but there are other genes that are involved that can be misfunctioning, that can create a state of homologous recombination deficiency in the tumor. And what we know is that nearly half of our patients with advanced ovarian cancer will have an alteration in these homologous recombination repair genes. So nearly half of our patients with ovarian cancer will have an HRD status. And there is a clear prognostic impact of HRD. If the highest score you have, the higher score you have with the HRD, the higher the probability of survival. And this has been validated and prospectively assessed in all the clinical trials in the first line setting, irrespective of the PARP inhibitor that they use. You have the PRIMA trial, you have the PRIME trial in Asian population, you have the Athena trial, and also the Paola one. And the history of olaparib in ovarian cancer is also a history of success. It's more than a decade that we learned that for those patients with a platinum-sensitive relapse, the use of olaparib compared to placebo improved clearly the median PFS, and this was in the relapse setting. So we moved toward a new paradigm on how do we design clinical trials in the first line, right? After the patient has received first line chemotherapy, it's critical to put our patients under some maintenance strategy, because what we know is that even if ovarian cancer is highly chemosensitive, unfortunately more than half of our patients, more than 50% of our patients will experience a relapse in the first 2 to 3 years if we do not administer any maintenance treatment at all. So here you can see all the main clinical trials, the phase 3 trials that addressed the use of PARP inhibitors in this front line. Again, we cannot do cross trial comparisons, different populations, different criteria, different drugs, even different duration of the treatments, but I will try to focus on the main results of the clinical trials and how do we apply the results in the clinical practice. So as a primary endpoint, all of them had progression-free survival. All of them, irrespective of using olaparib, niraparib, olaparib plus beva, the PAOLA-1 trial, or the Athena trial with rucaparib, all of them were positive. That meaning that if we use a PARP inhibitor after chemotherapy, the patients will get a great benefit of these adjuvant therapies. But there are some subtle differences that may lead to different clinical decisions. Because, for example, the SOLO-1 only admitted BRCA mutated patients, and probably this is the trial with the longest follow-up, but also with the highest benefit, right? Here you can see how the curves clearly separate. Probably this is one of the most clear Kaplan-Meier curves. It's very difficult to discuss it. You can see a hazard ratio of 0.33. So this is undoubtedly a very impactful drug. So patients with a BRCA mutation clearly benefit of adjuvant olaparib. And also the time to the first subsequent therapy is delayed. So it's not only about PFS. The patients with all these surrogate endpoints, you can see that those patients who with a BRCA mutation that receive adjuvant olaparib after chemotherapy, they get a benefit in terms of delaying the first subsequent therapy. The PRIMA trial was the trial with niraparib, and here you can see the benefit in terms of PFS. But this is something that was quite surprising, that the PRIMA trial did not demonstrate any benefit in terms of overall survival. So the only drug that has demonstrated an overall survival benefit in ovarian cancer is olaparib. Niraparib did not get the chance to demonstrate an overall survival. It's also important to take into consideration, you can see in the green box that nearly 60% of the patients in the placebo group received a subsequent PARP inhibitor therapy. So probably this crossover effect may have influenced the negative results in overall survival. So as I told you, it's not only BRCA, it's very important to know this concept of HRD, homologous recombination deficient, that can affect nearly 50% of our patients, and it's a great biomarker to be exploited in terms of selecting a targeted therapy. So here you can see the results for BRCA wild-type HRD positive ovarian cancer for the PRIMA trial, niraparib, Athena mono with rucaparib, but also with PAOLA, olaparib plus beva. And here you can see that also these patients that are HRD BRCA wild-type clearly benefit of an adjuvant PARP inhibitor. So this should be also considered standard of care in these patients. But what we know is that for HRP homologous recombination proficient, there is a clear unmet need, because the benefit of using a PARP inhibitor irrespectively of plus or minus beva is very, very, very limited. So probably these HRP patients are very good candidates to explore other pathways, other agents, like for example antibody drug conjugates. And in the Paola trial, the combination of olaparib plus bevacizumab was compared to placebo plus bevacizumab. And the trial demonstrated an overall survival benefit in HRD positive subgroup, including both BRCA wild type and BRCA mutated patients. So again, we have an option that is the combination of olaparib plus bevacizumab that has a clear impact, a clear benefit in these patients with HRD positive biomarker. Here you can see specifically the results for BRCA wild type HRD positive, and there is a difference in more than 10 points in a 5-year overall survival rate with a hazard ratio of 0.71. So in the 5-year analysis, when you stratify according to the classical high or low risk criteria, you can see that both groups benefit from the use of olaparib plus bevacizumab. But for example, in the lower risk group, that probably this patient that undergo primary cytoreductive surgery, stage 3, and that classically we don't think of them as good candidates to do a doublet. It's like an escalating therapy, but specifically those are the ones who benefit the most. You can see the red curve, it's approaching to nearly 100%. So that meaning, again, this concept of when do I have the higher chances of curing a patient with advanced ovarian cancer? So probably even if they have a low risk, if you go for adjuvant olaparib plus bevacizumab, the chances you have of curing those patients are the highest. So I think it's a very good combination to take into consideration. And here you can see the same for specifically HRD positive patients that both high or low risk benefit from the use of adjuvant olaparib plus bevacizumab. And as I mentioned, the PRIMA trial with miraparib did not demonstrate an overall survival in both intention to treat and also specifically for HRD patients. And as it was expected in HRP, there is no benefit, not in PFS, but also not in overall survival. So I'm just summarizing. This is what the ESMO guidelines recommend in advanced ovarian cancer, stage 3 or stage 4. It's critical to testing. I always say to my medical interns, to my medical residents, that we should not be treating any ovarian cancer patient without knowing BRCA status or HRD status. Testing is critical. We are in an era of precision medicine. We are in an era where therapies should be guided by biomarkers. So if we have a biomarker that has demonstrated prospectively that you can better select the treatment for a patient, let's use it. So for BRCA mutated patients, the clear benefit of a PARP inhibitor, and you saw the results for olaparib in the SOLO-1 trial, but also olaparib plus beva according to the PAOLA trial, overall survival benefit. If we go for BRCA wild type HRD positive patients, remember the only trial that demonstrated an overall survival benefit is the PAOLA one, olaparib plus bevacizumab, and for BRCA wild type HRD negative HRP proficient patients, well, you can go for niraparib, rucaparib, bevacizumab. All of them have a PFS benefit, but probably the overall survival benefit is very, very limited. So I foresee in the future that for these patients, we probably explore other potential therapies. I'm just finishing with the ESMO magnitude of clinical benefit scale. I don't know if you're familiar with this scale. This is the scale that we use in ESMO for scoring drugs and to capture the clinical benefit. And only those drugs that have a score of 4 or 5, meaning a substantial benefit. Indeed, olaparib is the only PARP inhibitor that achieved a score of 4, that meaning a substantial benefit compared to other options of PARP inhibitors. And with that, I would like to close my talk. And again, thank you so much for your attention. Thank you.
All right, thank you. Congratulations, Dr. Rodrigo, on a well-received talk. I hope we're not keeping you beyond your bedtime. I think it's now after 10 p.m. there in Spain.
Yeah, exactly.
Yes,
It's
okay.
10 p.m. Yeah.
But we just want to have a few questions, if there are any, for Dr. Rodrigo. No? If there are no questions, we want to thank you again for joining us at the Caribbean Gynae Cancer Symposium. And we'll speak soon.
Thank you. Thanks.
Appreciate it.
Thanks
Have a
so
good
much.
night.
And
Okay.
enjoy the
Oh, sorry,
symposium.
there's a
Thanks so
question.
much. Oh, sure. Yeah.
1 second.
Yep.
I enjoyed your talk very much, Rodrigo. I'm a senior GYN oncologist from Toronto. You're here with the Caribbean group. And oblivious of what actually is happening in molecular biology in ovarian cancer. So I'm asking you, almost like a layperson now, is the key to ovarian cancer found in the lab? It's a very simple question, but you would give, I hope, a more detailed answer. Is the lab the key to the ovarian cancer? Because we know that surgery is only one complement of it, and chemotherapy, the same thing. So it has to be a molecular biologic, like you're doing now, immunotherapy and things like that. So what's your long wish that you would like to do?
Thanks so much for the question. I think probably ovarian cancer next to endometrial cancer has demonstrated that in gynecological malignancies, once we understand what is happening beyond the classical biomarkers and when we start stratifying patients in a molecular fashion, I think that we have this concept of positive biomarkers, who are the patients that clearly benefit from a therapy, but also I think it's very relevant to see the negative biomarkers. Which patients do not benefit from a specific therapy, and we need to exploit alternative pathways. So I think that lab studies, molecular biology will give us the key to cure more and more ovarian cancer patients. And indeed, this HRD concept was born when analyzing in an exploratory way all the samples coming from the main clinical trials, even in an era before we had access to PARP inhibitors, right? And the history of olaparib is beautiful, but also it's very dramatic because this drug was this close to be dismissed only because of a dosing issue. But once we got to this concept of HRD and BRCA, this is a key for success. So the way I foresee the future for clinical trials, I cannot understand all comers trials anymore because we cannot treat all patients with ovarian cancer the same way. Probably a patient with ovarian cancer BRCA mutated, a patient with ovarian cancer HRD, and a patient with ovarian cancer HRP, we have three different diseases, three different entities. The same way we don't treat the same luminal breast cancer, HER2 positive breast cancer, and TNBC. Can you imagine now performing a clinical trial with breast cancer patients mixing luminal HER2 and triple negative? Doesn't make sense, right? So probably with ovarian cancer, with endometrial cancer, we are in an era where we can perform clinical trials biomarker driven, and probably we can better stratify and we can better select which patients will benefit the most, but which is more relevant, do not expose patients to treatments that are potentially toxic and they may not derive any benefit.
Great. Thank you so much. All right. Thank you again, Dr. Rodrigo, for a wonderful talk. Appreciate it.
Thank you. Thanks so much. Enjoy the symposium.
Yeah. Our next speaker is an associate professor of obstetrics and gynecology. He's also an associate professor of medicine and chief of the gynecologic oncology section, University of Chicago Medicine. Dr. Maroney received his medical degree at Loyola University Stritch School of Medicine and completed his internship at Walter Reed National Military Medical Center. His residency at the National Capital Consortium and his fellowship at the MD Anderson Cancer Center. He has numerous publications. Told me that he enjoys family life and loves to spend a lot of time with his family. It gives me great pleasure in inviting Dr. Maroney to the podium to speak to us on the emergent trends in multidisciplinary gynecological oncology care.
Thank you. Thank you. I see that lunch really wiped out a lot of our crowd. So good afternoon. Thanks for the opportunity and the privilege to be here to present the talk. My actual invited subject was robotic surgery, and the program, I apologize, doesn't reflect that. So we're really going to talk about robotic surgery. I'm John Maroney. I'm the section chief at the University of Chicago. This is our team. We're a large and diverse group. We're diverse with respect to different training backgrounds, seniority, areas of focus, and we're privileged to be a part of a National Cancer Institute, or NCI, Comprehensive Cancer Center, which offers us access to a whole lot of additional advanced therapies and specialists that we lean on to take care of our patients. A plug for the city of Chicago. If you haven't been there, I would strongly encourage you someday to go. Maybe your first trip should not be in the winter. Pick a summer month. It's a wonderful place with a welcoming character. It's a home of a beautiful river and lake views and one of the best skylines you'll ever see. It's also where you find some of the best hot dogs anywhere in the world, if you, in fact, someone who likes hot dogs. And of course, it's home to the world's best known Chicago baseball fan, Pope Leo, previously known as Father Bob. We're busy surgically, as you can see from this bar graph, with recent growth in our surgical volumes. I'll point out that this matters when it comes to outcomes. Repeated studies have shown that surgical volume by center and surgeon affects both complications as well as survival, particularly in women with ovarian cancer. We're a big group, and we have to be, because we take care of patients all throughout the Chicago region, which is very dense. These are our clinical sites. Enough about Chicago and us. We're here to talk about robotic surgery in beautiful Barbados. It's been a privilege to be here, and we've already soaked up the rays in the sunset. So a fitting place to start when it comes to robotic surgery is obesity. A growing issue I think everyone in this room is aware of worldwide, but particularly in Western countries. Remarkably, the presence of obesity in the US has nearly doubled within the past 30 years, with an annual increase of nearly 5%. Obesity is now affecting young women the most, with an annual rise of over 7% among those aged 20 to 29. Unfortunately, minority and underserved populations are affected disproportionately, with Black and Hispanic women with high rates of obesity versus white women. Of course, correlating with this rise in obesity is an increase in the incidence of endometrial cancer. Just recently, annual deaths in the US from endometrial cancer eclipsed those of ovarian cancer. And using age-standardized rates, you can see in the table that the United States and many Caribbean nations, including Barbados, have among the highest incidence rates of endometrial cancer in the world, according to the World Cancer Research Fund. So the standard of care for the primary treatment of endometrial cancer involves hysterectomy if safe and feasible. How should this be accomplished? The LAP2 trial, which is relatively old news, informs this. Published over 15 years ago, more than 2,500 early-stage patients randomized between laparotomy and laparoscopy for hysterectomy and staging. The primary endpoint of this study was non-inferiority of recurrence-free survival. Importantly, the hazard ratio establishing this was not met, likely though due to a lower event rate than was expected. However, overall survival with prolonged follow-up was not different between groups. Bottom line is that unlike in cervical cancer, the LAC trial, which I think most people in the room are familiar with, laparoscopy is not inferior to laparotomy with respect to survival outcomes. And that's where robotic surgery is so impactful. In the LAP2 trial, there were clear improvements in surgical complications, hospital stay, blood loss, and pain scores with laparoscopy relative to laparotomy. However, conversion rates were high with BMI and advancing age. Anyone with experience in robotic surgery will attest to the fact that the robotic platform, after a surgeon's learning curve has risen and plateaued at a high level, enables one to overcome the complexity introduced by these risk factors. So the last points I'll make about the LAP2 trial relate to surgical complexity. Node counts for laparoscopic cases were significantly lower than for laparotomy patients, and conversion rates to laparotomy were significant, as you can see in the slide. And they correlated closely with rising obesity and advancing age. In the absence of subsequent prospective data to guide a choice between traditional laparoscopy and robotic surgery, it's likely that the robotic platform plus surgeon experience make robotic surgery the preferred approach in certain resource settings permitting for the primary surgical treatment of endometrial cancer. More recently, several prospective trials comparing traditional laparoscopy to robotic surgery have been conducted, all with different measured outcomes. MAINPA evaluated surgical operating times within 5 years of the debut of robotic platforms in Finland. In 101 patients, the operating times were faster in robotic cases, and conversions to laparotomy favored robotic cases. In the RoboGYN 100 trial, 1004 trial in France, however, a superiority design did not favor robotic surgery over traditional laparoscopy with respect to severe morbidity. Instead, they were equal with similar conversion rates to laparotomy. Importantly, in both trials, the median BMI was less than 30. With the show of hands, how many OBGYNs or gynocs in this room would say that most of their patients with endometrial cancer have a BMI of less than 30? I don't see any hands. So for that reason, there's currently an Italian trial enrolling called the ROBEAST trial that compares traditional laparoscopy with robotic laparoscopy in endometrial cancer patients with BMIs above 30 only. Hopefully it will successfully accrue and further inform this question. So why or how does a robotic platform improve outcomes? These are the essential elements. A 3D camera, my preference is a 30-degree scope, wristed instruments. I think anyone who's done surgery can appreciate the difference between what you can do with this versus what you can do with this. And the fact that surgery is accomplished with significantly less physical effort than with traditional laparoscopy. I'm not familiar with a trial that can inform this in the current setting. However, once a surgeon has overcome the adjustment to the robotic platform, there is significant acceleration of anatomic mastery and surgical finesse, especially in the hardest cases. So, of course, the obvious downside to laparoscopy, to robotic laparoscopy, is cost. The capital expenditure is significant, ranging from just under $2 million to more than $2.5 million per robot. And each robotic instrument has a finite number of uses before requiring replacement, unlike traditional laparoscopic instruments. All this adds up to a more expensive per procedure cost. And in terms of operating time, it's clear that during the learning curve for a robotic surgeon, there are longer operating times. However, I would strongly assert that anecdotally, following the learning curve period, robotic cases eventually become faster than traditional laparoscopic cases. So to illustrate these points, I have two videos, if I can get them to work, to review, for you to review. I'll provide some anatomical orientation and commentary, but hopefully the video clips will speak for themselves and make my previous points about robotic surgery clear. So the first patient is a 53-year-old with a BMI of 35, with diabetes and hypertension and a prior cesarean delivery, who presented with abnormal uterine bleeding and menorrhagia to anemia. I was introduced to this patient with an urgent call from a benign gynecologist in the operating room who intended to do a hysteroscopy in D&C and encountered a large cervical tumor with hemorrhage. So with biopsies and packing, temporize the bleeding, and then the pathology you can see here is consistent with the grade 1 endometrioid carcinoma with staining consistent with an endometrial primary. Here are some CT images of her film. You can see on axial films, you can see a pretty bulky 8 by 9 centimeter cervical and lower uterine segment mass. And then if we switch to a sagittal view, confirms, and then a coronal view, just looks like a big barrel cervix. Based primarily on the endometrial primary as the source, I did counsel her for surgery. So let's see if I can get it going. Okay, so we'll at times speed this along, but this is entry into the left retroperitoneum in the pelvis. The deeper portion of the left retroperitoneum, you see the internal iliac artery on the left. Coming into view is the left internal iliac vein. And then within a short period of time, you start to see the uterine vessels separate from the internal iliac vessels, with the supravesical artery here. This is a close-up of the uterine vessels. You can see here essentially tractioning and then division of the internal iliac artery there. And yes, this is sped up. This is not actual time. I am not this fast. So this would be moving to another view, which is the vesicouterine peritoneum being divided here, and the bladder is up here, and the bladder is being dissected off of the uterus. Like the anatomy is markedly distorted related to the 9 centimeter cervical mass in this location. It doesn't usually look like this, but that bluish hue of the lower uterine segment is due to the tumor that's filling the space. And this requires a more caudal dissection of the bladder in order to essentially open the space. I'm going to speed it up a little bit. Now moved on away from the bladder back to the left parametria, where the left uterine vessels are being elevated and dissected free of this structure here, which is the left ureter. You'll see it moving along the way here. This is standard for a radical hysterectomy. This is the left posterior lateral or uterosacral division here. Moving on, I'm just kind of keeping it going because we're a little behind. There was no uterine manipulator, but this is an assistant placed in an EEA sizer in the vagina to identify the anterior vaginal fornix separate from the cervical mass. And so now we've made a vaginotomy, cut into the vagina, and now you'll see that big cervical prolapsing tumor that was identifiable on the scan previously in this space. And we'll speed it along a little bit. You have to like the fourth arm here is fantastic for tractioning. I'll say it again in another slide, but it's the best assistant you could ever want. And this is circumferential division of the specimen from the upper vagina. This is on the right side, and then just circumferentially kind of struggling to get around it. This is it goes into a bag and then it gets removed through the vagina. And then this is the vaginal apex reapproximated and ureters bilaterally that looked intact. So could this be done open or with traditional laparoscopy? Certainly. But I would strongly assert that it was much more manageable to do it with the robot than with straight stick. So this was her disposition. She had a robotic radical hysterectomy, bilateral salpingo-oophorectomy, and a pelvic lymphadenectomy. The whole procedure took 2 hours and 16 minutes. Estimated blood loss of 50 milliliters. Home with a catheter for a week, similar to most radical dissections. And her final path was actually pretty favorable. She had a grade 1 endometrioid carcinoma with inner 50% invasion, negative lymph nodes, essentially a 1A grade 1 endometrioid carcinoma, but because of the discordance with the tumor size and presentation, we did recommend vaginal brachytherapy for her. Next case, or takeaways from this, is that visualization matters. It's so easy to see up close and personal to these vital structures, uniquely with the robot in a way that you have a difficult time replicating with traditional laparoscopic visualization. We talked about the fourth arm, and then wristed instrumentation allows an angle of attack for some of those dissections that you just can't achieve with the limited degrees of freedom of traditional laparoscopy. Next case is a 56-year-old female, also with postmenopausal bleeding, underwent outpatient endometrial sampling, also a grade 1 endometrioid carcinoma, BMI of 36, unremarkable preoperative imaging, and I recommended a robotic TLH, that's not a TLN, BSO endometrial staging, or sentinel lymph node staging. I don't know if I can get this going. I promise I'm old enough. Okay, we'll speed this up. We're trying to catch up a little bit, so we'll speed this along a little bit. But this is just really to illustrate that kind of in real time sentinel lymph node staging. So there's the green node. You can see that after it's identified, it gets pulled away, tractioned, and dissected. You can see me just going to speed it up a little bit. This is moving over to the right lower abdomen, overlying the right common iliac vessels. Those are the gonadal vessels there that are being divided. And after doing that, then the peritoneum overlying the right common iliac vessels is elevated and dissected free of the nodal bundle posterior to it. And within that, and just underneath that nodal bundle or around it, are the common iliac vessels and then the inferior vena cava. And this peritoneum is being elevated to serve as sort of a parachute to retract the bowel cephalad. You can see the fourth arm retracting the small intestines there. This is the lateral border of the vena cava, and coming into view pretty soon, you'll see the right ureter. See, there's the ureter moving. And then this is being extended to the level of the duodenum. You'll see the duodenum coming in pretty soon in the right lower portion of this video. That's the cava to the left. Better view of the cava duodenum at the bottom of the screen. So that's the cephalad extent of the dissection. The nodal bundle you'll see there at around 12 o'clock, which will soon be elevated. This is taking it off of the vena cava. With the ureter over there on the right. This is over on the left of the aorta. The inframesenteric artery is in this bundle right here. You'll see when I put the infrared on that there's a green node in there. This is the lumbar vessel being desiccated and not ligated there. Aorta is just to the right of the right-handed instrument. Another lumbar vessel in there. And there's the sentinel node at the left side of the aorta. So eventually that comes out. Okay. Thank you for your help with that. And get me back to the presentation. Okay, so what's the point of asking you to watch those? It's really just to kind of seeing is believing, try and illustrate that. Can this be done other ways? Yes, but once you are facile with the robotic platform, it's infinitely easier, and I would assert safer to do it with the visualization and the instrumentation that's capable for that. In this patient's case, she had the surgery I mentioned. It took an hour and 42 minutes. She lost 25 milliliters of blood and was home for dinner. She ended up, though, with more concerning pathology, had a grade 2 endometrioid carcinoma with greater than 50% invasion, MELF pattern, which is a uniquely negative or poor prognostic finding, and she was mismatch repair proficient, so she was a stage 3C2. So all those nodes that we dissected that were visible on that scan, they were all involved. Which there's a couple different takeaway points from that. She did get a recommendation for adjuvant chemotherapy, which she starts in about a week. So takeaways from this. Laparoscopic surgery is the standard for the primary treatment of endometrial cancer. It can be done with or without a robot. But when available, a robotic platform does offer uniquely helpful integrated infrared visualization, access to both the pelvis and the upper abdomen without redocking, and then confident dissection of higher risk nodal basins. My heart rate and blood pressure are not normal when you're on top of the cava like that, especially when you get under the duodenum and you're in that kind of difficult neighborhood. Maybe for some other surgeons in the room, it's no big deal, but I would say the robot offers some advantages for that. So the summary for the talk is that surgery, and this is stating the obvious, is an essential part of the primary treatment of most gynecologic malignancies. And to do it well requires flexibility. One size does not fit all. And what we're asked and challenged to do is to be flexible with open, traditional laparoscopic, as well as robotic approaches, and know how to apply them in a patient-specific manner. However, the robotics platform with an experienced surgeon enables us to do more complex surgery safely and with equivalent outcomes. And I say that knowing that we're and I was really moved by some of the discussions earlier about the formation of the Caribbean Gynecologic Cancer Society as a response to an unmet need. And I know that this is a pretty resource-constrained area to practice. So I'd be curious to see what kind of comments or feedback there is about the fancy robot in a resource setting where it's variably available. And then last is that in order for this to be effective, the University of Chicago is a big place. We are in a very, very underserved portion of the city in some of the most disadvantaged neighborhoods in the Midwest, very dangerous and very poor patients. But we do have robots, and we have 11 surgeons. In order for this to work for us, we recognize that we're not all things to all people. So some of us, similar to a previous surgeon who talked today, do more of the ovaries, some of us do more of the robotics, and we tailor that. We have the luxury of tailoring that to the needs of our patients. So, thank you for listening.
Thank you, Dr. Maroney, for your talk on robotic surgery for endometrial cancer. Certainly, in the Caribbean, we have been seeing an increased incidence of endometrial cancer, and particularly we're seeing that westernized lifestyle with obesity as well. Unfortunately, we do not have robotic, and we can appreciate the role of the robotic surgery in patients who are obese with endometrial cancer. And unfortunately, we still have to be doing open surgery, and those persons increase risk of wound infection, DVT, etc. So we continue along that pathway. I know that one of our colleagues from Trinidad, Vishal, had done some work in this obese patients and so on, had published some paper on this, but that's where we are. We're not there yet. We're not there yet, but so if anybody have any questions or comments?
Thank you, John, for your presentation. I missed some of it, but I found it a very interesting presentation. And just to let you guys know in the audience, I wasn't familiar with the University of Chicago until they invited me up to a conference in Miami, and they spoke about what they offered there. And it opened my eyes to realize the quality of service that you guys offer. The amount of Nobel Prize winners, the latest research, the latest things that you're doing. And when I see you present on robotic surgery for gynecological malignancies, I guess when coming up in my training, it was something novel. There were a lot of studies that compared it with laparoscopic hysterectomies versus robotic hysterectomies, and they did show how much hospital stay and how much mils of blood loss less there was with a robotic compared to a laparoscopic. But modern gynae oncology programs, now fellowship programs, probably do not touch laparoscopic surgery as their primary teaching surgical technique, and they've transitioned into robotic. Now, I was in Jamaica probably, 14, 15 years ago, and there was talk about a robot coming. One of the concerns about a robot is obviously the patents, the reusables, the cost to the reusables, and it never took off. They built the theater for it. I remember they built a fantastic facility, a theater, but the robot never came. There is talk about a robot coming to Barbados this year. They've been told that the Da Vinci patent has run out and one is coming. It's a urologist that's supposed to be bringing it. And I don't want to say concern, is that I think we're missing out on the future, because obviously after our generation, I don't see much of the fellows being trained in laparoscopic. And yes, we know North America is a different healthcare system compared to here, where we look at resource settings and try to. What do you think in terms of the overall benefit? In your training, did you have laparoscopic surgery as a primary teaching tool, or was it always on the robot? And then do you think it has a particular role in more the third world cancers like cervical, the first world cancers like endometrial, or the complex cases like ovarian cancer? Sorry, John, I know it's a lot that I said, but just trying to get an idea where we're going in the future. Is this going to be the standard of care?
It's so hard for someone from my perspective to know how that translates to an area like gynecologic care in the Caribbean. But I did train completely pre-robot. So I didn't even see a robot till I was a faculty, and had to go through this big transition. And I was highly skeptical of it to begin with, but I will say that it is transformative for our patients. So as a priority, I do think that it helps some of the most vulnerable high-risk patients get through their riskiest period. A BMI of 60, a BMI of 65, where that you're not talking about morbidity, you're talking about mortality, quotable mortality with their surgery. It helps us do those patients' cases much more safely and with better outcomes. I don't use it for ovarian cancer. I think there's a pendulum that will swing back and forth and probably will always continue to do that, but I do feel that that it can take care of that, like what feels like a zebra, which is the early stage ovarian cancer patient. But what I teach my residents is that you always do have to have some kind of a palpable evaluation of the abdomen. So a fully robotic ovarian cancer staging, I think, is a mistake.
I appreciate your honesty. So back in 2011, when I did my training in gynae onc, the attendings there were traveling to Korea to get their robotic experience. There was only one or two machines in the unit that the general surgeons were using, but the gynecologists were going to Korea to get that volume. The institution that I trained at was a primarily cervical cancer based. It was in Asia, so they obviously cervical cancer rates were higher. They didn't have much of the endometrial compared to the ovarians that I saw. Now, with a specialty like bariatric surgery, where people, I'm going to bring this up again, practice in how to reduce obesity, and you're advocating the robot for obviously the morbidly obese patients, the obese patients, how do you think the new GLP-1s are going to factor into the use of the robot? Because if you're advocating it for the obese, and now we have a medication that could potentially change the demographic, not the biology of the endometrial cancer patient, you still using it as your primary tool for endometrial? You don't do much open, do you?
Pretty rarely.
Only the ovarians, or you do the ovarians laparoscopic?
We do the ovarians open almost. We do a lot of high pec too.
Right,
So
okay.
that's why we're open with the ovary
Yeah.
patients. We do very few laparoscopically. We actually do a lot of straight stick laparoscopy as well, almost as much for our trainees as any other reason. But a GLP, I don't know. I mean, that's a complicated.
Yeah, I know. I mean, every week
Um,
something new comes out. I remember when I first read about it, they talked about blindness. Now they're talking about severe bone loss, and you have to
Yeah.
keep it up. I mean, really and truly, we send. And my anesthetist has been telling me we are told that we have to optimize the patient for surgery, control their blood sugars, control their blood pressure. Now they're saying that the anesthetic associations are advocating the use of GLP, and guidelines are being rewritten for optimize their weight for surgery. So the whole dynamic of the patient you see in front of you, whether you're tailoring the patient to your needs in terms of making sure they're slim or what,
Yeah.
how many ever pounds they can lose, it's transformative, I think, until we know more of what's going on.
The ticking clock of a cancer diagnosis is going to make, the bariatric approach of medical optimization come back to me in 6 months. That's going to make that not so realistic. You're just going to have to roll with whatever the GLP landscape does on its own, I think. So I kind of feel like we'll be passengers in that respect.
Yeah. Thank you. I really appreciate it.
It's just a comment on how, in terms of healthcare in Trinidad. So I'm Vishal Bahal from Trinidad and Tobago. So I do a lot of laparoscopic surgery for endometrial cancer. I guess one of the main differences would be, well, we have a high incidence of fibroids. So even in some patients who can have minimally invasive because of the size of the uterus, it may limit. I've done a couple where, you put it in a laparoscopic bag, you exteriorize it, and you could sometimes cut the specimen, but again, not preferable. What I do find, for laparoscopic surgery, I would use a 5mm camera, 2 5-ports, and sometimes 1 5 on one side. So usually it's 3 ports in total. And for a big patient, I may use a 4th port to help retract. I can see the big value of robotic with the morbidly obese patients because it is a struggle laparoscopic for the obese patients. But the big factor for that may inhibit us getting a robot is the cost of the consumables. Because right now the surgeons, everybody use laparoscopic surgery, so the equipment is there, and we do have limited resources. And I think as a administrator or in politics, if they had to put money in it, they may go in money in terms of value-based healthcare or preventative medicine first, and then see how things go. But I do see if there is a center where robotic surgery, like one center for the Caribbean, where people then go to, that may be more beneficial than individual countries. Yeah,
I could totally see that. Yeah, easier said than done. But thank you for listening.
Thank you again, Dr. Maroney, for such a wonderful talk and for the questions that came by. So our next speaker is a tenured lecturer in public health and coordinator of the MPhil PhD program in public health and epidemiology at the University of the West Indies, Cave Hill, Barbados. She devotes most of her time advocating for the development of palliative care services and education in the Caribbean, and she has been leading various initiative and advisory and palliative care development in the islands of Barbados. Dr. Grieve was a consultant for the Barbados Palliative Care Needs Assessment Project. She has worked with the Ministry of Health of Barbados. In fact, she has also received, what's this called, the National, she was section lead of the palliative care in the development of the Barbados National Cancer Control Plan in 2015 to 2018. And in 2016, she received a Commitment to Excellence Award granted by the University of Southern Caribbean, Barbados, in recognition of her work in palliative care. It gives me great pleasure in inviting Dr. Greaves to the podium to speak to us on palliative care in gynecologic oncology. Please help me welcome her.
I really wanted to save him from the bio. So good afternoon, everybody.
I forgot to mention, sorry, that Dr. Greaves she's a doctor, palliative care doctor at day and a comedian at night.
Yes.
Yes, okay.
It's true. It's true. It's true. Yeah. So I have the task of, keeping you awake at the end of a long day, and with a topic that I am very passionate about. But I am also not going to be in here at 5:15. So I need you to help me to stay on time. Okay. So that seems fair and reasonable. Okay. So very reasonable. I think so. And I think some people went off and had a good time, and you probably want to do the same. So essentially, what our colleague, as he was editing the bio, a big part of what I do is global palliative care advocacy. So I sit on the board of the International Association of Palliative Care at WHO meetings, etc. And I am here to mess up your whole day, in that I want you to leave here just not as a gynae oncologist, but as a palliative care advocate. Okay? So I think one of the fundamental things is that we still have a lot of challenges with persons not understanding what palliative care is. And so when Vikash WhatsApped me some weeks, months ago, I said, of course I'm coming, because this is my opportunity to kind of get some converts. So I'm not going to be overly scientific. I'm just going to give you the facts as they exist within our region, and explain the gap, the extreme, terrible gap. I hear you talking about robotics. It's wonderful. It's pretty. There is stuff that was fluorescing and all that. But then fundamentally, we have people who are still dying in ways that they ought not to. And that's the reality of what you guys face. You might do your best. You might have a recurrence, and you just don't have a health system that still has the capacity to respond. So I want you to take notes on your phone, etc., because there will be some resources that I will share at the end that I'm thinking that you might not know that they exist, and I want you to be able to tap into them, take them back to your respective islands, your classrooms, etc., and have more persons engaged. So I just want to start off by getting a feel of where you land in this room, just openly and honestly about palliative care. And so we are going to use a particular model. I did not get the little preview of how to use this slide. How to advance. What do I do? First one. No. Okay, so I will do this in my head. There's a little bit of it's going to come up. I can still do it in my head, yeah. Okay, so essentially the next slide was going to tell you how we were going to frame the discussion. So we're going to frame the discussion by making sure that we have the same common understanding. Then I was going to give you a brief history of modern palliative care, and that's probably my fault for sending the slides late, so don't worry about it, Darren. Do what you can. And then we're going to talk about the burden of illness and the justifications of why we have palliative care, why we need palliative care, and then some of the peculiarities that you might face as a gynae oncologist. So as it relates to palliative care, when you think of palliative care, what do you think of? What's your definition of palliative care? There's no right or wrong answer in this classroom, but there's an answer that I want you to take away. So come to the mic. Let's talk together. What do you think of when you think of palliative care? How would you define palliative care? Anybody? No takers? Seriously? Okay, so there's an emphasis on quality of life. Yes? Symptom management. Thank you very much. Who's next? Managing. Thank you. Yes. Thank you very much. Managing expectations. Anybody else? So we have a focus on quality of life, symptom management, managing expectations.
Isn't it related to the quality of life towards the end of life?
Quality of life towards the end of life, but we will broaden our scope. But that's really, really excellent. And please feel free to give me your name, okay, as we talk with each other. So what I would want to say is that I want you to remember the next couple slides. Everything that is really important is going to be in red. Yes? So there is a definition that we should be operationalizing. And it's a definition that's still a bit contentious right now, but the WHO has a 2002 definition of palliative care. And you will hear some of the things that you mentioned in there. And it says almost by rote that palliative care is an approach. So there's no necessarily set delivery method. It's an approach which the aim is about improving the quality of life of patients and their families who face challenges associated with life-threatening illnesses, okay? And it would emphasize, this is where the symptom management comes in, that there is impeccable management of symptoms. And it goes on to give some examples of what those symptoms are, but then it says, this is the part where most people get their heads all twisted and whatever garments they have on, all twisted. But it's applicable from the point of diagnosis and extends into the period of bereavement. So that means that palliative care could be applicable when you have patients who are in the curative phases of their disease. And it also means that after death, the death of the primary client, the palliative care still continues. Yeah? So that's the WHO definition. And we all know how individual countries feel about the WHO definition, okay? So you will find a slight twist and a mixing of nomenclature in America, where there is a bit of a conflation between palliative care and end-of-life care and what that looks like. And then you will find, like say, for example, in Australia, you will see definitions that speak to persons having advanced curative illnesses. And in Barbados, when we did our stakeholder analysis and so forth to find out what people were willing to have as their definition of palliative care, you had a holistic construct being adapted. Oops, it's going forward all on its own, darn. Okay. No worries. Okay. Right. I'm just going to put this right there. Okay. So you will find an adoption of the holistic construct. You will find an adoption of the improving quality of life, a little bit of tension related to the dual clientele. Not everybody's happy to care for relatives and certainly not necessarily to think about what's going to happen to them in bereavement. And then particularly because of the resource-limited setting, there was a concern about whether we could really adopt palliative care from the time of diagnosis. And should we actually just be focusing on end of life? So there's still that bit of a tension, okay? So I want to say here that why the life-threatening illnesses is so important, because if you had to go back to the 1990 WHO definition, you would have seen that it had a heavy focus on cancer. However, now there is the understanding that persons who have non-cancer illnesses have a higher palliative care burden, symptom burden than persons with cancer. So, for example, in our case number 1, from our colleague in University of Chicago, he had this lady, but she had her tumor, but she was also diabetic and hypertensive, I believe, in addition to being obese. And that's kind of like almost a perfect setup 20 years down the line to come with heart failure and kidney failure, etc. or some kind of end-stage renal disease or renal impairment. And so we want you to understand that you will have your patient with their primary gynecologic, oncologic illness, but they may also have burdens related to their chronic non-communicable disease that they may have, especially in the Caribbean setting. Everybody's with me? Where in most of our islands, 25% of adults have one or more NCD, okay? Right. So, goody. So, going through the construct again, impeccable management of symptoms, and I think this is important. So, some persons will say supportive care, some persons will say symptom management. The thing is to palliate or cloak the symptom as much as possible. So if you go back to the root word of what palliative care comes from, it comes from pallium, and the concept is to cloak, but not to cloak as to hide, but to cloak as to swaddle. So it's like you're taking that patient, you're taking their symptoms seriously, and you are actually swaddling them and taking a detailed history about what's actually happening with their symptoms. So it takes time. It takes time, and it's not, cups of tea and holding people's hands and just walking away. I don't know if Vikash remembers this, but I think it was a good couple years ago, probably like 9-10 years ago, he had referred a patient, and I had like, I don't know, it felt like maybe an hour and a half consult with him. He was like, what was wrong? I was like, nothing was wrong, but we had this complex wheel, and there was so much that the person was, that patients carry. And sometimes you cannot do that. You may not have the ability to spend an hour and a half unpacking the needs of a patient, but this is where the other components of the WHO 2002 definition come in. It mentions that palliative care is best delivered by a multidisciplinary team, okay? So that holistic approach that's going to take into consideration a person's spiritual needs, their emotional needs, their social needs, their specialist needs that you might take care of, that the oncologist might take care of. But then there's who wants to have their hair looking like mine today, like slightly hot, messy. So I remember, I don't remember if this was one of your clients, but one of the youngest cases I saw, it was a complicated case, a 14-year-old who passed away with ovarian cancer. And we were with her to the end. What was one of the last things she wanted done? Her nails. Blue nails, sharp tips, hair done, braids, and everything. So you want to remember that your client, your primary diagnosis is a person. And sometimes the most important thing to them might be that general physical attribute that they need addressed. Yes? Okay. And you can talk to Vikash about what happened and when she was 14 and why all of the rest of it. But we were just there to palliate. Okay, good. All righty. So let's just move right on. Who's keeping time? Where am I? Good? Okay, goody. All right. So in terms of where we are, if we remember why modern palliative care started, I'm hopeful that you will feel the gap where you exist and challenge yourself to fill that gap. So what happened I'm not sure how many of you recognize the face. Probably many of you do. I think a couple of people in Barbados actually had the privilege of meeting Dame Cicely Saunders. So Dame Cicely Saunders is credited for being the founder of the modern palliative care or hospice movement. So she has a very interesting history in that she was a social worker who became a nurse, who then became a doctor, and then she was a researcher as well. And she was at the time of people like Elizabeth Kubler-Ross, etc. And a lot of the things that we take for granted just came out of the fact that physicians or clinicians or healthcare providers were seeing things that they felt were untenable and they had to address. And they weren't afraid to increase their knowledge and their scope and to challenge themselves and go into difficult places. So she is credited, and there's a nice timeline that you can use to kind of remember where we are. So before pre-1967, there was this massive assault on cancer. So there's the advent of radiation, there's the advent of chemotherapy, etc. But then there was also the abandonment of the patient as the patient. And I wonder how many of you feel that. And I wonder if the same thing might happen with the advent of robotics and other things that arguably the quest is man against disease. And in the quest of man against disease, we sometimes forget that the disease is being carried by a person who's living. And so that was part of why palliative care came in, because she felt that persons were reduced to diagnosis, reduced to particular beds. So if you were no longer curable and your surgery was not successful, etc., you were deprioritized and almost dehumanized. And I want to challenge you, are you seeing that where you are? If the person has an advanced and incurable phase of their illness, what appointment time do they get? Do they actually get to see you? Do they have a holistic network of support being built around them? If you have control over a department or a private practice, have you built a cushioning, swaddling mechanism or mesh or matrix around your patient? Or are you kind of like in that pre-1967 modality because of the resource limitations? Anyways, between 1967 and 1987, there was a massive growth. So what happened in 1967? There was the opening of the first hospice, modern hospice, is St. Christopher's Hospice in Sydenham in London. And then between 1967, you have all different kinds of people coming on board. I'm not sure who's here from Canada, but a real rapid growth in Montreal, McGill University, and then WHO getting on board. And we have things that we take for granted now being developed, like WHO analgesic ladder, cancer control programming, chairs and academic programs being facilitated. And for those of you who have academic positions, like Vikash has an academic position, Darren has an academic position, I want to ask you, how are you incorporating palliative care into the medical students that you see and you have the opportunity to mold and impress? So then we have the post-1987 era, and I'm just going to show you some classic pictures. So yes, palliative care was positioned historically a little bit in the context of faith and caring for persons through charities. And if you are part of a charity, it doesn't have to be a faith-based charity, but if you're a physician and you're an advocate, is there a role for Ghanaian Oncology Association in the Caribbean to partner with charities, etc., to facilitate the growth of palliative care in our region? So I'm just going to show you St. Christopher's Hospice logo, and I just want to show the positioning of Dame Cicely Saunders in this picture. So, classic surgical ward round is that you are with your team, you're doing your post-op round, you're walking around with your, 5 or 6 other staff members and a couple other students. Person's just had major surgery, you're kind of getting on with it. And you're around them, and then they're in a position of what we will call, they're not very empowered, they're laying on their beds, not necessarily always understanding what we're saying, and sometimes being very afraid. So what palliative care does, it says, okay, let's democratize this relationship, let's flip the switch, or the script, and come down to their level, sit down and spend time and that kind of a thing. And that's why we want to encourage persons to, where your hospital does not necessarily facilitate this, if you have the opportunity, tap into other community palliative care, bring them in, or advocate within your hospital for these kinds of services to be available. So I just have a little bit of a list of sorts that I kind of mentioned before. So things that you can credit to or partly associate with the palliative care movement. So we want you to remember Ghanaian oncologists, total pain, total management. I feel like I want everybody to say it with me, total pain, total management. So the pain, sometimes we get these referrals and the patient is in pain all over. Anytime you hear a patient saying that all over is hurting, that's not physical. It's not possible for everywhere to hurt all at once. And you are doing your best with your pharmacologic measures, but it's not really going to work because it's a social or emotional or something else is going on. And especially for those women who are moms. And our hospitals do not necessarily allow moms to be with their children. Not with meaningful visiting time. Sometimes not with exams going on. Sometimes not with the anticipatory loss. I might not get to see my child grow up. I might not get to see my child graduate. I might not make it to the next birthday. So total pain, total management, yes? So you have to remember that biopsychosocial model of pain. And if you find that you have a complex pain syndrome going on, if you have community palliative care or palliative care in your hospital, or even if you have to get, most people go backs against the wall once you mention psychology or psychiatry, but maybe even anesthesiology could get involved to help you to unpack the complex pain syndromes. In our community, we are blessed that we have patient control, PCA pumps, and so forth. I know not all of the islands will have that, but constant pain needs constant management. Gone are the days where, yes, you have your anchor thresholds for things like morphine and so forth, but then you have liberal amounts of breakthrough pain medication should be available. And there is an essential list of palliative care medicines. Barbados is fortunate in that all of the essential medicines are available free of cost on our formulary. But I would invite you to go back, engage with your health teams at your Ministry of Health and so forth, and find out if you have all of the necessary essential palliative care meds in the formulations that you need. Yes? So that might mean if a person loses the ability to swallow and maybe they have poor venous access, do you have access to transdermal patches, et cetera, et cetera? Some of the things, I know some countries have everything that they could possibly need, and there's a whole debate about opiate diversion in the north, but there's a lot that we can do with what we have. Okay, everybody still with me? Right. So I just want to say that regardless of where you are now, there are national associations that you can join, and you can lend your voice as an oncologist, as a gynae oncologist, to the palliative care movement. And so in the Caribbean, we have 3 very strong palliative care societies: Palliative Care Society of Trinidad and Tobago, Palliative Care Society of Jamaica, Palliative Care Association of Jamaica, which was formed by a colleague, Dingle Spence, and then Barbados Association of Palliative Care. I can't disclaim it. I am a founding director of the Barbados Palliative Care Association, but that association has continued to run in a multidisciplinary way with a focus on care provision. And this was the first Caribbean Palliative Care Conference. I think those of you who are from Jamaica will recognize Dingle. There's Karen Cox there from Trinidad, some colleagues from St. Christopher's Hospice, and the person that you can't really make out who's kind of fuzzy in the pink, that's me. Anyways, right. So, coming on to the last 10 minutes, okay? Why should you care? Why should you care? You've spent time learning, doing your surgeries, going on your fellowships, specializing and drilling down. Why should you care about providing palliative care? Hate to break it to you guys. Hate to break it to you guys. We don't actually control the physiology of death. We don't. If we could control the physiology of death, everybody would be alive. But there comes a point in time, in your situation, probably most commonly, you might not be able to stop the cervical hemorrhage if the person comes in too late. You might not be able to stop that ureteric obstruction and that hepatorenal failure, resulting in hepatic encephalopathy and hyperkalemia, arrhythmia, and death. So I think one of the things that when you read your literature, it will tell you to do is to make sure that you're maintaining your skills that help you to benchmark your patients and to understand when it's okay to deprescribe, when it's okay to have those conversations where the patient understands truthfully about what is realistically happening to them and what's possible, and what their prognosis is, and how valuable the remaining time is, and what a beautiful time they can have if they want taking full control of their lives. Everybody's with me? Yes, okay, perfect. Okay, so what I want you to remember, in the interest of time, I'm just gonna pop forward 3 slides. So this is a classic definition from Watson et al., 2005. This is one of the first Oxford handbooks of palliative care. And what they were trying to help everybody to remember in this is that all physicians should be comfortable with the ability and the need to handle persons with low to moderate complexity, low to moderate palliative care complexity. And you might ask me, well, what is low? What is moderate? How will I know? Yes? So well, for you guys, you have a bit of an advantage, but we would say things that involve the need or necessity for intervention. Say, for example, chest tube placement for drainage, certain kinds of nerve blocks, etc. Complicated coping cases with persons with maybe dissociative psychosis and those kinds of things. Things that trigger you to know that, hang on a minute, I need another specialist, another specialist in here. So what we find, though, is that because of lack of training and sensitization to palliative care, most persons are not comfortable with the low to moderate, and they then pass on to community palliative care or other palliative care teams far too easily, and then those teams become overwhelmed. So I found the course, guys, from the Royal College of Obstetricians and Gynecologists on palliative care. I looked at it last night. It's only £64. It looks really good. If you have not topped up, I would highly recommend, and it's open for a year. It takes you through definitions of palliative care, basic skill sets. It offers 3 cases or so that you can go through. I'm just saying that there are resources out there that are available. If you're in the Caribbean, University of the West Indies, KPhil, has an Introduction to Palliative Care 12-week course that is offered in the evenings online in the second semester of every year. So that's something that you can tap into. And then there are massive open online courses that you can join. If you go to the International Association of Hospice and Palliative Care, you will see a directory of services that you can choose the specialty that you belong to and the kind of course that you want. Maybe you want to top up on pain management. Maybe you want to top up on faith, etc. You can look at that directory. Okay. Am I converting anybody yet? Yes? Okay, good. Thank you. All right, goody. Okay. Okay, it doesn't want to go. I just wanted to then give you, say, for example, if you're not quite sure, I am pressing the right thing. If you are not quite sure, maybe I'm not sure where to point. Am I supposed to point in a particular way? What I wanted to give you, some. Yeah, advanced slide. Darren, we're going to rely on you because the clicker is having a moment. Okay, so what I want you to know is that when you talk to people about palliative care, there are some arguments that you may face, and so persons will ask you, well, we can't possibly provide palliative care for everybody. If that's the challenge that you have, decide as the gynae oncologist who the target population will be. Decide who will provide the care, if there will be a set of, thank you, it's not working, if there will be a set of gynae oncologists in the Caribbean who will then top up their skill sets and become persons who people feel comfortable referring to. And then as a society, you can even put forward your own guidelines, recommendations as to when care should begin in resource-limited settings. So the next slide, please, Darren, just reminds my friend who's a pathologist, when she looks at this, she sees a skull. So if you see a skull, just chuckle in your head, but if you don't, it's fine. But it's just I just have a list of it's not meant to be a complete list, but just to say that the bulk of palliative care occurs in the context of your office, of the primary care office, etc. It's everywhere, and it's only a few people that really need that super specialist intervention. So the next slide shows the course. So it's supportive palliative care, palliative and end-of-life care, and it's available, and it just seems like a good thing that you could probably try, just in case you feel a little uncertain, and it's okay. I have students that tell me, but if I'm involved in palliative care, does that mean that I have to be sad and sappy and like always happy? And they seem to think that the person who does palliative care is different and weird, and they don't feel comfortable with acknowledging that death is part of the trajectory. And so the next slide tends to be very, very useful for helping medical students to understand their role in palliative care. I'm going to share it with you as a framework. So our colleague mentioned about end of life. And I'm going to come closer to the screen here. So this is by Joe Harford. He was in the NCI program, National Cancer Institute's NIH program, and this is used with his permission. So palliative care is applicable from the point of diagnosis. And if you look at the rectangle of sorts, as the curative intent becomes less, the palliative care intent becomes more. Everybody can appreciate that? Yeah, fantastic. And then this is where the 6-month US model usually hits, where if you see prognostic markers like falling albumin, in your case, you'll see a lot of that, especially in your ovarian patients, and where you see your performance status falling and or your renal function failing, etc. That's where the palliative care intent becomes, palliative care becomes a dominant form of care. And then there's the extension into the period of bereavement. So if you can kind of remember that model, then you're going to be okay. The next slide, though, I think a lot of us miss this, and as gynae oncologists, you might see it, you might miss it. It would be really awesome if you could always remember the trajectory graphs for various diseases. So this is the trajectory graph for advanced cancer. So usually you have a person that you have treated, you've conducted their surgery, maybe they've had their radiation, maybe they've had their chemotherapy or their immunotherapies, etc. But then there is either increase in the tumor marker, they have rapid weight loss, multiple hospital admissions, etc. And you have this onset of incurable cancer. And then usually with a classic cancer patient, there's a rapid decline in about 8 weeks or so. And that turning point is usually the tipping point where the person is in your office and they mention that they had a fall, they were coming out to the bathroom or something like that. Something that tells you that there's been the onset of something like anorexia, cachexia syndrome, where they're losing proximal muscle mass, etc. The albumin is falling, they're getting a hyponatremia, those kinds of things. And sometimes we might miss it. And if we miss it, we miss the opportunity to talk to the patient and to help them to understand that they're kind of in crunch time. So I just wanted to remind everybody about that graph. Okay, so finally, if you're going to your policymakers, this is what you want to say to them. That palliative care in the Caribbean right now is crap. Okay? C-R-A-P. Next slide. And you can say, I'm not saying it. But I was really impressed with the guy from Spain because the university that was mentioned in his profile is the WHO Palliative Care Collaborating Center that helped us with the Global Atlas, University de Navarro. So the Atlas shows a disparity in Latin America and the Caribbean, and that none of our countries, can we say that together? None, N-O-N-E. None of our countries have integrated palliative care. Some of us are a little bit more advanced, like Trinidad is really doing well with their regional health authorities, but you can tap into this global atlas that was released in November 2025, and I have a QR code as well, so the next slide. And you can also share with your policymakers, because we don't like to rank poorly in global ratings. You can let them know that the next atlas will be in about 5 years. And so it actually has the new WHO model for integrating palliative care services. So next slide. And you can tell them that education is needed, policy is needed, access to medications, etc. There's a basic framework, and all of this stuff is freely available on the web. So if embarrassing them into action through the Caribbean Gynecologic Cancer Society, if you're not able to embarrass them into action, you can tell them, the next slide, you can tell them about the epi arguments, okay? And we heard this coming out. So it's really weird. Like the age standardized incidence rate for uterine cancer is 8. In the average Caribbean country, it's 14. That's a good argument. In addition to the food insecurity, the obesity, etc. While cervical cancer, we are doing better, arguably better than the global average, we're going to be up a creek as it relates to uterine cancers. So you can explain to them the number of persons who will have a particular condition and the extent of suffering. Some policymakers will need numbers. And then finally, 2 more slides, Darren, and then I'll ask you to stop. Next slide. You can drill down, and one more. You can drill down into the real stories about how people die and what needs to be palliated. If you need to tell them the stories of your patients who have lung metastases and are short of breath because of lymphangitis, carcinomatosis, or some kind of parenchymal disease or pleural effusion, go right ahead and do so. If you need to tell them about the complex pain syndromes that are inadequately managed, go right ahead and do so. And you can work out quite simply the needs assessments for your particular countries using something called the TIVET model. And these are the numbers for cancer for Barbados. And then I want to say to Darren that if you slide forward by 4, it looks like, and I think everybody will get these slide sets. Just go back 1, please. Just 1 before the legal obligations, right? What you can say is that there's a manual that is free, Free, designed from a massive Delphi study over the last 5 years by the International Association of Hospice and Palliative Care. I already gave my disclaimer related to that. You can download the manual. Your residents, your students can download the manual, and it will take you through basic symptomatology, use of medicines, and so forth, and it can be used to guide treatment. So the manual and the advanced and essential packages for both adults and children are now available as well through PAHO. And I just want to give you a heads up to look out for the PAHO regional webinars series, quarterly webinar series on palliative care in conjunction with IAHPC over the next 2 years. Okay? So I'm going to land the plane now. Okay? A little bit, you probably didn't get the warning to put on your seatbelt, etc. But just to say the slides are there, but it gives you the legal arguments, including the fact that all of the countries in the Caribbean, ALL, in 2014 signed the WHA resolution for palliative care integration in NCDs. So there technically is a little bit of a legal obligation as well. So everybody's with me? Yes? Okay, thank you for listening at the end of your day.
Thank you, Dr. Greaves, for your talk. I can see that you have a few converts there that you want to have. Yeah. But don't stay here. I have some questions for you. So I'm sure you use your comedic part of your life to help in your palliative care delivery sometimes. Yeah, okay. One of the problems we have in the Caribbean is, and I'm sure that discussing end-of-life care, discussing advanced directives is part of your but the problem we have is that sometimes that discussion is the relatives that really wants the patient to stay on forever. We don't have this culture of saying, do not resuscitate. How do you navigate that in Barbados, for example? Because we have a problem in that persons don't ask the patient, what do you want if your life should stop, if your heart should stop beating? It's the relatives who are pushing, even when the last breath is there, please do something, please do something.
So there are some legal gaps that still need to, hang on a minute, people. Okay, so there are some legal gaps, let's be honest, yes? So it is your right to have that conversation with the patient and let the patient know that they're in a different place and to document as best as possible what the patient wants. We still have the situation in the Caribbean where persons say, don't tell granny. If you tell granny what's happening, if you tell mommy what's happening, they're going to go down faster. And they want you to have the conversation with them and not with the patient. And that's totally inappropriate. You would get that MCQ question wrong, like 100% wrong, okay? You need to engage with the patient and respect their autonomy. But also, it's very important to explain to relatives that it's part of your duty, your medical duty, not to do anything that's going to harm a patient and only to do those things which are good And this all has to function within the context of what is reasonable and fair within the society and the justice mechanism of your country. Now, not all of our countries have a legal framework that respects do not resuscitate orders. And if that is the situation in your country, it's still good to document and to start having the conversation early with your patients. So there are various conversation models. So you can, yes, tell people that they're in a different place. You can also find out if they're big picture, detail oriented. Take it slowly, but I would really ask you to be honest with the patient, and it may mean that your back needs to be a little broad against the backlash of the family, but the patient really does need to know, understand, and agree to whatever care option is being advocated.
Good afternoon. Justin Pintard, IGCS Fellow from the Bahamas. Because of social and cultural issues, I guess we've seen a lot of patients often present in this discipline in advanced stages. Yes. Grandmother would have been having a postmenopausal bleed for a year, didn't tell anybody, then presents late stage endometrial cancer, that type of situation. In the Bahamas, we don't have a hospice. But again, in the short time I've been exposed to gynae patients, we've learned to adapt when patients get admitted and the family is unable to bring them home. We relax our visiting hours. We encourage them, the family, to come and speak with them and to stay with them, the pastor and all that stuff. However, you did mention lobbying governments for to get a hospice implemented in certain countries. From that aspect, governments don't see illnesses. Sometimes they don't even see patients. They see numbers. Is there any research or evidence speaking to the economics of hospice care versus someone spending time in hospital? Because we have such a small population, it's hard for us to give them that robust number to say, hey, it makes more sense to have these persons here versus in hospital.
So Darren, if you could go back to the thing with the little house. So palliative care, the model that is being advocated is the primary health care model as part of universal health coverage. So you can remind your governments that by definition, like literally in the definition, it says palliative care. So it talks about preventative services, rehabilitation services, palliative care services. And what you're putting forward is absolutely correct. If persons are cared for at the appropriate level of service, it saves the government money. You don't have a situation where persons are coming to A&E, having labs done, or maybe even in worst case scenario, in an ICU or something like that. Or I don't want to say this one because it's a little bit nuanced. So I would say it with caution. Accessing supportive products like blood, etc., that might not be useful. The person might not have the capacity to benefit, but because they're in a hospital, they might access particular services. So in the needs assessment, you just saw the numbers, but there are different kinds of ways to deliver services. So yes, you might have the traditional hospice where persons might go in close to the end of life and in the active dying phase. But you can also have the BAPC is a good example of that, hospice at home service. And unfortunately in Barbados, that market has been sucked up by the private sector and the government has not caught up as yet. So there's a little bit of a disparity. But hospice at home through multidisciplinary teams supported by nursing practitioners with the relevant care can save governments lots of money. So to answer your question, yes, you can look at the WHO models. You can look at the work coming out of the Palliative Care WHO Collaborating Center at University of de Navarro. And then you can look at, there's a metric coming out of University of Miami, Felicia Knoll, and that particular group. It's called serious health-related suffering. And that is also a metric that can be used. An economic metric is kind of like, but also a quality of life metric as well.
Okay.
Yeah.
Thank you, Dr. Graves.
You're
and
welcome.
Thanks for reminding us that palliative care is a dynamic process. It isn't
Yeah.
just a status.
Yeah.
Appreciate you.
And I want to affirm you in what you're doing in terms of the flexibility around the visiting time, and because there's two concepts there. Y'all, I could go on and on, but preferred place of death and preferred place of care. People should have the option for both. I might want to be cared for in the hospital, but I don't want to die there. I might want to go home, and vice versa. Some hospitals in Barbados will admit for death. Bayview is very good at that.
Thank you.
You're welcome. And some people want to die at home, yeah. Well, not necessarily. You hear his question? He asking me extra questions out here. He's asking if most persons want to die at home. It depends. So we've only done for breast cancer patients, the research for breast cancer patients, and they want to die at home in the context of not being seen as being a burden. So in your conversations with your patients, you want to make sure that they understand that they're not being a burden.
Further on that, they may want to die at home, but their family may not want them to die at home,
the
which is
duppy might
usually the
linger.
bigger problem, and that's
The
why
duppy might linger.
they bring them because they don't want to deal with having to sort out the police picking them up, and the death certificate is easier in hospital.
Okay.
But that's another aspect. Anna Kay from Jamaica.
Hello.
So Dr. Dingle Spence is there,
Yes.
and she has done wonderful work with the Hope Institute
Natalie
and
and
palliative care, but they can in no way manage the needs because it's in Kingston and it services the entire island. And we are fighting for our lives just to, as an oncologist, to cure and provide curative care. So from your experience, what practical advice would you give us as a new convert to,
Okay, so
to palliative care? What can we do in our clinics to de-hospitalize the care and improve the palliative care that patients receive?
So that's a beautiful question, because we're in the after August, we're going to be in the process of revising the manual for service implementation. So one of the things you can do is to figure out which models will work best for your society or your country that you're in, and give yourself at least a 5 to 7 year period to achieve it. Okay, so you might need to do some baseline research just to see what the uptake is likely to be and where the hospices are needed. Because sometimes we innately believe that people want to go somewhere else, but really they just want the support sometimes to stay where they already are. So the geographic location, the type of service model, and who it's best provided for. Education is critical, which is what Dr. Mitchell was saying. So you're educating the general public to accept the care in the first place. You're educating yourselves in how to communicate and how to plan the service. And you're also educating all of the support staff that you need. And Dingle was working on a diploma with the Ministry of Health to top up nurses and doctors in palliative care. And then Jamaica Cancer Research Institute, in conjunction with Harvard and Massachusetts General Hospital. So Jamaica might be slightly ahead in getting the education. So I would say some baseline research to see which models work. So maybe a hospice in St. Mary, maybe a hospice in St. T. It depends. But also, what some countries do, they repurpose existing services. So they may tack on hospice or palliative care onto hospital care, geriatric care, something that already exists, like district hospitals. So it depends on the kind of framework that already exists and what you can easily build on, because you don't want a situation where you have this idea that you must have this standalone building and you're forever like going after the quest of the standalone building. And because then that might, if you don't have a solid funding model, including government support in our setting, maintaining a standalone building is going to be difficult or more challenging. Okay.
Thank you.
You're welcome. Does that help? Yes? Okay.
Yes.
High pressure.
What is the role of the end-of-life doula?
I love it. Wow. Okay. So we have this concept of end-of-life coaching, and it's not widely seen here in the Caribbean outside of the context of sometimes spiritual chaplaincy. And the two are totally different. So if you have an end-of-life coach, so I should say that palliative care embraces the role of an end-of-life coach. We understand that when people can talk and they can discuss their pain, and also there's a concept called liminality, the fear of the unknown. Sometimes persons are not actually afraid of the point of death, but they're afraid of what might happen after death, depending on their worldview. And the doulas and so forth can help with that. And depending on if you have a doula that may also have prescribing privileges and various kinds of things, it can just make a world of difference.
Well, I didn't know anything about a doula until in 2024 when a relative of mine was diagnosed with ovarian cancer. And she died within 3 months, but she refused treatment. And then a doula she got the service of a doula.
If
so
she
this
was like
the first time.
Yeah, Western Canada, like Vancouver, BC, British Columbia area, that kind of thing, they are very advanced in their doula associations and stuff like that. You can have somebody who walks with you, who accompanies you all the way through.
I must say this happened in Jamaica.
Oh, wow. Very good. A private company? A private company?
I think she's private, yes. The doula is
That's
private,
wonderful.
Yeah.
Hi, good afternoon. I'm Eltora Bennett, OBGYN, gynae laparoscopist, and most recently I was the executive director for MD Alliance Hospital, where we have been forced to get into palliative care, actually, by the sheer need of some of our patients. So I have a very simple question. What actually is the difference between palliative care and hospice?
Right. So hospice, by definition, is a U.S. construct, which stipulates that a person is in usually the last 6 months of their life, and it's not applicable necessarily from the point of diagnosis where the person is in the curative intent. So if I had to go back to that diagram, instead of a vertical line cutting across the rectangle, you have a linear trajectory and then a solid line coming right down. So there's not that integrated pathway. Is that you go through a curative intent, you're deemed to be advanced and incurable, and then you can tip into what is called hospice care. Yeah, and it's usually for insurance purposes and other regulatory things, depending on where people are, you might have that 6 month cutoff. But some people use the term interchangeably, so you will see hospice care, palliative care, supportive care, sometimes all being mixed up, and depending on which side of the pond you are, you'll get certain tensions. Yeah, so that's the fundamental thing.
So legally, who makes that determination?
Technically, your medical legal structure for your country, based on the research that you want to do. Academically, yeah, the big major palliative care associations make those kind of decisions and definitional constructs after a lot of debate and stuff. So right now, IAHPC is proposing that WHO consider a new definition of palliative care that helps to relieve the burden of health systems that cannot support from curative phases and focus more on advance. But there's the possibility that might create a disparity as well. But it's really like how you have your ECOG societies and you come up with your frameworks and that. Yeah, it's kind of like that.
One last thing. I've noticed recently something that maybe the medical fraternity as a whole needs to look into, but certainly I think it will come under your palliative care definition if you say that it continues beyond the actual bereavement. It seems that everybody who dies now, no matter what the circumstances, needs the attention of a coroner and the complications of an autopsy and a prolonged period before the family can have the access to the body for burial. And I've had that experience too often recently, and I can tell you it really distresses the family who are left.
Yeah, it is true. And I don't know that is, I do believe that there have been discussions that have helped to sensitize police about the need to say sometimes respond quickly and so forth. Because in our legal framework, any home death especially is seen as unnatural and therefore usually has to get the coroner involved, and depending on the documentation and the meds in the last 24 hours. So usually with my patients, I usually make sure that they have a full instruction list. And sometimes when you present that full instruction list, which is the name, the date of birth, the diagnosis, the metastatic sites, the date last seen by the doctor, the medications given in the last 24 hours, the doctor's physician number, and so forth, sometimes once I just say, put it on the fridge. And when you go through that, and you are available to talk to the coroner, sometimes even real time, it makes it easier. But sometimes some families in the moment, you know, it might not always go well, but I think we just have to, I try to remember to give the coroners all of the information that they need. But then there's sometimes, say for example, somebody else might be responsible for writing the death certificate, and that hasn't happened. The medical certificate of death hasn't happened, and it causes an unnecessary delay in that element of closure. Yeah. Yeah. And they still insisted. Right. Yeah, you do. That's still a rule in Barbados. That is still a rule. So even though you are there as the attending physician, they still have to go and get the district police officer from their end. Yeah. Yeah, it does.
Good evening. Thank you so much, Dr. Greaves, for
You're
your
welcome.
presentation. My name is Sherry Tola. I'm an OBGYN from Antigua. Generally, with end-of-life care, there is, well, and I experienced this both when I was training in Jamaica. I see it in Antigua. There's a strong discomfort with dealing with end-of-life care. Persons don't understand their roles and what the objectives are at that stage of care. Once a patient comes to an institution, we are trained, do blood tests, chase, and you're treating all these things, but you're not achieving anything, right? Sometimes you're not even sure what's really happening in those final stages. My question would be, and I'm glad you actually shared those educational references. And I suspect, rather, before I ask the question, that even with the hospice model, we're going to have problems, because the hospice, we generally have a problem with our human resource, with those kinds of resources. So you're going to end up still having problems. Everybody can't go to the hospice. Is there a role for, one, if you were going to recommend a basic team for palliative care in a small island or a large island, what should that look like? Second thing, is there a role for a community model for palliative care, where the families and the patients are empowered to be a part of that process? So they don't even necessarily have to take the person to the hospital in those final stages, because they have accepted and they understand where they are, right? Especially if the patient doesn't want to be institutionalized in their final stages.
Yeah, so just where you are is where I would, I didn't realize these slides are not. So the WHO model, the primary healthcare model, it speaks about providing care in the community in an accessible and affordable way. So community-based care, where families are trained to be caregivers, is essential. And then at the core of the team, you don't actually need a physician. You might need a palliative care nurse who can act as a coordinator to pull in the necessary services. So if you had, if there was but one category of person that you would need, I would say the combination of a trained palliative care nurse who can function in the community, plus trained family members. And then layer on top of that your family physician, general practitioners, and all of the skill set that the gynae oncologist will have, because they've now normalized their ability to recognize and to assess and to treat low and moderate complexity. Yeah, does that help?
Yes, it does.
Yeah.
And I'd like to say that this was something, I should say, oncology nursing, and I'm sure palliative care would have been a part of that, was something that, we were looking at even in Antigua, UE being the fifth landed campus for the
Yeah.
UWI, perhaps that's something that we should be exploring
Yes.
across all the UE campuses.
Yeah, so if you could, that's good. Trinidad has an MSc in oncology,
Yeah,
but
yeah,
maybe
they-
there
yeah,
is a
it
need
would-
to
yeah.
for Five Islands to adopt it along with their distance MPH program.
Yeah, we had met
Yeah.
with them, so we hope
Fine.
that's something that will take off. Thank
That
you
would be
so much.
fantastic. Okay, thank you, everybody. Oh, but
Thank you, Natalie.
You're welcome.
My classmate from medical school.
You're welcome.
I felt so proud listening in the audience to her presentation, her passion.
You have a question?
Your passion. No question for you. I just commending you because I enjoyed it so much to hear your passion about palliative care and keeping us on time. You couldn't stop the questions because it was very interesting. You forced me last year to do that course online. I enjoyed it, remember? So I'm going to share the link with the guys out here because a lot of them seem very interested in doing it. Thank you, Ian. Sorry to interject here because I know I don't want people to leave, but we have an event this evening at 7:30 at the Copacabana Beach Club. The shuttle starts leaving here at 7 p.m. So you can meet in the lobby. Those who don't know about it are invited. So everybody here is invited. Dr. Bennett said she's going to put on her dancing shoes and come, but I had to tell her it's on the beach with a deck, so no dancing shoes. She can take off her shoes and do what she has to do. So thank you, everybody, today. Thank you, Ian. Get an hour break. Meet me back in the lobby, and the show lasts till 10:30. So even if you have another engagement that you got to go and do your nails or your hair and you got an hour and you still want to come for 2 hours, you can still come. Yours done. You're always on point. Thank you, everybody.